بسم الله الرحمن الرحيم. أحييكم بتحية الإسلام وتحية الإسلام السلام، فالسلام عليكم ورحمة الله وبركاته. أصحاب السعادة، الضيوف الكرام، الزملاء والأصدقاء الأعزاء، صلوا على خير من وطى الثرى وسلموا حتى تنالوا المبتغى. اللهم صل وسلم على نبينا محمد. إنه لمن دواعي سروري أن أرحب بكم جميعاً في الملتقى العلمي لمراكز ووحدات السكري وجراحة السمنة، والذي يعتبر ضمن جهود وزارة الصحة ممثلة بالوكالة العلاجية والإدارة العامة لخدمات المستشفيات والإدارة العامة للمراكز المتخصصة، والتي تتضمن أهدافها الارتقاء بالخدمات الصحية ورفع مستوى العاملين في القطاع الصحي. عليه يأتي هذا الملتقى لكي يعكس ويبرز جهود الإدارة في هذا المجال، وذلك حرصاً منها على رفع مستوى الكادر الصحي في هذا القطاع الهام والحيوي. أخيراً وليس آخراً، أرحب بكم جميعاً وأتمنى لكم النجاح والتوفيق في أعمال هذا الملتقى، الذي نرجو من الله أن تصبو قراراته وتوصياته إلى حجم المسؤولية الكبيرة الملقاة على عاتقنا جميعاً من أجل توفير حياة كريمة ملؤها الرخاء والازدهار. فأهلاً ومرحباً بكم. ونبدأ برنامجنا العلمي بكلمة لسعادة قائد تخصص جراحة السمنة الدكتور محمد أبو خاطر، فليتفضل مشكور. محمد أبو خاطر فليتفضل مشكورا.
السلام عليكم، صباح الخير. شكرا للحضور الجميع من الأطباء والمشاركين، ونتمنى إن شاء الله تكون الفائدة للجميع. في مؤتمرنا يتضمن أشياء محاضرات بالسمنة والسكر، وربطنا السكر مع السمنة في كل المحاضرات للفائدة. كما نعلم السمنة لها عامل كبير لمرض السكر خاصة من النوع الثاني، ونشكر الجميع على الحضور. ونبدأ محاضراتنا ببروفيسور الدكتور خالد البيعان، يتكلم عن محاضرة مهمة جدا اللي هي Over the last 100 years what medical science has done in diabetic management. تفضل دكتور.
السلام عليكم. بسم الله والصلاة والسلام على رسول الله. حقيقة in the beginning I would like to really express my great thanks to the people who have organized this meeting. And when I read the title is really very interesting. It is not that far from what I'm going to give you today. But I'm very pleased that finally diabetes is linked with bariatric surgery, because I think it is the one which has to be really taken in consideration and has to be taken seriously. I'm not sure if I could be having the slides. But what I'm going to tell you now today is what do we know over the last 100 years? You know, insulin was discovered in 1921, used in 1922. And then after that, the era of diabetes came. Before that era, people used to die because of diabetes. And after this discovery and the insulin availability, diabetic patients start to live longer. And now we start to see more complications and more behavior of this disease. Now, to take you swiftly over 100 years, I think I have to stop in certain stations. Some of them are historical, some of them are microbiological, some of them are genetics, some of them is pharmaceutical, and so on and so forth. And I know that I have been only given 15 minutes, so I'll try to really compress all this in a very small capsule, trying to give it to you, to take it home and to understand, did we do good for diabetic patients over the last 100 years? Is patients' life better? Did we make them live longer? Are they enjoying their life? Those are the four main questions I'm going to raise for you today. And I hope you will take it with a pinch of salt, and also understanding that, yes, we have done a lot, but I don't think we have reached to our target. Let me start with this love story. Those two couple, Professor August Croft. He's a professor of biochemistry, and he was given a Nobel Prize in the early last century. Then he took his wife, who is also a biochemist, but she was also suffering from diabetes. At that time, Nobel Prize will give them a chance to round the world and at the same time give lectures. He was in the United States and he met Elliot Joslin. He's a very famous diabetologist from United States in Boston. There, he told him, I have heard that somebody in Toronto, Canada, they discover insulin, and they know your wife is now diabetic. Why don't you drop in your way back to Europe and see what they have done and take this medication? Maybe it will help your wife. His wife improved a lot. He went back to Europe, and then this is the story of Novo Nordisk. This is how Novo Nordisk was found, and this is how things so. In fact, the insulin is also a love story. Now, to start with something shaking, you have to know that diabetic patients before the era of insulin is completely different from after that era. You can see from the data in front of you, those who's been diagnosed with diabetes and they are 10 years old, they almost die. More than 95% of them will die at least in that year or next year. And you can see the story is now totally different, and they start to live longer. You can see after the insulin, their life expectancy have really improved a lot. The same story for those who have been diagnosed at an age of 30. And maybe Croft's wife is basically with this group. You can see how much they have improved their life expectancy. It didn't touch much for those who are very old and diabetic patients, even with the insulin, because usually they have the mildest type of diabetes that can be even managed with diet and maybe physical activity. Now, although I have given you a very primitive data, but if you take it in deep, this is what they have done. In 1980, minus 1 year, which is in 1979, which is not that far from them. At that time, I was maybe in my 4th year medical school. The Joslin issued a certificate for those people who survived for more than 50 years. And they gave them this medallia and this certificate. And they start to call all endocrinologists and diabetologists to register their patients. Imagine in 1980, those who managed to survive 50 years after being diagnosed is only 338. A very small group. Now, if you look at it, in England alone, there was only 38 patients, which means that usually they die within, or most of them are dying within their 50 years of diagnosis. Now, do we see them now living longer? The answer is yes. And for that reason, I would like to go now into the second point, which is, did we reduce the disease spread? If they are now living longer, and if we are seeing more diabetic patients, did we stop that increment? The answer, unfortunately, up to this moment, globally, diabetes is still growing. There is more incidence, and as you can see, it has almost doubled. We are here in this line, whether you are talking about the incidence or incidence rate or prevalence of the disease. And as you can see, we have already doubled, unfortunately. And this doubling is basically related basically to the increase in human population. At the same time, obesity, which is part of your meeting today. At the same time, did we manage to really prevent primary or get a good primary prevention for the disease? The answer, unfortunately, is clearly from this data is a big no, unfortunately. Now, the other story of diabetes, it is growing, definitely. Now, do we know diabetes? Is this definition which was made by the American Diabetic Association for Diabetes is a proper definition? Why did we call it diabetes? Why we call high uric acid hyperuricemia? And why we call high lipid hyperlipidemia? Why don't we call diabetes hyperglycemia? The name was given almost more than 2,500 years, and we are still dragging that name. Is it the right name? Do we know the disease better these days than what was there before? The answer is going to be answered, in fact, in the next future. But I want you also to understand this very interesting point. From 1921, when insulin was discovered, until 1980, the classification was juvenile and adulthood diabetes. In 10 years' time, this is when I was graduating, in fact. In this 10 years, we start to use another nomenclature, insulin-dependent versus non-insulin-dependent. Finally, the American Diabetic Association and the WHO sat together and they came up with the American Diabetic Association classification, which is type 1, type 2, LADA, gestational diabetes, impaired glucose tolerance. Now, if you ask me after 40 years, is this the right classification? I can tell you honestly, working and doing a lot of research in this field, it is not the proper naming. For that reason, just recently, 2 years back, the people have really gathered a lot of data trying to reclassify and look into diabetes from another angle. And this is something new now. You have to know that unfortunately, although we named it many names, and although we don't have a proper definition for it, or even better understanding, but at least using the markers and the clinical presentation of those patients, we could even identify grouping of these diseases. Now, if you see here, we are talking about the old classification, which is type 1, LADA, and type 2 diabetes. These small rings is the secondary diabetes, gestation, genetic diabetes, and so on. They are always outside the picture. They are diagnosed with hyperglycemia, but they are different pathology here. So what these people did, they collected more than almost 200,000 patients, and they have very clearly looked into the classification, and they came up with the 5 classifications, which I'm going to tell you now. The first group is the severe autoimmune disease, the classical type 1 diabetes. A child who will develop autoimmune stimulation, and his immune system will destroy his beta cell, and he presented with severe insulinopenia and severe hyperglycemia. The second group is severe insulin deficiency disease. This is an entity group. There is no autoimmunity here. There is no genetics for it. But for one reason or another, beta cell gave up and the patient developed diabetes. The third group is the severe insulin resistance, either syndromically, genetically, or because of obesity, which is really very popular these days. So this is the third group. The fourth group is the mild related diabetes. We do have patients who are really very mild, and you can only manage them with diet and exercise. And usually they are old group, and so on and so forth. Now, if you look about our reactions, we always have overreactions to those patients, and those are the people who goes in hypoglycemias. The last group is the mild age-related diabetes. This is when you grow old, you lose beta cell. When you come to a certain level of number of beta cells, then your insulin will not be enough, and then you will develop diabetes at an older age. Now, if you see this classification, it is really very good classification. And it is even better than what we are having in our hand. Yet you have to know that we are still calling it diabetes mellitus. We have to give it another name, but I don't know what. Now, if you try to plot them according to the insulin demand versus insulin level, you can see that the people who are having insulin resistance have the highest insulin level, and also at the same time, they have the bad requirements. And as you go down, you have the type 1 diabetes patients. The type 2 diabetes group is here. I would like to tell you that this is your group when you are really trying to fight obesity and try to minimize. Now, if you take this in consideration, and if I show you the percentage, this is speaking about what sort of medications you are really trying to use. And believe me, this guidelines is going to be much better than what our primary care physicians are doing in their clinics. Look at this. The first group is only 6%. The second group is 18%. And then 15% for the third group, 22%, and the biggest is the mild age-related diabetes. Now, if Saudi Arabia is aging, and the mean age for Saudis have moved from 53 to 74, I can tell you we are going to see more diabetic patients in the community. And we are going to see more of those type. And they are very mild and very easy to manage. So don't really bombard those people with a lot of medications, and then eventually you will find yourself putting those patients in a very, very bad situation. Now, if you look into these groups and you try to look into hemoglobin A1C level, BMI, age, and insulin resistance or insulin secretions, these are, you can really very nicely segregate them. So I am really thinking that in the near future, we are going to develop a model by which you can use these markers to classify your patients, and then it will tell you what type of medications. We usually run into insulin if the blood glucose is very high. We usually give metformin if the patient is obese. Is it true? The answer, we don't know. And even studies have shown, which I'm going to show you, that unfortunately we are not doing a good job. And maybe we are not doing a good job because we mixed everything together and we did not segregate the groups into the proper pathology they are behaving. This is the classical markers you are going to see, the hemoglobin A1C, using fatty acids, glycated albumin, OGTT, and so on. I want just to draw your attention that the best for diabetes or pre-diabetes is basically, regarding sensitivity and specificity, is basically hemoglobin A1C, followed by the oral glucose tolerance test, which has very high sensitivity and a very, very good specificity. So this is where your money is. Unfortunately, until this moment, we are still relying on the response of the body to the glucose challenge. Now, if you see how many in the literature speaking about markers that you can use to diagnose, to follow, and even to predict complication, these are the big lists you can see. In fact, there are even other markers. I didn't include them in this presentation because I have shortened my presentation, which are really the inflammatory markers. So diabetes is an inflammatory process. Obesity is an inflammatory process. And now we are in a better shape, understanding the response of the body and also the hormones to this blood glucose level. The classical and the best teaching, if you go to any medical school or even in the conference, the DCC study and the extended DCC study. Now, did we learn anything from this? The answer is yes. We have learned something which is very interesting. Regardless of what you do, even if you control diabetes, you still see complications, which means that, yes, you can reduce the rate of the complication, but you cannot eliminate the complication. What does this mean? This means that it is not only the glucose level which matters. In fact, there are other things which, unfortunately, we are now exposing slowly to understand the disease better and better and to try to minimize the complication and do a good primary and also secondary prevention programs. From there, I will take you to the most famous big 3 studies. I'm sure all of you knows the ACCORD study, the ADVANCE study, and the VA-DT studies. Now, I want you to concentrate on this in a very brief look. Look at the outcome. What is the most significant improvement? The ACCORD study have shown that the death rate is improving, but it's not eliminating. Microvascular disease or cardiovascular disease mortality also decreasing. Non-fatal myocardial infarction improving. and also the severe, and the other complications are not really that significant. But if you try to replicate this in the advanced study, you can see that unfortunately none of them is significant, which means that in this study, which has even more patients, or almost equal number, they have 11,000 patients, yet they did not show that the strict control really have mattered. The same things with the other study, which shows basically the same. Now, I want you to also concentrate on the last line, which is the hypoglycemia. Look how significant hypoglycemia is. In all the three studies, although we have minimal improvement and reduction in the complication, but yet we have put the patients in a very severe hypoglycemia. And I can tell you, over my 40 years experience, I have seen some of my patients have died because of hypoglycemia. They develop hypoglycemia and then they go into myocardial infarction. They develop the hypoglycemia and they go into a car accident and so on and so forth. So it seems that the balance, even in the degree of control, we did not reach to that phase by which we can really balance this issue. Now, let me summarize. What we know now, the glycemic control does not reduce the total number of cardiovascular events or mortality. It does not reduce the risk for stroke. It does not reduce the risk for arthritis and amputation. It does not reduce and may even increase the risk of heart failure. And the heart failure issue is now becoming more popular if you read the literature. Now, what is the possibility? I think the intensive glycemic control reduced the risk of non-fatal myocardial infarction by almost 15%. At the same time, the Accord study have shown that cardiovascular mortality is not really as serious as what we thought. So if I summarize this to you and keep in your mind that we are now having a new understanding of the different types of diabetes, and we are more worried about hypoglycemia and heart failure among diabetic patients, this will take me to the second point, which is also a focus of your meeting today, inshallah. The metabolic syndrome. Metabolic syndrome in Saudi Arabia is one of the highest, and you can really quote our study where we have looked into a large number of patients, and I can tell you that it is a big problem. Now, look at this. I can understand that type 1 diabetes causes retinopathy and type 2 diabetes causes retinopathy, but nobody can convince me how metabolic syndrome, when the blood sugar is completely normal, with OGTT that really reflects normal level, they are still having retinopathy. I have collected more than 1,000 metabolic syndrome patients with normal glucose, but all the other metabolic syndrome markers are high, and unfortunately they develop retinopathy. What does this mean? This means that it's not only the hyperglycemia which makes the complications. Now let me conclude by telling you something which is very important. The mortality over the last 10 years, and this data is from Elliot Joslin. Now what he did, he collected his patients and he looked into the mortality rate. This is before insulin and this is after insulin. Yes, we got the people reduced. This is the group he has managed with diet and exercise. This is the group when he started to use insulin. You can see how much drop, almost by more than 10%, more than 90%. But with time, we are even having better lifespan for our diabetic patients. But the question after this is, did insulin make the difference? The answer is yes. This is the total population from the World Bank data. Most of the humans are living in Asia, as you can see. We have 3 billion humans on Earth. I can tell you that the number of diabetic patients is approaching now 400 million diabetic patients. And this is the type 1 diabetic patients. Look at how many we have saved. We have saved a lot of lives for type 1 diabetes, and this is true, in fact. And this is something I think we should account for the insulin discovery. Insulin discovery made the difference. The oral and the other medications have made the people live longer, and this is also proved by different studies looking into the lifespan of those people, yes, there is an improvement on our lifestyle. In diabetic patients, for example, from the registry, and it is data which we have published, diabetic patients in the 80s, the mean lifespan is 51. When we conclude in 2013, the mean lifespan for diabetic patients was almost 6 years behind the normal Saudis, which is about 68, while the Saudis are 74. Now, my last 2 slides is this slide.
1 minute, Prof, please.
Yes, I'm just concluding now.
Thank you.
This is just to show you the lifespan when you look for the whole globe and look at the difference. This is where politics are really playing. Now, this is the female, and this is the male, and this is the midline. You can see females live longer. People from Africa have lower lifespan, followed by people from Asia. You can see the bubble is even bigger because we have more diabetic patients in Asia. The best lifespan was from America and Europe, as you can see. Now, did we have better quality of life? This is a study which was done here in Saudi Arabia, and this very clearly tells you that unfortunately only 50% of our people have good quality life and they are happy with it, while the other half, unfortunately, is either having very slight problem to moderate to severe to even some of them are really reaching a phase that their lifespan is in. I think I would like to conclude with this slide, which is in fact is true. Although we are running for a cure, but unfortunately diabetes is still behind huge life loss. Thank you very much. Yeah, okay.
نشكر الدكتور بروف خالد بيعان على المحاضرة القيمة والمعلومات المهمة عن السكر في خلال آخر 100 عام. جزاك الله خير وشكرا لكم. الآن نأخذ 5 دقائق استراحة ونرجع ثاني القاعة. شكرا لكم.
السلام الملكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين، نبينا وحبيبنا وقدوتنا محمد عليه وعلى آله أفضل صلاة وأتم تسليم. ثم أما بعد، أصحاب المعالي والسعادة، السادة الحضور، مشاهدين الأعزاء، السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم وجميع أوقاتكم بكل خير وبركة وسرور. ومرحبا بكم في الملتقى العلمي لمراكز ووحدات السكري والغدد الصماء وجراحة السمنة. هذا الملتقى الذي ينطلق لمدة يومين متتالية برعاية سعادة وكيل الوزارة للخدمات العلاجية الدكتور طريف بن يوسف الأعمى، وخير ما نبدأ به آيات من الذكر الحكيم.
أعوذ بالله من الشيطان الرجيم.
وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون وستردون إلى عالم الغيب والشهادة فينبئكم بما كنتم تعملون.
صدق الله العظيم. نترككم الآن مع كلمة ترحيبية مع الدكتور عبد الله السهيمي، المدير العام للإدارة العامة لشؤون المراكز المتخصصة بوزارة الصحة، فليتفضل مشكورا.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سعادة وكيل الوزارة للخدمات العلاجية دكتور فيصل، سعادة الوكيل المساعد للإمداد المهندس مرعي، أيها الحضور الكرام، زملائي وزميلاتي، كل عام وأنتم بخير. في هذا اليوم وفي هذا الصباح الجميل نقول لكم تقبل الله منا ومنكم صالح الأعمال. كثير من الزملاء يعني كان عندهم تحفظ على موضوع أن بعد العيد مباشر تكون الملتقى، ولكن التسجيل كان في الملتقى حوالي 1000 في الموقع، لدرجة أنه وقفنا التسجيل، وهذا دل على شيء، دل على شغف البحث عن المعرفة. احنا في المراكز المتخصصة يعني بدأنا ننظر إلى آفاق تواكب رؤية المملكة 2030 وبرنامج التحول في القطاع الصحي بتوجيهات من الدكتور طريف الوكيل العلاجي، ومتابعة ويعني متابعة دقيقة وحثيثة من سعادة الدكتور فيصل يعني بشكل أسبوعي على موضوع المرحلة القادمة، أين سوف نكون في موضوع التشريع. في المراكز المتخصصة عندنا مجموعة كثيرة من البرامج. احنا نسعى دائما الآن إلى أن ما ننتظر إلى أن نصل إلى المستوى الثالث في الخدمة، ننتظر المريض حتى يصل عندنا. بدأنا نبحث عن شراكات سواء داخل نطاق الوزارة أو أيضا حتى مع الجمعيات، مع الجامعات، مع القطاع الثالث، وذلك لتأكيد فكرة البيشنت جيرني، المريض من أين يبدأ حتى يصل عندنا، والفجوات اللي موجودة في الخدمة نحاول من الآن ننظر لها. طبعا وجدنا فعلا نفس الهاجس عند كثير من الشركاء، وهذا دل على شيء، دل على أن فكرة التحول للقطاع الصحي هي الفكرة اللي تشغل بال جميع مقدمي ومزودي الخدمة، الموائمة ما بين التشريع وتنفيذ الخدمات هو هاجس الجميع. طبعا برنامجنا اليوم يستمر إن شاء الله لمدة يومين، هو برنامج يخص السكري والسمنة. طبعا عندنا برنامج السكر مستقل، برنامج السمنة مستقل كالمراكز المتخصصة متابعة، ولكن لوجود علاقة قوية بين السكري والسمنة، وكذلك وجود علاقة قوية بين السمنة وغيرها من التخصصات، وجود علاقة قوية بين السكري وغيره من التخصصات، لم نعد ننظر للمرض كمرض نفسه، إنما ننظر إلى العلاقة بين المرض، وهذا يستوجب العلاقة أيضا بين مقدمي الخدمة. فمن هذا المنطلق وضعنا ملتقى السكري والسمنة. طبعا لله الحمد في تطور في مراكز المتخصصة على مستوى المملكة في موضوع التوسع في تواجد هذه المراكز، لذلك لتحقيق هدف استراتيجي للوزارة الأكسس تو كير. عندنا تقريبا جميع مناطق المملكة يوجد فيها مراكز للسكري، عندنا تقريبا جميع مناطق المملكة ما عدا منطقتين إن شاء الله في خطتنا لهذا العام أنه يكون فيها مراكز للسمنة. فأصبح من السهولة الآن وصول الخدمة، وجب علينا الآن العمل على رفع مستوى تقديم الخدمات. نرحب بكم مرة أخرى، وإن شاء الله أن يكون اليومين هذه يومي عطاء، نطلع بتوصيات. نحن يعني دائما نقول موجودين لتنفيذ التوصيات اللي ترون أنها هي راح تحقق لنا هذه الأهداف. حياكم الله، ونراكم إن شاء الله مع نهاية اليوم الثاني بتوصيات تخدم الجميع، وشكرا لتواجدكم اليوم. شكرا.
الشكر موصول لك دكتور عبد الله السهيمي، المدير العام للإدارة العامة لشؤون المراكز المتخصصة بوزارة الصحة، على هذه الكلمة. وكما ذكر بأن هذا الملتقى يسلط الضوء على عوامل الإصابة بداء السكري وآثاره على الصحة العامة وطرق الوقاية منها، وكذلك تسليط الضوء على آخر المستجدات العلمية في مجال السكري وجراحة السمنة بحضور نخبة من كبار المتخصصين في مجال السكري وجراحة السمنة. ويضم الملتقى عدد من ورش العمل المصاحبة في مجال السكري وجراحة السمنة، وأيضا المعرض المصاحب. ونترككم الآن مع كلمة الدكتور تامر رجب، مدير إدارة اللقاحات لشركة GSK الراعي البلاتيني لهذا الملتقى.
السلام عليكم ورحمة الله وبركاته. السيدات والسادة الحضور، انطلاقاً من الشراكة طويلة الأمد بين مقام وزارة الصحة في المملكة العربية السعودية وشركة GSK، فإن الشركة شرفت أن تكون الراعي البلاتيني للمؤتمر. GSK هي شركة أدوية بيولوجية عالمية تستهدف دمج العلم والتكنولوجيا والموهبة للمساعدة في التغلب على المرض. ولأكثر من 65 عاماً ظلت الشركة مساهماً مهماً في دعم جهود الصحة العامة في المملكة العربية السعودية. وتعمل الشركة في السعودية من خلال مصنعنا في جدة الذي تم إطلاقه في عام 1992، وبذلك تكون أول شركة عالمية تصنع محلياً وتتوسع عاماً بعد عام في التصنيع تماشياً مع رؤية المملكة 2030. تحسين جودة الحياة. تحسين جودة الحياة والحد من المضاعفات لمرضى السكري من أهم مستهدفات رؤية مراكز السكري في وزارة الصحة. واستكمالاً للمسيرة الناجحة، فإننا نشهد اليوم بداية تحصين مرضى السكري ضد الحزام الناري داخل مراكز السكري. وأود أن أشكر دكتور عبد الله السهيمي، دكتور عبد الله عرب، على كل مجهوداتهم لتحقيق هذه الخطوة المهمة مع جميع اللجان للموافقة على إدخال اللقاح. وتعد المملكة أول دولة في المنطقة توفر لقاح الحزام الناري، واللقاح هو أحد ابتكارات وتصنيع شركة GSK، ويتم أخذه على جرعتين. وسريعاً، فإن الحزام الناري هو طفح جلدي مؤلم ينتج عن إعادة تنشيط فيروس هيربس زوستر، وهو نفس الفيروس الذي يسبب العنجز الذي أصيب به 99% من البالغين فوق 50 عاماً. وتشير الإحصاءات أن 1 من كل 3 أفراد معرض لخطر الإصابة بالحزام الناري في حياته. في وقت لاحق من اليوم سوف يقوم زميلي دكتور مصطفى علام بالتحدث باستفاضة عن المرض والتحصين. في النهاية أود أن أشكر القائمين على المؤتمر لإخراجه بهذا الشكل الرائع. شكراً لكم.
شكرا للدكتور تامر رجب مدير إدارة اللقاحات الراعي بلاتيني لهذا الملتقى على هذه الكلمة. ونترككم الآن مع كلمة راعي الحفل الدكتور طريف بن يوسف الأعمى وكيل الوزارة للخدمات العلاجية، يلقيها بالنيابة الدكتور فيصل بن سالم الدهمشي الوكيل المساعد لخدمات المستشفيات بوزارة الصحة، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. الزملاء الكرام، أصحاب السعادة، الحضور الكريم، المحاضرين، لجان التنظيم، أبطال المراكز المتخصصة في كل المناطق والمحافظات. في البداية أرحب بكم جميعا، ويسعدني أن أكون متواجد معكم اليوم في هذا الملتقى الرائع، وأسأل الله العلي العظيم أن يجعل كل ما تقولون وتعملون في هذا الملتقى في ميزان حسناتكم. اسمحوا لي في هذه الدقائق أن أرسل 3 رسائل، وأتمنى أن تكون بإذن الله رسائل تصل من القلب للقلب. فرسالتي الأولى رسالة شكر وتقدير من راعي هذا الحفل سعادة الوكيل للخدمات العلاجية الدكتور طريف بن يوسف الأعمى، والذي يبلغكم شكره وتحياته وإعجابه بما تقومون، فشكرا لكم جزيلا باسم راعي هذا الحفل. رسالتي الثانية لزملائي أبطال الإدارة العامة للمراكز المتخصصة. هذا ثالث ملتقى خلال 3 أشهر، بدأنا في ملتقى الكلى، ثم ملتقى التوحد، والآن في ملتقى السكر والسمنة. شكرا لكم من الأعماق ما تقومون به من أعمال جليلة، أنا متأكد أن سيكون لها أثر بالغ في تجويد وتحسين الخدمات المقدمة. شكرا لكم لاقتناص هذا العنوان وهذا المحورين اللي يعتبرون وجهين لعملة واحدة، السمنة والسكر. شكرا لكم من الأعماق، وأتمنى من الله العلي العظيم أن يوفق جهودكم وأن يكللها بالنجاح، وأن يكون هذا الملتقى داعما لكل ما يفيد المستفيدين من هذه الخدمات. رسالتي الثالثة لزملائي وزميلاتي الحضور. نحن كما تعلمون نمر في مرحلة تحولية من تغير نظام تشغيل وتقديم الخدمات، فبوجود الذراع التشغيلي لوزارة الصحة شركة الصحة القابضة، وتفرغ الوزارة للأدوار التنظيمية وإعداد السياسات العامة في تقديم الخدمات، أتمنى أن يكون هذا الملتقى مواكب لهذا التغير. نقصد بذلك أتمنى أن تكون توصياتنا اليوم في هذا الملتقى، لأنها فرصة ذهبية، تخصصين يلتقون في مكان واحد، خبرات يعني أكثر من 30 محاضر موجود معنا في هذه اليومين. أتمنى أن نخرج بتوصيات مفيدة جدا للمستفيدين من الخدمات. فمقدم الخدمة يحتاج منكم توصيات اليوم، يحتاج يعرف ما هي الطرق المثلى لتقديم هذه الخدمات، التواكب مع نموذج الرعاية الصحية الجديد. فأتمنى أن تكون التوصيات ذات العلاقة بتقديم الخدمة أن تصدر منكم اليوم، ودورنا أن نفلترها ونجعلها في قالب قابل للتنفيذ. فأنتم من يحرك بوصلة خدمات السكر والسمنة، فأتمنى أن تكون التوصيات التشغيلية تتواكب مع معطيات المرحلة القادمة. يحتاج يعرف منا مقدم الخدمة ما هو الطريق الأمثل لتقديم هذه الخدمات، كيف أقدمها، ما هو المسار السليم، أراقب وأراجع وأنقد النموذج الحالي إذا رأينا أنه في مجال التغيير. فأنتم أفضل من يعطينا هذه المادة العلمية اللي بناء عليها نحوكم العمل في تقديم الخدمات. أيضا منظم الخدمة يحتاج منكم توصيات اليوم، مديريات الشؤون الصحية بثوبها الجديد، مقام الوزارة يحتاجون منكم توصيات تدعم وتعزز هذه الأدوار. كيف أراقب؟ كيف أتابع؟ كيف أسن اللوائح؟ هل لديكم ملاحظات على اللوائح الحالية؟ هل لديكم مقترحات للوائح القادمة؟ فنحتاج منكم هذه الجواهر اللي تنير لنا الخطة القادمة، لأنه في مرحلة تحولية وفي مراحل نهائية من هذه المرحلة التحولية. فوجود مثل هذه الملتقيات في هذا الوقت نعتقد أنه بيكون لها أثر كبير بإذن الله في التميز في تقديم الخدمات. في جميعنا يبحث عن التميز، منظم الخدمة يبحث عن التميز في القطاع الخاص، في القطاع الحكومي، في قطاع التجمعات الصحية التابع لشركة الصحة القابضة، ومقدم الخدمة أيضا يبحث عن هذا التميز. حتى القطاع الخاص يبحث أن يتميز في هذه الخدمة، يبحث أن يعرف كيف ما هي مرئياتك يا منظم الخدمة عن الخدمة المميزة اللي تريدها. فوجودكم في قاعة واحدة نعتقد أنها فرصة ذهبية لنا جميعا، نحتاج أن نركز وأن تكون توصياتنا قابلة للتنفيذ ومبنية على مزيج من الأبحاث العلمية والإيفيدنس بيزد وبين البراكتيكاليتي اللي أنتم فيها. أنتم تعالجون المرضى، أغلبكم لسنوات طويلة وهو يعالج المرضى في نفس المواقع أو في مواقع مختلفة، فهي فرصة ذهبية اليوم أنه كلنا نكون مركزين. نحن في مرحلة نحتاج أن نخطط سويا، المنظم ومقدم الخدمة سواء في القطاع الخاص أو قطاع التجمعات. زملائي في اللجنة المنظمة، أتمنى لكم يعني أن توفقوا في بلورة هذه التوصيات وهذه الملتقيات وصياغتها بصياغة مفيدة لجميع مقدمي الخدمات. فأتمنى لكم التوفيق، وأتمنى من الله العلي العظيم أن يسجد جهودكم وأن يجعل هذا الملتقى من الملتقيات اللي نعتبرها نقطة انطلاقة، نقطة تقارب حقيقية وفعلية. مراكز السمنة وتوزعها في كل المناطق، ومراكز السكر وتوزعها في كل المناطق. كل فئة لديها احتياجات، لديها تخطيط، ولكن هو المريض واحد. فالمفترض مريض السكر إذا مر في السايكل كاملة لازم يمر على عيادات مراكز السمنة وطب السمنة. مريض السمنة يجب أن نتأكد أنه مر على نفس بوتقة أو مسارات عمل مرضى السكر. فأتمنى أن اليوم يكون عندنا هذا السنس من أنه ترى مريض واحد لربما يمر على مراكز السكر ثم ينتقل للسمنة والعكس صحيح. فلا نتمنى أن نخرج من الملتقى اليوم وأن السكر عطوا خططهم والسمنة عطوا خططهم ولا يكون في تجانس. فشكرا لزملائي في اللجان المنظمة على اقتناص عنوان هذا الملتقى وعلى توقيت هذا الملتقى، وأسأل الله العلي العظيم أن يوفقكم جميعا وأن يجعله ملتقى مبارك. يعطيكم العافية جميعا.
شكرا للدكتور فيصل بن سالم الدهمشي الوكيل المساعد لخدمات المستشفيات بوزارة الصحة على هذه الكلمة التي ألقاها نيابة عن راعي الحفل الدكتور ظريف بن يوسف الأعمى وكيل الوزارة للخدمات العلاجية. نجدد الترحيب بكم حضورا الكريم في الملتقى العلمي لمراكز ووحدات السكري والغدد الصماء وجراحة السمنة. والرسول اللهم صل وسلم عليه يقول: من لا يشكر الناس لا يشكر الله. من هذا المنطلق ومن باب الشكر والتقدير والتكريم يتفضل الدكتور رائد المطيري نائب المدير العام للإدارة العامة لشؤون المراكز المتخصصة بوزارة الصحة لتقديم فقرة التكريم، فليتفضل مشكورا.
سعادة راعي الحفل، سادة الحضور، سادة المحاضرين، السلام عليكم ورحمة الله وبركاته. من باب قول الرسول صلى الله عليه وسلم: من لا يشكر الناس لا يشكر الله، باسم الإدارة العامة لشؤون المراكز المتخصصة نتقدم بالشكر الجزيل لجميع مراكز السكري ولجميع مراكز جراحات السمنة لما يقدمونه من خدمات عظيمة ومتميزة جدا في تحسين الرحلة العلاجية لهم، سواء ذلك كان بالطرق الجراحية أو الغير جراحية. لغة الإنجازات هي أبلغ من جميع الكلام، لذا لن أطيل عليكم كثيرا. أتمنى من الدكتور فيصل بن سالم الدهمشي الوكيل المساعد لخدمات المستشفيات وراعي الحفل بالصعود للمنصة لتكريم متميزين، كما أطلب مساعدة المدير العام لشؤون المراكز المتخصصة الدكتور عبد الله بن محمد السهيمي بالصعود للمنصة لتكريم متميزين، وسعادة الوكيل المساعد إمداد التموين الأستاذ مرعي القحطاني بالتفضل للصعود للمنصة، سعادة الدكتور محمد أبو خاطر قائد تخصص جراحات السمنة، سعادة الدكتورة لميا الزبيدي قائد تخصص السكري، نبدأ بالمراكز المتميزة في مراكز السكري. مركز السكري بمدينة الملك فهد الطبية بالرياض. مركز السكري بمستشفى الملك عبد العزيز التخصصي بالطائف. مركز السكري مستشفى الملك فهد بالباحة. قائد مسار السكري بالتجمع الصحي بالقصيم. تكريم مراكز جراحات السمنة مدينة الملك فهد الطبية بالرياض. مركز جراحة السمنة مستشفى الملك عبد العزيز التخصصي بالطائف. ومركز جراحة السمنة مستشفى الملك سلمان بمنطقة حائل. مركز جراحة السمنة مستشفى الملك عبد الله بمحافظة بيشة.
تفضل. السلام عليكم ورحمة الله وبركاته. أنا ما جهزت حاجة، لكن 30 ثانية. الحمد لله والصلاة والسلام على رسول الله. قبل سنتين افتتحنا مركز السمنة في بيشة ولله الحمد والمنة. استدعانا الدكتور فيصل الدهمشي، سعادة الدكتور فيصل الدهمشي، في ورشة عمل، وكان موجود سعادة المهندس مرعي القحطاني، وبلغنا الدكتور فيصل إن ما شاء الله تم اعتماد المركز، وأبشر كدكتور فيصل إن سوينا 150 حالة خلال 3 أشهر. هذاك الوقت انبسط الدكتور فيصل الله يطول عمره ومن يسمع، وقال لكن ما نبغاها نهاية المشوار، ما بعدها ما هو. فقلت إن شاء الله تبشر بها بإذن الله. الآن مر على الكلام هذا تقريبا 2 سنين، لله الحمد والمنة أكملنا 1500 حالة، حالات متنوعة، حالات متنوعة، حالات متعددة، لله الحمد والمنة. فأنا حاب فعلا أرسل باقة شكر بحجم السماء لسعادة الدكتور فيصل الدهمشي، سعادة المهندس مرعي القحطاني على الإمداد الغير منقطع. سعادة الدكتور فيصل الدهمشي بصراحة قد يقول البعض الدكتور فايز بيبالغ في شكره، وأنا أذكر ذلك دائما عندنا في بيشة وفي الباحة، لكن لولا فضل الله ثم سعادة الدكتور فيصل الدهمشي وفريق عمله، تذليل الصعوبات، إتاحة جميع الإمكانيات، وفي الأخير إتاحة الفرصة أننا نخدم. فهو وضعنا في الركن المحرج لنا إنه ما بقى عليكم إلا تعملون، اعمل وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. فأنا حاب أني أبلغ الدكتور سعادة الدكتور فيصل الدهمشي وفريق عمله ألف 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 شكر. دكتور فيصل ما قصرتوا. هذا وكل عام وأنتم بخير، ونراكم إن شاء الله، ونرى إنجازات زملائنا اللي نحن نتعلم منهم ونستفيد منهم، وأشكرهم جميعهم على الدعم وعلى الاستشارات المتواصلة. فريق عملك دكتور فيصل لا يعلى عليه، ما شاء الله تبارك الله. أسرع اتصالات، تذليل صعوبات، يا ليت والله يا ليت، ما شاء الله تبارك الله. تدري الرسول صلى الله عليه وسلم يقول: من قال جزاك الله خيرا فقد أجزل في الثناء. فأنا أقول التكريم لن يفيهم حقهم، لكن جزاكم الله خير. سلامتكم. الله يعطيكم العافية.
دكتور محمد موسى أبو خاطر، قائد تخصص جراحة السمنة، تكريم. تكريم الدكتورة لميا محمد الزبيدي، قائد تخصص السكري. تكريم الأستاذ عبد الله عربي، مدير برنامج السكري. تكريم الشركات الداعمة، شركة GSK. شركة نوفو نوردسك. شركة الجراحات المتقدمة. شركة بروميدكس. شركة أبوت. شركة فايتالير. تسليم درع تذكاري للدكتور فيصل بن سالم الدهمشي، راعي الحفل. ختاما نتقدم بالشكر الجزيل لجميع المراكز السكري والسمنة على ما يقدمونه من خدمة جليلة وعظيمة لجميع المرضى في وزارة الصحة.
شكرا للدكتور رائد المطيري، نائب المدير العام للإدارة العامة لشؤون المراكز.
تقنية مبتكرة وسريعة وسهلة الاستخدام لصناعة أطراف صناعية باستخدام الطباعة ذاتية الأبعاد. تأتي هذه الشراكة اليوم بين جامعة الأمير سلطان ووزارة الصحة استكمالا لهذا النهج التعاون البحثي بين القطاعات الصحية والأكاديمية لخدمة المجتمع. كرر شكري وتقديري لكل القائمين، وأرجو من الله أن تترجم هذه الشراكة والحفاوة التي لامسناها من الجميع إلى تعاون مثمر إن شاء الله. السلام عليكم ورحمة الله وبركاته.
شكرا للدكتور عبد الحكيم الماجد عميد كلية الهندسة على هذه الكلمة. والآن توقيع اتفاقية بين وزارة الصحة وجامعة الأمير سلطان الطبية، فيتفضل الدكتور فيصل بن سالم الدهمشي، وأيضا الدكتور عبد الحكيم الماجد عميد كلية الهندسة ورئيس برامج الدراسات العليا بجامعة الأمير سلطان الطبية.
نجدد الترحيب والشكر لكم. الآن نبدأ بالجلسة الحوارية واللي يقودها سعادة الوكيل المساعد لخدمات المستشفيات الدكتور فيصل بن سالم الدهمشي، وبتواجد وكيل الوزارة للإمداد والتموين الأستاذ مرعي القحطاني، ونيابة عن وكيل مساعد للرعاية الأولية الدكتور خالد عبد الكريم ينوب عنه الدكتور أمجد الفالح، ومن الصحة القابضة سعادة الدكتور عبد الرحمن القحطاني، فليتفضلوا مشكورين. أول شيء أجدد الشكر لسعادة الدكتور فيصل والمهندس مرعي والدكتور أمجد الفالح والدكتور عبد الرحمن القحطاني. نستغل تواجدهم اليوم بالنخبة من القيادات المتميزة لنا في وزارة الصحة لمناقشة التحديات والحلول التي تواجه مراكز السكري والسمنة، سواء كانت هذه التحديات في مجال الإمداد والتموين أو في مجال مراكز الرعاية الأولية ومشروع الكبير والذي اليوم ممكن يلقي الضوء عليه الدكتور فيصل، مشروع طبيب لكل 1000 أسرة، وأيضا في التحول والوجهة المقبلة لهذه الخدمات في التحول ومع الذراع الأيمن لوزارة الصحة التشغيلي اللي هو الصحة القابضة. نبدأ البداية مع سعادة الدكتور فيصل دهمشي. تفضل دكتور فيصل.
شكرا دكتور رايد، والشكر وأكرر شكري وترحيبي بجميع الزملاء الحضور. أنا يمكن سأعلق بدقيقة دقيقتين ونفتح المجال للزملاء إذا له استفسار. يعني هي فرصة اليوم وجودنا مع بعض أن نكون يعني نوصل المعلومات بين بعضنا بطريقة يعني مفهومة للطرفين. من أهم المشاريع اللي حاليا في كل ملتقى نركز عليه وكل محتفل نركز عليه هو مشروع طبيب لكل أسرة. لك أن تتخيل إذا أنا مدير مركز سكر وعندي مريض يتابع عندي، المفترض هذا المريض وصلني لأنه حالته كريتيكال وعالجته واستقرت حالته ورجع لمركز الرعاية الأولية، انقطع الوحي بيني وبينه فترة، لربما حتى ما راجع في الرعاية الأولية. ماذا لو راح للقطاع الخاص وبدأ يتابع بنفسه؟ ماذا لو ما كان يروح لا قطاع خاص ولا مركز رعاية أولية ولا مستشفى آخر ولا مركز سكر في منطقة أخرى؟ فوجود برنامج يضم هذا يعني مقدمي الخدمات كلهم في نفس البرنامج، أنا أعتقد أنه هذه هي الفتح الكبير اللي بكرة أنت كطبيب مهما كان تخصصك موجود برنامج طبيب لكل أسرة سيضمن لك المتابعة، سيضمن لك أن تكون الأكتيفيتيز والنشاطات اللي موجودة عند مريضك متواجدة عندك إذا طلبتها. الآن لو جميع الموجودين في القاعة يفتحون برنامج صحتي ويشوف اسم طبيبه المختص، في وقت من الأوقات كنا ما نعرف أسماء المراكز الخاصة فينا، فالآن ولو الجميع يجربها الآن يبدأ يبحث في صحتي ويشوف قائمة فريقي، يسمونه فريقي، تفتح فريقك تلقى الطبيب المعالج لك وتلقى الممرض اللي من ضمن الفريق مسؤول عنك. فأصبحت الآن المسؤولية ليست على المركز بل على طبيب متخصص بمتابعة حالتك. المفترض دورنا كمراكز سمنة ومراكز سكري ألا أعمل أي إجراء سواء جراحي أو متابعة أو عيادة خارجية بدون إشعار طبيب لكل أسرة. فأول سؤال أسأله للمريض: هل أنت منضم لطبيب لكل أسرة ولا لا؟ اليوم مسجلين 11 مليون في برنامج طبيب لكل أسرة، الهدف 100%، فلا يزال يعني وصلنا إلى 60%، فنتمنى أن نصل إلى المستهدف بأسرع وقت بدعمكم. فالمفترض جميع أطباء السكري وجميع أطباء السمنة وجراحة السمنة أول نقطة يعني زي الجيت كيبر، لا تجري أي إجراء لأي شخص بدون ما تتأكد هل أنت مسجل في طبيب لكل أسرة أم لا. هذا السؤال الأول. السؤال الثاني: هل أنت مرتبط كطبيب الآن مع طبيبه المختص؟ لأنه أنت إذا سويت إجراء وما بلغت طبيبه اللي هو نسميه طبيب لكل أسرة، أعتقد أنه أنت قطعت الخدمة العلاجية المقدمة لهذا المريض. فترى المانديت علينا جميعا، جميع الأطباء سواء اللي موجودين معنا اليوم أو اللي موجودين خارج هذا الملتقى، وجود طبيب لكل أسرة هو حماية للمريض، استمرارية للخدمة اللي أنت تقدمها. لأنه بالنهاية أول ما نبحث في طبيب لكل أسرة إذا ما كان في أكتيفيتيز، إنه ما قاعد يراجع مركز سكر، ما قاعد يراجع مراكز بدانة، هذا يعطي نتائج خاطئة حتى وإن كنت أنت طبيب ماهر، لأنه أنت ما اعتمدت على بيانات حقيقية لهذا المريض. فدائما أنا أركز وأحاول أؤكد على أهمية طبيب لكل أسرة، إنه ترى هذا ليس برنامج فقط للرعاية الصحية الأولية ولا مراكز الرعاية ولا البابليك هيلث، هذا برنامج لجميع مقدمي الخدمات. من حقوق المريض علينا أن نتأكد أنه إحنا متأكدين ومرتبطين ومشاركين في هذه البيانات مع طبيب لكل أسرة. رسالة الثانية: أتمنى من خروجنا من هذا الملتقى اليوم، ترى من المسؤوليات على المشرف أو مدير المركز سواء سمنة أو سكر أن يعرف الطرق المثلى لطلب الإمدادات. واليوم معنا سعادة الوكيل مساعد للإمداد، وهو الشخص المعني عن مسألة تأمين الإمدادات والطرق. فترى من المانديت اللي علينا جميعا اليوم أن نعرف المعلومة الصحيحة، ولا يكون دورنا فقط رفعت وانتهى دوري، لا، يجب أن تعرف الوسائل، الطرق اللي تخليك تأمن أنه الإمدادات متوفرة، وأن لا يكون هناك إلغاء لأي إجراء سواء جراحي ولا إجراء مراجعة عيادة خارجية، والسبب أنه والله توفر مستلزم. فلذلك من ضمن المسؤوليات علينا اليوم أن نعرف الطريقة المثلى، لأن هذا من حقوق المرضى علينا. ورسالتي الثالثة، نماذج الرعاية بمساراتها أو نموذج الرعاية بمساراتها المختلفة، من ضمن المسؤوليات علينا اليوم أن نعرف ما هي الجيت كيبرز، من هم المشرفين على نموذج الرعاية لكل نطاق في منطقتي وفي الوزارة على مستوى الشركة القابضة. وجود الدكتور فؤاد أبو غزالة نيابة عن الدكتور عبد الرحمن القحطاني بيعطونا إن شاء الله معلومات عن نموذج الرعاية، عن يمكن حتى الأسماء. وهي فرصة اليوم بدامنا موجودين، إذا ما قدرنا نجيب حنا في البانل ترانا متواجدين حتى في المعرض، فإذا كان في شيء مو واضح لك من منظور شركة قابضة، من منظور مسارات علاجية، وجود الدكتور فؤاد اليوم إن شاء الله بيجيب على كل استفساراتنا. الدكتور أمجد، وكما تعرفون دكتور أمجد هو مدير عام الصحة المدرسية، هذا برنامج كان يتبع لوزارة التعليم، والآن انتقل انتقالا كاملا إلى وزارة الصحة، فأصبحت الإدارة عامة للصحة المدرسية ومبادرة اعرف أرقامك، وهذه دائما ما نذكرها لأنها من المبادرات اللي تبناها الدكتور، هو قائد المبادرة، وجميعنا لمسنا أو سمعنا كلمة اعرف أرقامك. طبيب الأسرة وطبيب السكر وطبيب البدانة يحتاج هذه المبادرة، يحتاج أن تتأكد ما هي أرقام مريضك. فالمبادرة، الاستفسارات على المبادرة، كيف أدعم هذه المبادرة مع الدكتور، بالإضافة إلى الصحة المدرسية وماذا يقتنصون أثناء زياراتهم للمدارس، 1,400,000 اللي زرتوهم، كم اكتشفتوا منهم حالات السمنة المفرطة، كم اكتشفتوا منهم حالات السكري. فأيضا هذه فرصة اليوم أنه نسأل ونستفسر، وإذا لم تجدون إجاباتكم في البانل ديسكشن متواجدين معكم اليوم، وأيضا حتى بكرة. ويمكن أنا أحط المسؤولية على الدكتور رايد، أي استفسار لم يصلكم اليوم أو إجابة لم تصلكم اليوم، ترى مسؤولية الدكتور رايد أنه يوصلها لنا بإذن الله. فمفترض أنه موجودين معاكم اليوم كامل وبكرة، ولكن انشغالنا بعض الاجتماعات نعتقد أنه فيزيكلي ما راح نكون موجودين معاكم، ولكن قلوبنا وعقولنا معكم اليوم، لأنه نتمنى أن يكون هذا الملتقى فعلا ملتقى يغير البوصلة للاتجاه الصحيح بإذن الله بوجودكم. تفضل دكتور.
السلام عليكم ورحمة الله وبركاته، صبحكم الله بالخير جميعا، وكل عام وأنتم بخير، وسعيد بتواجدي معكم. شكرا أخي الدكتور فيصل على الدعوة، كذلك الأخوان المنظمين، أتمنى لكم التوفيق في ملتقاكم العلمي. احنا في مسار الإمداد وسلاسل الإمداد والتموين في الوزارة، يمكن أخليها على جزئين، جزء السمنة وكيف تواصلنا مع مراكز المتخصصة على مستوى المملكة. الحمد لله أصبح التواصل عالي جدا بين الزملاء في سلاسل الإمداد وكذلك في المراكز المتخصصة اللي تقدم جراحات السمنة. أعتقد الأرقام يعني عند الزملاء اليوم بعد ما سمعنا الأخوان في بيشة أو المناطق الأخرى، سعيد صراحة أني أسمع الإنجازات في جميع المراكز. الدعم متواصل في أي خدمة ممكن يقدمونها للمرضى المحتاجين في مراكز جراحة السمنة. المراكز المتخصصة في علاج السكر، صراحة في أرقام جدا أنا سعيد أني أشاركها معاكم اليوم. على سبيل المثال في السنوات الماضية كنا نغطي فقط 500 مريض في المضخات، اليوم الحمد لله العقود الجديدة أتاحتنا نغطي إلى حوالي 10,000 مريض، وهو كل المرضى المحتاجين في الوزارة. حساس السكر كان المتاح فقط 25,000 مريض، اليوم وصلنا إلى 75,000 مريض، وبناء على طلبات الأخوان في لجنة السكر بقيادة الدكتور محمد الحربي، نحن مغطين جميع المرضى المحتاجين لحساس السكر. الحساس أصبح اليوم على وصفتي، ولله الحمد الوصول له أصبح سهل وسريع ومتوفر في جميع المناطق. كذلك ما يخص شرائط السكر، اليوم نغطي حوالي 600,000 مريض. الأرقام صراحة جيدة وتغطي نسبة كبيرة من الناس أو جميع المرضى المحتاجين اللي يتبعون لوزارة الصحة. لا زال التواصل كبير بيننا وبين الأخوان في المراكز المتخصصة في أي خدمات يحتاجون يقدمونها للمرضى. في أي مشاريع تطويرية ممكن أنها تؤثر في تقديم خدمة للمرضى. أي تحديات، أي أمور تحبون تشاركونها معنا، إحنا جاهزين زي ما تفضل أخوي الدكتور فيصل في البانل أو في المعرض أو في أي وقت. فشكرا لكم على حضوركم، على تواجدكم معنا، وسعيد مرة أخرى بتواجدي معكم.
يعطيكم العافية، عيدكم مبارك جميعا. أثني على مقدمة المهندس مرعي على شكر الزملاء على التنظيم وشكركم على الدعوة. وبصراحة يعني أقول إحنا سعيدين بالرعاية الأولية، وأنا كطبيب أسرة أيضا أن يكون يعني أول رسالة يرسلها الدكتور فيصل هي عن طبيب كل أسرة. يعني هذا التناغم اللي كنا ننتظره صراحة من سنوات، والآن الحمد لله نشوفه يعني بتكامل أدوار بين مختلف الوكالات والجهات داخل الوزارة وخارجها. بالنسبة للصحة المدرسية مستقبلها طبعا هي جزء من طبيب الكل أسرة، يعني كل ما سأذكره سيكون ضمن مهام طبيب الأسرة في مشروع طبيب الكل أسرة، اللي هو قائم على رعاية فريق طبي للشخص. هذا الوجه الجديد للرعاية الأولية الهدف منه هو تحسين ورفع مستوى الخدمات المقدمة من خلال مراكز الرعاية. لما يكون المريض سابقا يتناوب عليه، حتى خلينا نتكلم تحديدا على مرضى السكري والسمنة، يتناوب عليه أكثر من طبيب وكل مرة يعني يتعامل بخطة علاجية. الآن طبيب الكل أسرة أوجد باثوي واحد يمر فيه كل المستفيدين من الخدمة ويعمل على الوقاية ويعمل على العلاج الاثنين، بالإضافة إلى تكامل خدمات مع المستشفيات من ناحية الإحالة، من ناحية الحاجة لأي إجراءات تشخيصية وعلاجية. إذا بنتكلم على موضوع الصحة المدرسية، يعني الحمد لله وصلنا إلى مرحلة أن عندنا فحص تقريبا كل 3 سنوات للطالب، نقوم فيه الآن سنويا على مستوى أولى ابتدائي ورابع ابتدائي وأولى متوسط وأولى ثانوي لكافة الطلاب. من ضمن الفحوصات اللي نقوم فيها الاستكشافية موجود فحوصات متعلقة بالسكري والسمنة، وعندنا رصد كامل في كافة المناطق بكافة البيانات لكل يعني المصابين بالمشكلتين الصحية هذه. طبعا تعاونكم أو التعاون بيننا وبينكم هو مهم وهو قائم يعني عمليا. يمكن أول مرة نجتمع في ملتقى، لكن عمليا احنا قاعدين نشتغل مع بعض يوميا بإحالة هذه الحالات وتعاملكم معها وإعطائكم. يمكن إذا في رسالة الطالب أو الطفل غير البالغ يعني يحتاج إلى أدفوكيت، يحتاج أحد يحارب على مصلحته. الوعي أحيانا عند أولياء الأمور ما هو كلهم بنفس الدرجة، فنحتاج لما يكون فعلا في طلاب فئات عمرية من الأطفال أن يكون يعني نساعدهم من ناحية تسهيل المواعيد والمتابعة وإرشادهم للطرق الأمثل للاستفادة من الخدمة. طبعا ما يخفى عليكم أنتم يمكن اللي في الميدان وشايفين كيف الحالات قاعدة تزيد، طبعا نتيجة اللايف ستايل ونتيجة أشياء أخرى. إذا ما تعاملنا مع كرة الثلج من الآن هي راح تكبر مع الوقت وراح نوصل إلى مرحلة تفوق يمكن حتى احتمال النظام الصحي. لذلك من جهتنا كرعاية أولية وكصحة عامة احنا نعمل على الوقاية أيضا، ونتطلع يعني تعاون الجميع من ناحية التعامل مع الحالات المصابة بهذه المشكلتين الصحية. وأعرج على المبادرة ذكرها الدكتور فيصل، مبادرة اعرف أرقامك. اعرف أرقامك هي مبادرة لخدمة كل الجهات الصحية. احنا نقوم على يعني فحص تقريبا في مختلف القطاعات الحكومية والخاصة وحتى القطاع الثالث شريك في بعض الجهات. نقدم الخدمة مجانا للجميع، وفحصنا إلى الآن تقريبا ما يفوق 4 مليون شخص من ناحية السكر والضغط والسمنة. وفي خيارات للفحص، في خيار فحص شخصي أنك أنت تفحص نفسك وتدخل بياناتك من تطبيق صحتي، أو أنك تفحص من خلال المراكز والمستشفيات وتضاف لك من خلال الممارس الصحي. فعندنا شريحة بيانات ضخمة جدا على الفحوصات اللي جاية من المنشآت الصحية. هذه فحوصات كلها دقيقة ويمكن يعتمد عليها، وبالإمكان تزويدها لكل مراكزكم، إنه ممكن نعطيكم أكسس على هذه البيانات وتقدرون توصلوا للناس، سواء البالغين من ناحية تعرف أرقامك والأطفال من ناحية الصحة المدرسية. وسبق أن حصل في تعاون مع الدكتور عبد الله العربي والدكتورة العلمي بهذا الخصوص. يعطيكم العافية وشكرا للفرصة تواجدنا معكم. الله يعافيك.
السلام عليكم، كل عام وانتم بخير جميعا. اثني على كلام الزملاء وعلى شكر زملائنا بالوكاله المساعده للمستشفيات والزملاء في المراكز المتخصصه. طبعا شركه الصحه القابضه يعني تعمل جنبا الى جنب مع الزملاء بوزاره الصحه على تفعيل كافه المبادرات اللي تصب في الصحه العامه بشكل عام وفي صحه المواطن بشكل خاص والمستفيدين من خدمات وزاره الصحه. طبعا خلال الفترة الماضية استكمالا لجهود الزملاء في وزارة الصحة يتم العمل على العديد من المبادرات اللي تصب في موضوعنا الخاص اليوم، سواء كانت السمنة أو مرضى السكر. في العديد من المبادرات تم عملها من ناحية تفعيل مسارات خاصة للسمنة وأيضا مسارات خاصة لمرضى السكري. أيضا الاستفادة من المراكز المتخصصة من الدعم اللي يقدم من وزارة الصحة من وكالة المستشفيات في نقل بعض الخدمات إلى بعض المناطق أو التجمعات الصحية التي في السابق يكون إحالة المرضى منها إلى خارج هذه المناطق لعدم توفر الإمكانيات مثل عمليات السمنة. الآن صرنا نسمع بعمليات سمنة تتم في بعض التجمعات الصحية سواء كانت في المناطق الشمالية أو المناطق الجنوبية. سابقا لا يمكن يعني عمل هذه العمليات لعدم توفر أطباء مختصين. الآن تم نقل يعني بعض المتخصصين والاستفادة من المراكز المتخصصة والاستفادة من الطبيب الزائر، مبادرات الطبيب الزائر في هذه التجمعات. أيضا عملية الطبيب لكل أسرة والاستفادة من الفحوصات المبكرة لدى المستفيدين بشكل عام. أيضا مبادرات الزملاء في الصحة المدرسية وفي الرعاية الأولية بشكل عام. أيضا وجود الإمدادات الأكثر من رائعة اللي بدأت تتوفر من وزارة الصحة بما فيها يعني أجهزة قياس السكر الذكية اللي صارت الآن متاحة للجميع وخصوصا لمرضى السكر من النوع الأول. أيضا توفر الأدوية الحديثة من ناحية بعض الأدوية السابقة التي لم تكن يعني متوفرة من قبل الوزارة. الآن اللهم لك الحمد يعني في تقدم كبير في توفيرها بشكل يعني أكثر من رائع. وبإذن الله يعني وجود أيضا مبادرات نوعية لتمكين الزملاء في الرعاية الأولية مثل المثقف الصحي، وأيضا وجود مدير الحالات. يعني في السابق كانت الحالة ممكن تفقد ما بين المستشفى والمركز المتخصص والرعاية الأولية. في وجود يعني مدراء الحالات الآن الكيس كوردينيتور داخل الرعاية الأولية صار في تنظيم يعني أكثر من رائع، وبإذن الله القادم يكون أفضل. وإحنا متواجدين معكم إن شاء الله الردود على جميع الاستفسارات التي راح تقدم لمحور نقاشنا في هذا المؤتمر الكريم. والله يعطيكم الصحة والعافية.
شكرا أبو محمد والزملاء الكرام، يعطيكم العافية. أتمنى أن يعني هالجلسة الحوارية يعني أجابت على بعض الاستفسارات والاستفهامات لديكم. بدقيقتين بحاول يعني ألخص ما دار في نقاش الزملاء. أبدأ من حيث ما تطرق له المهندس مرعي، الإمدادات وتوفر الإمدادات. ولله الحمد الآن يعني كثير من الوسائل أصبحت واضحة جدا. الديجيتال بدأت تساعدنا كثيرا لمعرفة احتياجاتكم. لزملائي مدراء مراكز السمنة، آلية طلب الكتات والمستلزمات واضحة جدا. الآن أنت كطبيب يجب أن تعرف قائمة انتظارك اللي موجودة عندك، تتأكد أنك جدولت هذه القائمة بأي وقت يناسب المنشأة والمواقع اللي حددت لك. يجب أن تتأكد إن كان هناك نقص إمداد في المستشفى فيما يخص التخصص اللي أنت تشرف عليه، أن تتأكد أن زملائك في برنامج أداء يرفعون ذلك من ضمن المنصة الأسبوعية. نحن نتابع ذلك على مستوى الوزارة. إذا كان في رفع من المناطق، إذا كان في نقص، نتفاجأ بعض الأحيان يجينا أوامر أنه في نقص ونلقى الطبيب ما رفع الاحتياج بشكل صحيح. فلذلك أول رسالة العودة لمشرف أداء في المنطقة لديكم، والتأكد طبعا بالتنسيق مع المساعد العلاجي، مساعد للخدمات، مراقبة المخرجات أو CMO إذا كنت في تجمع، أن تتأكد أنك ترفع احتياجاتك بشكل واقعي ودقيق، لأنه الإمدادات تتابع من قبل زملائنا في وكالة الإمداد بشكل أسبوعي ونراقبها. فالمفترض إذا كان هناك في عدد العمليات له سبب، فلا نتوقع الآن يكون سبب نقص إمداد، لأن نقص الإمداد له آلية واضحة. كيف نتابع؟ نتابع بناء على المخرجات الأسبوعية، كم عدد المرضى اللي أجريتهم العمليات، وكم الحالات اللي تم إلغاء العمليات بسبب نقص الإمداد أو توفر الطبيب. فأتمنى من الجميع يركز على الآلية الأسبوعية هذه عشان هي ما ستقيم عملك. أتمنى أن نركز على الأوتكمز ولا يكون هدفنا فقط إجراء العملية. الأوتبوت الآن محوكم بشكل جدا رائع، المخرجات، المتابعة الأسبوعية، نعرف عدد العمليات. كثير من المناطق الآن أصبح لديها يعني أعداد كبيرة جدا، ولكن هذا لا يغفل أهمية الأوتكمز أو الأثر لذلك. فالمريض يعتبر مريضك من قبل لا يصل إليك، أتأكد من ارتباط الطبيب بكل أسرة. أثناء إجراء العملية أتأكد أنه مر في السايكلز السليمة، يعني هي ليست فقط إجراء توقيعات من بعض الأطباء عشان أجري العملية، لا، يجب أن أتأكد أنه مر على اندوكراينولوجيست، يجب أن أتأكد أنه مر بالسايكل السليم، أتأكد أنه أدى المطلوب منه قبل إجراء العملية. العملية آخر الحلول وليست أول الحلول. بعد إجراء العملية يجب أن أتأكد في متابعاتي معه، ثم أضمن ارتباطه مع طبيب لكل أسرة، لأنه هذا هو صمام الأمان لهذا المريض. فهذا فيما يخص مراكز السمنة ومراكز السكر. أيضا المراكز للحالات الأنستيبل، مجرد ما يكون في كنترول هيموجلوبين A1C والحالة استقرت، ترى مكانه ليس لديك في مركز الرعاية، في مركز السكر المتخصص. المفترض أن تكون هناك الهجرة العكسية المنظمة من خلال برنامج طبيب لكل أسرة، وتأكد أنه موجود في مركز الرعاية الأولية لاستمرار متابعته لديهم. متى ما كانت الحالة غير مستقرة يجي دورك كمركز متخصص. فهي فرصة الآن لمراجعة البيانات اللي لدينا، المرضى اللي نراجعهم، كم نسبة الفولو أب مقارنة في النيو بيشنتس. إذا كنت مدير مركز يجب أن تراقب هذا العدد، فنسبة 70-30 لربما تكون مقبولة، ولكن في بعض الزيارات وجدنا 100% من المرضى في مراكز السكر مراجعة. فهذا ما يعني أنه ما في هجرة عكسية للمكان المناسب أصلا لاستمرارية الخدمات. فمركز الرعاية الأولية وطبيب لكل أسرة هي المكان الدائم للمراجعات، سواء لمريض السكر أو أي من الأمراض المزمنة، واحتياجها المراكز المتخصصة فقط لمراحل معينة ثم يعود. فهذه يمكن رسالة أحب أكدها على جميع زملائنا. أتمنى التأكيد على تقارير الزائر السري كقيادات وكأطباء. تقارير الزائر السري مفيدة جدا لمعرفة إذا كان عندك قصور في الخدمة في مكامل، لأنه الزائر هو عبارة عن عين المريض وليست عين المسؤول والقيادي. فتجينا تقارير دورية. أتمنى أن تسأل متى كان آخر تقرير زائر سري عندي، وش الملاحظات، هل وصلك التقرير أم لا؟ لربما يمكن ما وصلك. فمن ضمن أدوارك ومسؤولياتك التطويرية لهذا المركز أن تتأكد وين تقرير الزائر السري، إيش كانت الملاحظات. كل مركز يزار 8 مرات في السنة، فما هو من المتوقع أصلا أن الزيارات نفس التكرار بدون أي تحسن. فهذا المانديت والمسؤولية على مدير المركز. أيضا تجربة المريض ورحلات المريض، هذا من التقارير نعتمد عليه اعتماد كبير جدا، لأنها من ثيرد بارتي، من بريسجيني، يعني جاية من منظمة أخرى هي من تقيم تجربة المريض بناء على الرحلة اللي أقرناها جميعا. فهي فرصة إن لم تكن تعرف رحلة المريض أن تسأل ما هي الرحلة المناسبة عشان أتأكد إذا كان عندي نقص في تجربة المريض ونسبة رضا المريض، أنا أتأكد لماذا هذا النقص لم تنقص إلا لسبب. فمن ضمن أدوارنا ومسؤولياتنا التأكد من رفع نسبة رضا المرضى. هذا ما حاولت ألخص ما دار في كواليس البانل ديسكشن. إذا فيكم أي استفسارات احنا بين يديكم.
يعطيك العافية دكتور فيصل. شكرا. تفضل مهندس.
أنا بس عندي تعليق، أجدد وأؤكد دعمنا للزملاء في جميع المراكز المتخصصة، ويعني أي تقنية أو مشروع يرون الزملاء في المراكز المتخصصة اليوم بيضيف في خدمة المرضى بشكل جيد، ترى أبد احنا حاضرين في أي دعم في هالموضوع. هدفنا أن نكون الخيار الأول والأفضل في تقديم الخدمة. وجود التقنية، وجود الأدوات، وجود المستلزمات الأفضل، هذا هدفنا أن نقدم خدمة جيدة للمرضى. فأبد اللي تمرون فيه أو أي مشروع أنتم تبدون فيه أو أي خطوة اعتبرونا معاكم من الخطوة الأولى. شكرا.
الله يعطيك العافية مهندس مرعي، دائما أنتم سباقين. ولعل يضيف رقم، عام 2017 كان يتم تغطية حوالي 2200 عملية السمنة، في 2022 تجاوز 5500 عملية، وشكرا لكم يعني. طبعا ضيق الوقت يعني شكرا للنقاط الكثيرة اللي ذكرت. في مداخل عندنا من الدكتور أنور عنزي نائب الرئيس التنفيذي للتجمع الصحي الأول بالرياض.
طيب السلام عليكم، يعطيكم العافية جميعا. شكرا للزملاء وشكرا للمتحدثين على الملتقى. يمكن يعني قالوها الزملاء أنه كثير الآن صار في اعتماد في النظام الصحي الجديد على الوقاية وعلى السكرينينج، وهذه هي اللي تخليك تركز على تقريبا 30% اللي يستهلكون 70% من إمكانياتك أو من مواردك. وكذلك في عملية تقديم الرعاية الصحية في حراك ما بين البرايمري والسكندري والتيرشري سيرفيسز. يمكن الآن كل هذا قاعد يصير، والسيستمز قد كونكتد سواء عن طريق تطبيق صحتي، إنشاء تجمعات وربطها كمنظومة رعاية صحية، لكن الأهم هو الاستمرارية والديمومة. كيف أنت تضمن أن هذا النظام الصحي بمحركها الأساسي اللي هو مقدم الخدمة اللي هو الكادر الصحي، أنه يضمن أنه عنده نفس الانترست اللي أنت عندك يا المشرع أو يا المراقب أو الممول. أنا ما أعرف، لكن كثير من الأشياء يمكن اللي هي عملية الانسنتيف أو المحفزات في النظام الصحي لابد تبنى على الديمومة، من ناحية مثلا المركز الصحي والله كم نسبة الإحالات أو كم نسبة التحكم في الإحالات لمرضى السكري. واحدة من الأشياء مثلا والله كم قدر مركز السكري هذا يتحكم في المريض خلال كم زيارة. ليس هدفنا أن المركز السكري أو المراكز المتخصصة أنها تحتفظ في المرضى على طول الرحلة العلاجية، بالعكس المفروض هو يحصل على خدمة ويرجع لطبيب الأسرة، ويصير طبيب الأسرة أو المركز الصحي هو الحاضن وهو المسؤول عن هذا. فيمكن هذا سؤال مفتوح، يمكن أحد الزملاء عنده تجربة أو اطلع على شيء، كيف نقدر نحافظ على ديمومة الأشياء اللي قاعد نسويها الآن. يعطيكم العافية.
أنا بجيب من زاوية ويمكن الدكتور أمجد لديه زاوية أخرى. أقرب مثال على ذلك، سابقاً كان مساعد المدير العام للخدمات العلاجية، هذا المنصب الموجود، ومساعد المدير العام للصحة العامة. الآن أقرب مثال، أنت دكتور أنور في بي للهيلث كير ديليفري لتقديم الخدمات، هل هي علاجية ولا صحة عامة؟ المثال الآخر دكتورة ميسة السويلم مساعد المدير العام للمخرجات وليست للخدمات العلاجية وليست الصحة العامة. فأنا أعتقد هذا أقرب مثال حي واقعي أنه أصبحت المسؤولية على تقديم الخدمة، فتقديم الخدمة لم تتقطع زي ما كانت سابقا بناء على المنشآت والمرافق. فالآن هذه أمثلة حية من أصبح من أدوار الهيلث كير ديليفري إعداد لوائح واضحة وبروتوكولات واضحة لكل مرفق من المرافق، ولكن هو نفس المريض اللي في الصحة العامة، اللي أول ما بدأ أصلا في الصحة المدرسية انتقل إلى الصحة العامة والخدمات الأولية، انتقل للخدمات الثانوية والثالثية تحت مظلة مقدم الخدمة اللي هو الفي بي الهيلث كير ديليفري، وتحت رقابة المساعد لمراقبة المخرجات في مديريات الشؤون الصحية في ثوبها الجديد. فأعتقد هذه إجابة من الزاوية الإدارية والتنفيذية اللي بإذن الله سيكون لها أثر كبير، إنه المريض أصبح ننظر له جميعا إنه patient centric بناء على المناصب الإدارية أصبحت تدعم ذلك. في وقت من الأوقات لم نستطع ذلك، لأن كنت أنا أنظر فقط للمستشفى، الدكتور ينظر فقط لمركز الرعاية الأولية، والمريض هو اللي قاعد يحاول يسوي البريدج. فالآن كلنا ندور حوالين البيشنت سنتريك. وإذا الدكتور أمجد لديه تعليق.
أعتقد من أهم المحفزات اللي صارت طبعا وضوح المسؤولية في يعني في طريقة تقديم الخدمات في الوزارة، ساعدت الكل انه يتقدم بادواره، لانه خلاص كل واحد عارف حدوده. ما كنا نمشي بطريقه يعني من السابق، وناس تقدم وناس ترجع وناس تشتغل لحالها. الان تقريبا كلنا ماشيين على نفس النغمه. ويمكن الكلام اللي ذكرته طبيب لكل اسره اللي ذكر الدكتور فيصل اللي هو مسؤول عن المستشفيات، هو مؤمن فيه مثل ما مؤمن فيه الصحه العامه والرعايه الاوليه. هذه راح يعني تحفز الكل انه ينطلق بمسار واحد لخدمه المريض. لما نتكلم على مريض كان عشان يتابع السكر أو أي مشكلة صحية، كل مرة يجي المركز الصحي يلقى شخص مختلف، ويلقى الريكوردينج أو توثيق الحالة مرة في الملف العادي ومرة في ملف الأمراض المزمنة، الممرضة اللي هنا تختلف عن اللي هنا. الآن نتكلم على فريق طبي واحد وبلاتفورم للتواصل، يعني الطبيب راح يقدر أو الفريق الطبي الكامل يتواصل بالجوال مع المريض بشكل مفتوح عن طريق تطبيق صحتي. عندنا ال HIS اللي صار موجود الآن في كل مراكز الرعاية الصحية الأولية، وصار مربوط على الأنظمة الأخرى، والآن حتى أنظمة الصحة المدرسية مع وزارة التعليم شغالين نربطه فيها. يعني الطبيب اللي هو جالس في مكانه في المركز الصحي راح يعرف أن الطالب هذا فحصوه فرق الصحة المدرسية وطلعت نتائجه فيها مشاكل، وراح يبادر يتواصل معه قبل حتى لا يجي هو يسوي موعد. فكل هذه أنا أعتبرها محفزات عملية صراحة تخلي الناس ما عاد في صعوبة في تقديم الخدمة، ممكن ينطلقون الناس فيها أكثر ويتوسعون في الخدمة ويزيدون حتى يعني العمليات اللي تصير داخل المركز. إن شاء الله يكون الجواب كامل. الله يعطيك العافية.
يعطيك العافية دكتور أمجد. أجدد الشكر صراحة للدكتور فيصل على دعمه الدائم والمعلومات الثرية والدعم اللي دائم نجده منك. شكرا مهندس مرعي على تواجدك دائما في الإمداد والتموين وما تمثلونه من خدمة كبيرة في الرحلة العلاجية الجراحية خاصة في السمنة أو في مراكز السكري. شكرا دكتور أمجد على ما ذكرته. شكرا دكتور فؤاد وغزالة، مثل ما ذكرت في الصحة القابضة نعمل جنبا على جنب، وهذه معلومة يجب أن يعلمها جميع التجمعات والمديريات، أنه الرؤية عندنا واضحة والعمل دائم بجانبنا على الخطط والاستراتيجيات القادمة. أطلب من سعادتكم سعادة راعي الحفل بتدشين المعرض المصاحب للمؤتمر باسم الدكتور عبد الله السهيمي.
Assalamu alaikum. Back to scientific program and lectures. Now we are going to present Professor محمد النعمي. حيتكلم اليوم عن موضوع مهم جدا. هتكلم بالعربي لأنه بعض الناس يحكوا بالعربي. نوع من أنواع تغيير المسار اسمه سادي. والبروف النعمي ما شاء الله مشهور بعمل العملية هذه، تفيد في الميتابوليك والأمراض الميتابوليزم زي السكر والأمراض الأخرى. فهي going to present a single acidural ileal bypass as primary or revisional procedure. تفضل بروف.
السلام عليكم ورحمة الله وبركاته وكل عام وأنتم بخير. I would like to thank the organizing and scientific committees for inviting us to share in this excellent symposium, and I hope we can share a very important topic. Why it's moving so fast? A very important topic that addresses a subset of patients who are really difficult to manage, and they are mostly neglected because of this difficulty, and always the centers refuse to treat them, even refuse to transfer them to other places. So I took this opportunity to present those subsets of patients in relation to this procedure. We at Prince Sultan Humanitarian City, we are mainly a rehabilitative center or city. And the rehabilitation is for those who sustain CVA with handicap, those who sustained road traffic accidents. And the city has progressed to include other diseases like lymphedema, and we have an established lymphedema program there. Also obesity, especially severe obesity, where they have special needs like pre-operative rehabilitation and post-operative rehabilitation. So I'll be delighted to share with you our experiences. I have no disclosures. The objectives for this presentation, by the end of this presentation, respected audience will be familiar with SADI-S and its indications, differences between SADI and SADI-S, the literature review of this relatively new procedure as a primary or a revisional, and I will give you our local experience and summarize and conclude at the end. So the procedure was invented by a group of Spanish surgeons led by Bernois and his colleagues in 2007 as an advancement of the older procedure called biliopancreatic diversion with duodenal switch. As this procedure was having lots of metabolic and nutritional complications. So it's a rescue procedure for the older procedure. And basically, as you see the duodenal switch here, they measure from the ileocecal valve 250 centimeters and then separate the bowel. They take the distal end and hook it to the first part of the duodenum after resection of the first part. And the distal end, they hook it to the terminal ileum at around 100 centimeters. It is similar to another operation invented by an Italian surgeon called Scopenaro procedure, biliopancreatic diversion. However, they are modifying that to help avoiding the malnutritional and the metabolic consequences of that operation. However, the SADI came also to improve this further by changing the duodenal switch operation into single anastomosis duodenal bypass. And if we add S, means sleeve gastrectomy as well added. So what we do, we measure 300 centimeters and hook it as an omega lobe to the first part of the duodenum. That's all. So they will have a very good length for absorption and avoids the metabolic and nutritional effects of the older operations. The International Federation for Surgery of Obesity, based in Europe, and the Association of Metabolic and Bariatric Surgery in North America approved SADI-S as an effective and safe procedure for the treatment of severe obesity and metabolic comorbidities. What is SADI? I'm sorry. What is SADI and what is SADI-S? SADI means single anastomosis duodenal bypass without sleeve gastrectomy. And this is usually a term expressed for revisional surgeries, especially after sleeve gastrectomy, when the sleeve gastrectomy failed to give the optimized results. But when it is primary, it's called single anastomosis duodenal bypass with sleeve gastrectomy, as you can see in this slide. And the single anastomosis is the omega lobe that is measured 300 centimeters from the ileocecal valve. And this is the modification of the previous two older operations to avoid severe metabolic and nutritional consequences. So now I'll go quickly reviewing the literature of this as Serve and his colleagues published in obesity surgery, the early outcomes of primary SADI from Australia. And they published 91 patients who were analyzed with a BMI ranging from 46 and averaging 46, and the mean age 46, and the BMI 43. The operative time is around 2 hours in their early experience, and at 12 and 24 months follow-up, they have a loss of BMI of 15 and 17 kilogram per square meter respectively, which is a very good compared to regular surgeries like sleeve, where they lose about 10 to 11 BMI degrees. The short-term and long-term complications were 4 to 0 on the long run, and they had reported 0 mortality. Post-operatively, they observed improvement in the comorbidities, including diabetes, dyslipidemia, and reflux resolution with good rates, except the reflux, because there is a sleeve component of this procedure, so the reflux did not improve that much. And there was no statistically differences between most of the pre- and post-operative nutritional data. Same group published another study in 2020 and call it long-term outcome of SADI-S. And they involved 750 patients with the mean age and body mass index 49 and 50. So now they are moving to higher BMIs to treat, and with a follow-up of about 61% at 5 years and 53% at 6 years. So this is a long-term follow-up of this procedure. The operative time has improved from their previous publication by half of that time. So they used to take more than 2 hours. Now it's around 1 hour. The intraoperative short-term and long-term complication rates were considerably acceptable. A 30-day emergency room visit, which is 1 month post-op complications, were 0.4%, readmission 1.1%, and redo surgery, reoperation 1.1%. Complete remission of diabetes was about 77%, and at 5 and 6 years, the mean change of body mass index was sustained at 17 approximately. And the mortality, they reported in this study, 0.5%. Another prospective multi-center randomized trial, which is the only one I found in the literature, comparing the efficacy of and safety of SADI with sleeve gastrectomy, Roux-en-Y gastric bypass. They call it SADI sleeve study protocol. This was published in the British Medical Journal in 2020. All these studies are recently published. And the main objective was to compare this new procedure with an old procedure called Roux-en-Y gastric bypass, or the classic gastric bypass. The secondary objective is their effect on metabolic and nutritional comorbidities. They found out that SADI is superior to Roux-en-Y gastric bypass on weight loss and metabolic results. SADI has the same nutritional complications as Roux-en-Y gastric bypass. So there was no issue on nutritional problems. Another study showing the short-term outcome from SADI by Andalib and his colleagues. Again, they have similar results of other reported cases with low rate of complications, no mortality, follow-ups was adequate, and the BMI is around 17 to 18 kilogram per meter square. The complete remission for diabetes was 91%. Long-term results, also another study by Sanchez Bernois, those in Spain who invented this procedure, and they involved 164 patients, and the mean age was 47, mean body mass index was 45.8, around 46, with a total of 101 patients who had diabetes and others who had other comorbidities. They being those who invented this procedure, they tried different distal or common channel limbs. They tried 200 centimeter, they had 250 and 300 centimeters. And they found that the outcome is better for nutrition with the 250 and 300 centimeters. And there was no mortality. 1 patient had leak and 2 patients had anastomotic leaks. A total of 25% of patients lost follow-up, so 75% were followed up to 10 years, which is very important to give this study this strength. Excess weight loss and total weight loss were 78% and 38% respectively. A total of 12 patients had revisional surgery for hypoproteinemia. So whenever a patient who had a side effect of SADI causing nutritional deficiencies, they have to be reversed. Mean glycolated hemoglobin was 55.5 at 5 years and 5.8 at 10 years, which is a very good glycemia control of this procedure. Another study, an updated systematic review by Spinos and colleagues, published in 2021. They found out from this systematic review, they collected about 400 studies and they filtered them, and the comorbidity resolution after this procedure was 72% for diabetes and 77% for dyslipidemia and almost 60% for hypertension. The needed reoperation was most commonly was the most common reason for reoperation and reversal. Several patients, however, develop nutritional deficiencies. And these nutritional deficiencies, they claim that it's not due to the procedure itself, as other studies have proven, but it is due to patient compliance. So conclusion, SADI seems to be an overall safe and effective bariatric procedure. Now we'll move for SADI as a revisional procedure. As you know, rates of weight regain after sleeve gastrectomy are increasingly ranging from 5.7% at 2 years to 75.6% at 6 years. So this is a systematic review that showed that sleeve, most of the time, the patients regain weight after a long-term follow-up. Therefore, you have to salvage those by doing other things. So why they regain after sleeve? There are multiple causes, including initial sleeve size is not adequate. So those patients don't lose weight even from the beginning. Sleeve dilatation, especially when the fundus is not completely removed, increased ghrelin levels, inadequate follow-up and support, and maladaptive lifestyle behaviors. So they go to the bad habits of eating and no exercise. There are no hard recommendations for failed sleeve, what to do. Are you going to offer them re-sleeve, to offer them classic Roux-en-Y gastric bypass, mini gastric bypass, SADI, other one anastomosis bypass? It depends on the case merits itself. So you study your patient very well and you decide accordingly. Each case has its own indication and appropriate revisional procedure. So in failed sleeve, there was a study published by a Dutch group in 2018, and they found that they performed about 66 patients converted from sleeve to Roux-en-Y gastric bypass to SADI, and 74 to Roux-en-Y gastric bypass. So they are comparing those failed sleeves with the SADI and with the Roux-en-Y gastric bypass. So SADI achieved 8.7%, 12 and 19% more total body weight loss at 6, 12, and 24 months compared to Roux-en-Y gastric bypass, with significant difference. Roux-en-Y greatly reduced the complications of reflux, however, and dysphagia after surgery compared to SADI. So whenever there is a reflux patient, it's better to go for Roux-en-Y than SADI. A similar amount of complication and nutritional deficiencies were observed, and they were considered comparable, and no mortality in this study. Another revisional study comparing SADI versus one anastomosis gastric bypass, mini gastric bypass. And This was published by Basha in Obesity Surgery in 2020. They compared 42 patients who underwent SADI after failed sleep, of course, with 49 who underwent single anastomosis.
2 minutes, Prof.
Yes. The early outcome was better for SADI. However, late follow-up, 18 months, it's comparable. Remission of comorbidities were also comparable. However, both SADIs are effective. SADI is associated with less upper gastrointestinal complications. Pyreflux may get worse with single anastomosis gastric bypass. There are also other literature reporting outcome of revisional surgery. I will skip our experience because really it is only 16 patients. However, we select SADI for severe obesity and for weight regain after a lap sleeve gastrectomy with major comorbidities. This is one of our patients in Sultan bin Abdulaziz Humanitarian City who has a BMI above 70 with lymphedema and blistering even, and she was really bedridden. She cannot move at all. So how are you gonna salvage this patient? So she underwent a rehabilitative course starting with dieting and injection of Ozempic until 2 months passed. Then she was considerably, not totally, considerably fit for SADI procedure. She underwent SADI, and after 6 months from rehabilitation in Prince Sultan Humanitarian City, she was walking outside the center with her family. So that's an amazing results of this procedure. Don't tell me that this type of patient you can do sleeve only, or you do Roux-en-Y gastric bypass. These are not enough for such patients to have them cure from their lymphedema and to have a good sustained weight loss on the long term. So that's my message really for the audience, for the centers of MOH. If they have such patients, please don't deny them. Send them to Prince Sultan Humanitarian City and they can take care of them. So these are the results of the study. So in summary, SADI is a relatively difficult procedure, but shows excellent outcome in terms of weight loss and comorbidity resolution in severely obese patients. However, there is a high prevalence of macro and micronutrient deficiencies following SADI, for which strict follow-up with labs and regular follow-up basis is needed. And compliance ability should be assessed carefully before surgery. If you are not sure of compliance ability, last month we did a patient who was living alone. So we don't know whether she will be compliant or not. So we did sleeve as stage 1, and we're gonna do SADI after 1 year as stage 2, just to assure compliance. Predicting non-compliance before surgery might be a difficult task. However, if in any doubt, you do it in 2 stages, as I mentioned. Redo SADI with or without re-sleeve should be considered for severely obese patients who fail laparoscopic cholecystectomy. There is a video, but I will skip that if you have any questions.
Thank you, Prof. We appreciate your lecture, and we will invite the Prof. Thank you, Doctor. We will leave the question after the end of this session. We will have Prof. Khalid al-Dosari. He is a consultant diabetologist in Professor and Consultant Diabetes Management, Australian Clinical Fellowship in Diabetes Management, Prince Sultan bin Abdulaziz University. Welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. And first of all, I'd like to thank the organizing committee and Ministry of Health, Dr. Alumni, Dr. Abdullah, and all others. So today we'll talk about the, no, this is not the one. لا لا. We'll talk about the telemedicine in diabetes. So, after COVID periods, everything is changed, even for the consultation. But before that, if I ask you, what do you think, which area in the kingdom has high prevalence in diabetes? So what do you think, roughly speaking? So we have 14 regions. What do you think? We have pre-diabetes and diabetes. Do you think the higher percentage will be in the central areas or the high, like Jeddah region, Mecca region, or Riyadh, Dammam, or the others, the peripheries? South? South? Eastern region? What do you think? نشوف بعد شوية. Okay, let's go. So diabetes is increasing with time, and almost we expecting the numbers to be doubled. Now we have 4 million patients with diabetes in the kingdom, which is a huge number. So among the percentage in the Gulf area, we are the second after Kuwait. So this is the answer of our question. So some of you said, I don't know if it's clear or not, but if you notice, the Mecca region has the highest diabetes prevalence. While if you look at Jove, for example, Jove in the north of the kingdom, and the impaired fasting glucose, pre-diabetes, is almost 30% of the population. For the eastern region, Asir, 11%, and the impaired fasting is almost 20%. So we are suffering here and there. The lowest area maybe in Hail and Qasim. This is the most lowest area in the kingdom with prevalence of diabetes. The answer is, if you look at Jove, for example, Jove has 12.7% has diabetes, and almost 30% have pre-diabetes. How many diabetologists, endocrinologists there? So 10, 15, 20. So you are facing every day hundreds and hundreds of patients. So we are in an era that we need telemedicine in such cases. We need virtual clinic. For whom and when to start the virtual clinic, this is the area of discussion, and we'll discuss about it. So before COVID is something, and after COVID is something else. So this is the study just done here in Saudi with Dr. Sahar Al-Harthi, the impact of prolonged lockdown and use of telemedicine on glycemic control in people with diabetes during COVID-19 outbreak. So this study is published in 2021, and for type 1 diabetes and type 1, we have several issues for them. For titration of insulin, for if they are using pump, or if they are using even the CGMs, for reading CGMs, for carb counting, lots of the interventions, lot of patients need, lot of diabetes team want to discuss with this patient. So this is the time and range. They download the result from CGM after 2 weeks. Then this is the result. For time range, patient doesn't interfere with the study. Placebo was on the left side, and the other hand, on the right side, that's patient who is having virtual diabetes clinic, and B-value was significant in virtual group. So this is one of the local study that can show you the importance of close monitoring and virtual clinic for such cases. Also, another one that's time above range, if the blood sugar more than 180, and also if more than 250. So there is a huge difference. P-value was significant. So, and that's logic, because you will talk to your patient, you'll adjust insulin, and one of the most common problem and issue for patients with diabetes, either type 1 and type 2, that we are giving insulin in the primary care or even for diabetic centers, and we ask them to go. Take 10 units, take 14 units, and go. Patient will still for 3 months, and he will come to you later on without any improvement. Reason why? Less education, missed titration, and there is no close-up with the team. So if you have a patient just virtual clinic, you see him first time, you'll give him after 1 or 2 weeks, virtual clinic with 5 minutes, either by you or by clinical educators. So I think the life will be easy, either for long-acting insulin or short-acting insulin. So this is the for the HbA1c. It's excellent and wonderful. Then the p-value was significant. Another study, perception of virtual clinic among Saudi adults with type 1 diabetes. This is examining the patient themselves and their perception about the virtual clinics. Most of them, about from 60 to 90%, they agreed, they are happy about the virtual clinic. They want to continue and they want to have bond with their physician. Personally, I have experience with Ministry of Health. In COVID period, we started 4-month volunteer clinic in Wadi Dawasir Hospital, and we have 391 patients there. After 4 months from lockdown, we got an excellent results. At that time, we don't have access to them only by phone. But anyhow, most of them, we start them in insulin, we give medications, no complaint that at that time. And most of them, I saw them before, those are my patients. So what are the pros and cons, advantage and disadvantage for such case, such modality? Telemedicine cut geographic barriers. If you have patient, for example, in Sabt al-Alaya or something, and he want doctors in Asir Central Hospital, there is no need to go from Wadi, from Slayil, Tathlith. There is no need to go and to 6-7 hours by car to come to Central Hospital. Also, adherence to their medications. Physicians will be, and also educators or pharmacists, will be close to their patients. We remind them about their medications, and this is an extra benefit. Also the cost, financial cost, direct cost, or from the indirect cost that we prevent the complication in the future. So what are the challenges? Challenges is a lot. Sometimes you don't have a system that can help you. One of the problem that if you talk to your patient for first time, you don't know his background, you don't know his history, you don't see him face by face. Sometimes some endocrine cases you can notice in the clinic, and you can shift your diagnosis to other one. But from my personal approach, the virtual clinic will be important and beneficial for a second visit or follow-up visit. For new patient, especially newly diagnosed diabetes, I think better to come to the clinic and explain to them, especially type 1 or even type 2, all the aspects of diabetes. He has to meet you and dietitian, educators, and other members of the team. When, how, and for whom, this is a huge topic, huge area. I know there is virtual hospital nowadays in the Ministry of Health, and there is a clinics. I'm happy that also GDM cases can be seen also in virtual hospital, and that's fine. So nothing right, nothing wrong for whom and how and why, but definitely to see your patient in the clinic, this is the wonderful things. But nowadays with crowdness and busy clinics in Ministry of Health and also in the universities, you are seeing 20 to 30 in your clinic. There's no much time to explain and to give the full communication with your patient. I think some of the patients I know, There is one hospital, they are doing TSH for their patient, and they ask him, please take the next appointment. Next appointment is after 9 months. How come? This is an area of the virtual clinic to be implemented. So I like this talk by Dr. Farouk. How do we change the focus of diabetes management from being retroactive to being prospective? And if not prospective, at least along the same time with diabetes progressing. If you are with your patient, either in your clinic, virtual or face-to-face, I think you will prevent lots of complication in diabetes management. Thank you very much.
Thank you, Prof. And from the virtual care to the robotic bariatric surgery experience in King Fahad Medical City by Dr. Muhammad Abu Khatir. Welcome, Doctor.
Assalamu alaikum. I'm going to present some robotic bariatric surgery experience in King Fahad Medical City. We started the practice in 2018. We started by simple cases. Now we do more complex cases, and I will speak about the advantage of robotic bariatric surgery, and I'll show some videos of some cases. You know, the surgery between surgery and patient, there will be some tools. We started open surgery previously with using the usual open surgery. Then in 1990s, we shifted to the laparoscopic tools. Then the computer came between patient and the surgery, right? Then, the robotic. Actually, this not accepted idea at the beginning, why we keep something between patient and between surgeon and the patient. Even some surgeons think this is not a good thing, it's a danger, stupid, too big, too long to operate, difficult to teach, there is no tactile sensations. All these things, even me, before I start, I was thinking about it. But when we work in it, we find the different things. There is a better vision. We see a 3D visions, better range of motions, better ergonomics. Stress to the surgeon is less compared with laparoscopy or open surgery. Recovery time, revisional surgery, and learning curve is much less compared with laparoscope if you compare it. What is the history of bariatric surgery in the world? Himbens performed the first robotic assisted adjustable gastric band in 1998 in Belgium. Then 11 surgeons in 2003 in the US started the bariatric surgery. They use it in anastomosis, duodenal anastomosis, and gastrointestinal anastomosis at the beginning. Then also bariatric surgery incorporate the robotic surgical system into surgical armentum with advanced hand sewing technique and improved the outcome in 2000. The first robotic Roxanne gastric bypass and robotic assisted belly pancreatic diversion with duodenal switch was performed in US in 2000, in the year 2000. With the rise of prevalence of obesity and failed of bariatric surgery is in witnessing an ever increased demand. High body also in high body BMI, it is good to use. In limited space, always the robotic is good. And thick abdominal wall, which is usually difficult for the surgeon to handle the abdominal wall, especially in laparoscope. In revisional bariatric surgery, it shows some advantage in managing the complication and revisional surgery. So what you see in why robotic bariatric surgery? So vision, as I mentioned, it's better, like 3D camera. Ergonomics, you didn't feel difficulty like in laparoscope. You have to keeping your hands and arms and neck. This all cause pain for you. Retraction, you didn't need help of the assistant. You retract yourself because you put 4 arms. One of the arm, you can freeze the arm, and you didn't need the assistant pull and push and injury to the organs, because the robotic is steady. Robotic system damage unnecessary. If you have some tremor of movement by robotic, it will be subside. As super obesity is also a greater problem with robotic, is much easier. Hand sewing is a really enjoyable work when you do hand sewing. Anastomosis is much different than laparoscope. latest generation of robot also, it has long arm staplers and other things also. You can have all type of staplers, which as a bariatric surgeon, we need the staplers, all type and color of stapler, and long instruments so you reach to the target tissue. I advise when you start doing robotic bariatrics as a beginner, start with sleeve gastrectomy. Because you need to have a team, you need to teach yourself, and this is also proved in some studies. You have to do some learning curve in robotic is much faster than laparoscope. So you need 20 cases to practice sleeve gastrectomy. You need more than this. And also in bypass, same thing. So they found stricture, bleeding, mortality, and leak is less in some of the studies. So this is one of the foot inside our OR. You should have your team, you should have your anesthesia, you have your nurses. They should be trained how to do robotic. At the beginning, maybe when you train your center, you need time. At the beginning, maybe the procedure will take time. But now, really, after working from 2018 till now, we found a difference in the timing. Now, it's comparable with laparoscope. Even the time is less. Here is the setting in our OR. So we start doing, after we did around 60 cases sleeve gastrectomy, we shifted to a metabolic surgery. We do all type of metabolic surgery by, robot. So it is not a big thing, really. If you start, you find it different. Also, the lowering gastric leak, there is some studies shows much difference between robotic and laparoscope. Also the hospital stay, operative time. The strange thing also we found the pain. Pain is less compared with robotic compared with laparoscope. Robotic ruxolitinib gastric bypass is really a surgery of robot because you do anastomosis. If you do hand swing anastomosis, the stress of the operation is much if you do it by laparoscope. You have to have special settings, special port setting to do the bypass. Revisional surgery is another advantage in robotic because you need a meticulous dissection in robotic because of adhesions, and you have a special tools like scissor and division, so you can go through the tissue easily. There is many studies support that leak, especially leak, which always we scare from it. Some studies shows in revisional surgery in laparoscopic 13.2%. But by robotic around 2%. But this is really a big difference. Let's go our experience in KFMC. We did around 163 cases, 65 cases sleeve, 40 cases revisional surgery, 58 primary Roux-en-Y gastric bypass. The male and female around 38 to 34, age group from 21 to 61, BMI range from 41 to 57. We did sleep around 150, the operative time at the beginning was a little bit higher, 152 to 40 minutes. Roux-en-Y from 172 to 110. Revisional, we have more time, 186 to 125 minutes. So the length of stay in the hospital, 2.6. Our complications, we have only one bleeding out of 163 patients. We have to convert to laparoscope 2 cases, one due to technical difficulty inside, and 1 case due to deficiency of some instrument. These are all the complication we have. So we didn't have mortality. I will show you a procedure. I did it 2 weeks ago, a revisional bariatric surgery. Usually it takes a lot of time. We took around 2.5 hours in this case. We removed the gastric band. We can see how meticulous the dissection here. This patient did 14 years ago a gastric band. She came with severe reflux and hiatal hernia. So we did for her 3 things. We removed the gastric band, and we see how much the meticulous of the dissection because we see 3 deviations. So we remove the gastric band. Here, after we remove the gastric band, we have to remove the fibrous band. We cannot proceed because this fibrous band can cause, if you do a stapler in these, it can cause leak. So after this dissection, we have to go and open the diaphragm. and to check the hiatal hernia. If you don't repair the hiatal hernia, patient will keep having reflux and you don't do anything. So here we can see how these fibrous band, it's look like band. It's actually a natural band, so we have to remove it. So to have, to prevent the reflux, to prevent the stricture, this is really very important point. So here we start opening the paraflaccida to go to the diaphragm, to dissect and take care of the dissection. So I'll go just for the sake of time. Here we start dissecting the right crus. We have the vessel sealing system. You can use it in dissection. You can use it also in controlling the bleeding. So we can see maybe the things look bloody and not healthy because it's a revisional surgery. Here we can see the pleura. You can see at the side the pleura. So in this case, I injured the pleura because near the band. So I could repair it very easily. Sometimes in laparoscope, difficult to repair. You can see the other arm here, retracting the esophagus. Here we have some adhesions in the side, so we have to dissect all these adhesions. We have to keep the esophagus free and bring it intra-abdominal. Otherwise, you cannot, do the proper surgery, and patient will keep having reflux. Now I'll show you a very small step after we do that. Now I have to reinforce the gastric pouch I did. Why? Because it's a revisional surgery, thick tissue. The chance of leak is high. I usually reinforce it with suture. See the suturing in the robotic is very easy. You didn't feel struggle. So the second point after that, we have to do, repair the, here we can see the diaphragm. We start repairing after we clear the esophagus and we bring it. We can see the other instrument retracting the esophagus. See the advantage. If you have assistant pulling the esophagus, this will cause a traction. You will be worried. But here you control the power. You control everything. So you control camera yourself. You didn't need nobody catch the camera for you. He will show you somewhere. You are doing some surgery somewhere, and the assistant give you some other view. So you control yourself everything. You don't need help in anybody. So the suturing here, a very narrow area, difficult to suture in the chest. But with the robotic, even I'm stitching by back needle. It's not a simple thing. But see, we have to stitch here. See, managing the sutures and managing the needle. It's very simple, you know. Doing these things with robot really make difference. And you see the angulation of the grasper. See how many angles and how you do the sutures. Then you start tying your diaphragm and do your repair. This is how we repair the diaphragmatic hernia before doing the bypass. Then we start counting and proceed in the bypass here. You can see after we stitches, we confirm there is no hernia. Then we go to the second part of the procedure. Here our pouch is ready for anastomosis. We start dissecting the omentum with the vessel sealing. You can use it in two things. Now we start counting the bowel according to the patient BMI, and we do our anastomosis, hand sewing anastomosis. This is really advantage, and you didn't feel the difficulty and back pain and these things. So after doing the anastomosis, we have to do the jejunostomy. Also counting the bowel is not easy by laparoscope. Here you do the diathermy, you do the opening, you do the suturing, all type of instrument you have, so you can manage the dissection and anastomosis. I'm just concluding this. Then we see here we close the jejunostomy defect by BDS, and this really will be faster, much faster than laparoscope. So in the end, our result in doing the procedure, I think we do the procedure less than laparoscopic in timing. If you have a good team who knows what to do and they are fast in operating. We close also the defect in the end. We do our test. Here we close the gastrojejunostomy. Also we did it, hand sewing anastomosis. We do our test and check there is no leak. And in the end, we complete the procedure. And in conclusion, routine use of robotic in bariatric surgery is a safe and feasible option. Several studies have shown a lower complication rate with a robotic platform, including leak, hemorrhage, stricture. The advantage of robotic is received much more in challenging cases like Rowan-White revisional bariatric surgery, SADI, if you want to do the anastomosis, need to move step by step, like starting robotic sleeve, then move toward more complex cases. The entire team learn with the surgeon and develop experience about patient safety, precaution, OR setting, and type of instrument needed, leading to better OR time with better patient outcome. Robotic system is improved ergonomics, no doubt in it, and lesser operator fatigue, and lesser also stress, physical and mental stress. All this have been studied and proved. Operative time decrease after initial few robotic Roux-en-Y gastric bypass. This may be due to more favorable learning care for robotic than laparoscope. Future study comparing actual cost, comparing analysis of outcome are needed. Robotic provide augmented and higher quality input from the patient to the surgeon, empowering tools to the surgeon which can potentially change the way of the surgery practice today. Thank you. We'll keep
Thank you,
the question
Doctor.
in the end of the session.
Yeah. This is the end of the first session, and we will now take the second session. Is the complication after the success what we see in from our profs and Dr. Muhammad. And we would like to welcome Dr. Nasreen Al-Faris. She is a consultant in endocrine and diabetes management, and in King Fahd Medical City. Welcome, Dr. Nasreen.
أهلا وسهلا. I cannot find my thing here, so I'm guessing you're going to put it on. Okay. So I am Nasreen Al-Faris, as she presented. I am a consultant endocrinologist. I am also a consultant to obesity medicine. And I will raise the issue actually with the very kind people here who actually invited us to give these talks. When I was looking through specialties, I did not find my specialty. I had to put endocrine because there is no obesity medicine. So I hope by next year, now that we have a fellowship that is accredited by the Saudi Commission for Health Specialties of Obesity Medicine, that we will start seeing obesity medicine listed as a specialty. I work at the Obesity, Endocrine, and Metabolism Center at King Fahd Medical City. I've been here working for the past 6 years. Prior to that, I used to work at Mass General Hospital at the Weight Center there. And prior to that, at the Weight Center at the University of Pennsylvania. So I do not have any disclosures for my talk today. I don't have anything to disclose for this talk. And prior to talking about complications, and I'm glad that I'm opening this session, is that we have to remember, prior to talking about any complications with metabolic surgery, is metabolic surgery is the most effective mode of treatment of obesity. And this is data from the Swedish obesity subject study. And what they did is that they took these patients who have had metabolic surgery and followed them up for years. We have data now up to more than 15 years of these individuals that have had metabolic surgery. You will see here there are some of the older surgeries that are no longer done, like the vertical banded gastroplasty that has fallen out of favor a while ago, but you'll see gastric bypass banding. This is prior to the birth of sleeve gastrectomy, and you'll see them all compared to control. Patients who undergo metabolic surgery lose weight, their obesity is treated, and they maintain the weight that they have lost. So it is an effective mode of treatment. I will not talk about the benefits of metabolic surgery today because this is not the talk. But we have to put in mind that these are life-saving surgeries. We have data now on cancer prevention with these surgeries. We have data on remission of other diseases with these surgeries. We also do have data on increased life expectancy by about 6.1 years after people have had this surgery. So yes, it is a very effective mode of treatment. And although I am obesity medicine, it is important to mention that it is also the most cost-effective method of treatment. It's not only effective in its work, but it's very cost-effective when we look at it. At least now, Probably in 10 years, not so much, but at least now in the current stage, it is cost effective. But surgery does not come without its complications. And unfortunately, what I see as an endocrinologist and as an obesity medicine consultant, I see that physicians do not like to deal with patients who have had bariatric surgery. When they see these patients, especially when they see post-bariatric surgery, hypoglycemia, the topic that I'm going to be talking about today, we see that these physicians actually are scared. They don't like to see these patients. They really don't like to deal with them. And they just give surgery a bad name because of this very small percentage of patients that are developing these complications. And when I come to ask myself, why is this happening? Is it because our physicians, our endocrinologists, our internists, our family physicians are less familiar with the anatomy of metabolic surgery? As Dr. Abu Khater showed you, he showed you that there are different ways of doing surgery. But Dr. Mohammed Al-Na'mi also showed you prior to that there are so many different variations of our surgeries that it's really hard to keep up with the surgeons, because every day a surgeon's going to come up with a new way of doing things. And when we don't know what the anatomy is, it's really hard for us to understand how to fix it. There's also a lack of strong understanding of the physiology that happens after surgery. I still meet physicians that think that surgery works because the stomach is smaller. And when I tell them this has nothing to do with how surgery works, you see that they are shocked and they don't understand what exactly has gone on with surgery. So just in the region here, we do a number of types of surgery. We do the adjustable gastric banding, which is falling out of favor. We do, Dr. Abu Khater just showed you a surgery where he was removing it because it's really not a good surgery. We do vertical sleeve gastrectomy. This is the most commonly surgery done not only here in the region, but around the world. We do Roux-en-Y gastric bypass. We do one anastomosis gastric bypass, what is wrongly referred to as a mini gastric bypass, because I can tell you, not only me, even the surgeons will tell you there's nothing mini about a mini gastric bypass. And we do the variations of the surgeries, just as the SADIs that Dr. Al-Na'mi was talking about earlier today. And it's important to know that a number of these surgeries have actually weight-independent metabolic benefits. And this will bring me into the post-bariatric surgery hypoglycemia. So that means that their benefits are not related to the weight loss that happens after surgery. And the most common example here is when we talk about diabetes. Patients who undergo surgery will have their diabetes go into remission on the day of surgery. They don't have to lose a single pound or a single kilogram for their diabetes to get better. So when we talk about post-bariatric hypoglycemia, it is really important to talk about definitions, because I do find a lot of physicians referring to it as dumping syndrome. Dumping syndrome is not post-bariatric surgery hypoglycemia. It is a symptom occurs in the first hour after meals, and it results in the rapid emptying of food into the small bowel, causing abdominal pain, sweating, dizziness, really the patient feeling really bad. But when you measure their blood sugars, they're completely normal. So that is dumping. What we're going to be talking about today is the post-bariatric surgery hypoglycemia, and this is really a condition that is characterized by a real hypoglycemic symptoms occurring about 1 to 3 hours after a meal, so it's postprandial, and it's accompanied by low plasma glucose that is documented, and it is associated with hyperinsulinemia and drop in glucose levels. Some people refer this as a late quote-unquote dumping. I do not like to refer to late dumping. Dumping is one thing, hypoglycemia is another thing. Mechanisms of both diseases are very, very different. How common is it? Really, it is unknown, because what we are seeing in our clinics are those patients with those severe forms of hypoglycemia. So we are thinking that it is an underdiagnosed problem. When you look at data from CGMs, it suggests that it can occur up to 55% of patients after sleeve gastrectomy and up to 75% of patients after Roux-en-Y gastric bypass. But we know that most of those patients actually have asymptomatic hypoglycemia, and that's why we are detecting them by CGMs. What we are seeing again in the clinics are those who are symptomatic. The worse the symptoms, the most likely the patient is going to show up in the clinic. How do we diagnose? History is the key. Again, it breaks my heart when I see a lot of history where endocrinologists, physicians, internists, family physicians are not taking the surgical history. They don't know the exact type of surgery. Is it a sleeve versus a Roux-en-Y gastric bypass? Is it a SADIES? Is it a one anastomosis gastric bypass? When did the patient have surgery? Was it 1 year ago? Was it 5 years ago? Was it 17 years ago? It makes a difference. What is the nadir? What was the lowest weight the patient has gone after surgery? Is the patient now, is it a successful surgery, or does patient have relapse? These are all important information that we have to know. How much is the total body weight loss as of today? Post-surgery. We no longer use excess body weight loss. I know the surgeons like it. Hopefully after the IFSO consensus that is going to come out in a few months, we will be getting rid of excess body weight loss and really just sticking to total body weight losses, which we as internists have understood for a very, very long time. Documented hypoglycemia is very important. So I do not see patients in my clinic unless they bring in a paper with documented hypoglycemia. If they don't get it, then they don't get seen. Because there's a lot of patients that actually get referred because of dumping syndrome, but they do not have hypoglycemia at all. Timing of the hypoglycemia is very important. Is it postprandial versus fasting? In my career, I have seen 2 insulinomas that have been labeled as post-bariatric surgery hypoglycemia. Until we saw them, it was actually an insulinoma because nobody bothered to figure out that the hypoglycemia was happening in the fasting state rather than the postprandial state. And most importantly, Whipple's triad. Patients will have symptoms of hypoglycemia. They will have documented hypoglycemia. They will take something with carbohydrates, and the hypoglycemia will get better. If they have the threesome, then that is it. Those 3 point to a Whipple's triad. There are some questionnaires out there, such as the 6-stat system and the dumping syndrome rating scale. They take into account, it is a scoring system. It's a very simple questionnaire that you can find even online and give it to your patients. You can easily even turn it into Arabic and validate it. It's easily, because it looks at symptoms like it's dizziness, palpitations, sweating. So, and if a patient scores 7 or above, it becomes a very big question. I tend to actually just include that in my history taking, and instead of just giving the patient a questionnaire, because we do give a lot of our patients other questionnaires such as obstructive sleep apnea questionnaires, PHQ-9s, and binge eating questionnaires, so I save them from that and just ask that when I have to. The mixed meal test, a gold standard of seeing these patients, and remember it's a mixed meal, never an oral glucose tolerance test. People who have bariatric surgery will always have a positive glucose tolerance test. That's the nature of the disease. So we do not do oral glucose tolerance tests for patients who have had bariatric surgery. And then honestly, the best thing that if you have access to, I would highly recommend to use is continuous glucose monitoring. You can give these devices to patients. You can have a couple of devices in your clinic and just give them to the patients for a week or 10 days. They bring them back, you have the diagnosis, wonderful. You'll have all the drops, when they happened, relation to food, and it's really easy. I tend to use Dexcom, but you know, it's what you have. So what happens? So it's really important to understand, because when you do those mixed meal tests, you have to understand what's happening with these patients who undergo metabolic surgery. And I hope this is a clicker that actually works. Maybe yes, maybe no, we will see. No, we're not lucky. I don't think it works on the screen. So what happens here is you can see here in the black line, those are the patients that have hypoglycemia post-Roux-en-Y gastric bypass. And the gray one, those are the patients, the control, who do not have surgery, who do not have hypoglycemia. And then the dotted line are the ones who have had surgery but never developed hypoglycemia. And it's really important to see that everybody post-bariatric surgery will have an excursion, as you can see on the right side, in both their GLP-1, the hormone that actually raises insulin, one of the hormones that raises insulin in the body, and their insulin levels. So this is normal. So everyone is going to have high C-peptide, high insulin levels. So if you see that, if it is not associated with real hypoglycemia, this is not post-bariatric surgery hypoglycemia. You can exclude that. That is the normal. And it's important to see the normal in order to be able to interpret those mixed meal testing challenges. And what happens is, because you get that fast emptying from the stomach to the jejunum and then the ileum, you get these hormones to go up really fast, and then you get that insulin to go up really fast. Some patients, the patients who develop hypoglycemia, will just have higher excursions of those hormones and therefore will develop the hypoglycemia. Others won't. Why? We do not know. We still do not know. This is just what a CGM would look like. You would put it, you will see that the patient is having a meal, you'll see the excursion after the meal in sugar, and then you'll see the rapid drop after the normal. This is really diagnostic, and as I said, if you have CGMs, it's going to make your life so much easier in diagnosing these patients. Sometimes, in very rare cases, I give these to patients who have really life-threatening hypoglycemia to give them alarms and let them know before these things happen. CGMs versus mixed meal, which is better? This is an old study done by Mary Elizabeth Patty at the Brigham with a group with us at Harvard when we used to work together. And what she did, she compared, this is really old, this is about 2011, she compared CGMs at the time with MMTs, and what she found that they had actually greater sensitivity and greater specificity than MMTs. Now, this was in the old days. We have better CGMs right now, so I think that we're going to have even higher sensitivities and specificities. I still use MMTs in my practice when I cannot get the CGMs, and I would still highly recommend depending on them if you have them. How about treatment? And I'm going to shorten this as much as I can just because I've been given a short time to give this talk. Nutritional management is key. More than 90% of your patients will get better after nutritional management. Again, it blows my mind away that a lot of our patients come in and they are advised to do frequent meals. Frequent meals is not part of treatment of post-bariatric surgery hypoglycemia. Frequent meals are just going to make your patients gain more weight, and they'll not know what to eat. So what you end up doing is really educate them about the type of food they're eating. So it's really complex carbohydrate, avoid simple carbohydrates. Simply, if you even go on Google and just write low glycemic foods, you'll get a sheet. You can get it even in Arabic. And you can just hand it to the patient in the first visit and then send it to the nutritionist. For the surgeons who are sitting here today, I would advise you to have your nutritionist do bariatric surgery courses online. And so, because a lot of our nutritionists are not trained, they really don't know what to do. And this is a challenge that we have when we deal with our dietitians. We have very, very good dietitians, but they're not trained in bariatric surgery care per se, so they don't know how to do this as well. Complete avoidance of carbohydrates is never, never, never the answer. We tell our patients to eat carbs because our bodies need carbs. Just choose the right carbs. And if you're going to have simple carbs, then make sure that you have them with protein or with fats, because that's going to slow and delay the emptying to the intestines, and then you avoid those surges in your incretins. And if you avoid surges in incretins, you avoid post-bariatric surgery hypoglycemia. Always manage with a dietitian, and don't give the patient an appointment with a dietitian and then give a patient the appointment 3 months later. What should ideally happen is the dietitian should see the patient first, see them again in about a couple of weeks with a food diary, and then adjust the meals as needed, and then bring them back again as needed to adjust. Other treatment modalities are alpha-glucosidase inhibitors, acarbose, calcium channel blockers. This is really good for those women who are pregnant, because all other drugs on this list are contraindicated in pregnancy, except for calcium channel blockers. So I tend to use them a lot in our patients who are pregnant. Diazoxide in some patients, somatostatin analogs, either octreotide, lanreotide, paseriotide. I tend to prefer paseriotide. I tend to be lucky at King Fahd Medical City and have access to it. If you do, gastrostomy tubes are a very last resort. The whole idea of using a gastrostomy tube is if you cannot fix it, then you can just put a feeding tube and just bypass that area where you get the incretins, and the problem will be completely solved. Actually, in my career, I have never ever had to use this modality, but it is mentioned. I'm just going to show briefly, these are the studies on acarbose, really not much if you can see, and those studies are not randomized control trials. We really don't have very high quality on them. I tend to give them to my patients at 50 milligrams and just tell them, you know what, if the dietitians fail, then if you need it, use it on a PRN method. If you're going out to a restaurant or so, pop a pill and you'll be fine. GLP receptor agonists, again, this may seem counterintuitive because I was talking about a surge in GLP-1 and then I'm giving extra GLP-1. People don't tend to understand why this works, but the reason these work is because we get two things. We get the delayed gastric emptying, A. The second thing, the thing that we don't want is that surge in GLP-1 and incretins. When you give a continuous dose of GLP-1, you get a more stable level in the blood, and that's why you avoid the surges and you avoid the hyperinsulinemia that happens. So that is thought to be the theory behind why these work. Somatostatin analogs, as I said, again, no randomized control trials used here and there. You will see if all else fails. Always I prefer the use of the long-acting ones rather than the short-acting ones, just because they're more convenient for the patient. But use whatever you have. Again, I use pasireotide. If the short-acting, I use up to 0.6 milligrams twice a day, or about 40 milligrams of the longer-acting one, Signifor. And this is just a schematic, just looking at it. You can find this at JCAM. 2018, Mary Elizabeth Patty did just a simple review of how to look at these patients, who to diagnose, who to label as post-bariatric surgery hypoglycemia and who not to label, and how to go about treating them. And if you can see here, she really mentions nutritional intervention, and acarbose doesn't go a lot into the other details. I'll end my talk here because it is a limited talk, and I'll be happy to take any questions if anyone wants to ask me. Thank you so much.
Dr. Nasreen, nice, interesting lecture. Can we listen a question from, can you sit and we'll call the other, please. Dr. Prof. Mohammed Al-Na'mi, and Prof. Khalid is here. Okay. Okay. Prof. Al-Na'mi, Dr. Nasreen, and me. If you have a questions, please, we are ready to hear from you. Any question from audience? تفضل دكتور.
Thank you so much for all the speakers for the elegant presentation. My name is Sulaiman Al-Sheikh. I'm a bariatric surgeon in the northern border. One question to Dr. Abu Khatir. You know the cost effectiveness is a challenge behind robotic surgery as to be widely available. So do you think this is now solved as a challenge, the outcome of doing bariatric surgery by robotic device, by laparoscope? Is it any change in the major issue, which is the cost effectiveness, to be available widely?
Yes, thank you, Dr. Sheikh. I think your question answered. We have done in our society in bariatric surgery, we have done a webinar. And in that webinar, we discussed the cost. Cost was done in USA. There's a bariatric surgeon, his name Ahmed Arif. He's an American surgeon. He did 4,500 cases. He compared the laparoscopy with and robotic. The cost was less. And I believe in the coming things, because there are many robotic company in the area. Many, I will not mention names, but starting a lot of robotic company. This will make the things cheaper, sure. Maybe in our country here it's more costly, but I think overall cost is less compared with laparoscope, because instrument going to be cheaper because there is many companies they will, but according to that American surgeon, the cost is less according, he did for around, I think, 4,500 cases bariatric surgery. I can share with you the presentation.
Thank you.
Thank you.
The question to Prof. Na'mi. our leader in the bariatric surgery society and practice. You know, the most common primary procedure is sleeve gastrectomy worldwide and here. And this is affected here in Saudi Arabia mainly, and this is really, we should address it by the patient choice. Still, we have a resistance to have other options. And if we go to your recommendation for use it as SADI-S as a primary procedure, we have to have really dedicated work to convince the population to accept other modality of primary surgery for the huge problem of obesity. What's your comment on that?
Thank you very much for this excellent question. Thank you for reminding me about this issue, because I missed to mention it. Actually, we encountered patients who refuses SADI. They say, do me sleeve, that's all what I need. So we finally came to agreement with those patients who are refusing that we will do sleeve, but I will tell you from now that it will not be enough. You will eventually need SADI at 1 or 2 years later as a second stage. So we come with an agreement on that. So this is my answer to those patients who are refusing. But I will try to convince them not to do 2 stages, to do one stage procedure. And those who are not compliant, you cannot predict a good follow-up and education. Yes, I can do them 2 stages.
Okay, thank you. Dr. Isam, you have a question?
Just a comment regarding the robotic bariatric surgery. When we were starting in Cleveland Clinic during my fellowship, the main concern was the cost. So we did a data analysis and it was carried out, but unfortunately we were not able to publish it because of the numbers and the financial issue. But we approve it to the administration of Cleveland Clinic that it is comparable to the same price of the laparoscopic cases if you eliminate the cost of the machine itself. But the machine itself, it will pay itself by the time, especially if it's being used by other specialty. And this is another concern and advantage of the presence of the robotic surgery. It's not only for bariatric, it can be used by all other specialty from all other general and subspecialty and general surgery. So I think it's going to be an era after some time.
Thank you, Dr. Hassan, for mentioning this point, because a lot of surgeons start arguing with you, it's costly and this, but really I consider it this a future surgery and we should go and catch it, otherwise we'll be too late. The cost, I believe, as Dr. Hassan said, it will be less cheaper. You know, many companies, competition will be more. So I think it will be cheaper. Some companies now selling the machine freely. I will not mention company names, and it till you just take the instrument with us. So this is another cost. Like some new company now, they came to us and they said, we'll give you the machine freely, but take our instruments. So this is another point, Dr. Isam. Thank you.
Also, another concern is the robotic is time consuming. But as you mentioned, with the learning curve and the more experience you are, the less time you will take. And you have mentioned that...
It happened with our center. And it's actually, it's written in literature.
Yes.
And the study shows that in the end, you will have even less time than laparoscope. But you need to have a trained team. Any other question, please, to Dr. Nasreen or...
In our data, by 20 case of number, we publish it and we present it in 2013. We minimize the docking time and the preparation for the robotic time to 20 minutes.
Yes.
So it was, yes, initially taking longer time. By the time we reach number 20 case, we already dropped down the timing to 20 minutes.
Sure, it's true. Thank you, Sam. Any other question? تفضل دكتور. جزاك الله خير.
Assalamu alaikum.
Salam.
My question for Dr. Nasreen. I am Dr. Ibrahim Al-Maghauri, physician consultant lab, Ministry of Health. I ask about what is the difference between post-bariatric hypoglycemia and postprandial hypoglycemia.
Post-bariatric surgery hypoglycemia and postprandial hypoglycemia?
Yes, the difference between both.
So, post-bariatric hypoglycemia, bariatric surgery hypoglycemia.
Is it the same? It is the same mechanism?
Usually happens postprandially, because that is the mechanism of how it happens. You'll find some people that do complain of some fasting hypoglycemia that have had bariatric surgery in the past, but most likely those patients are going to come with you with postprandial hypoglycemia. So you will see that it's happening really postprandially, yes. And that's why we treat it really nutritionally. Once they change the way they eat, they get that less incretin effect and the less hyperinsulinemia that they get. So it's usually postprandial hyperinsulinemic, and there's hypoglycemia with it.
Is the cause insulin overshot in both cases? Insulin overshot?
In post-bariatric surgery hypoglycemia, yes, it is a hyperinsulinemic status. So yes, you will have increases in insulin, increases in C-peptides, and increases in GLP-1 that you can see. We haven't measured other hormones. We're expecting more than GLP-1. We're expecting all the incretins to be increased post-bariatric surgery.
Okay, thank you very much.
Okay, thank you, Prof, and thank you, Dr. Nasreen. Thank you, Dr. Mohammed. We will have the last talk for this session by Dr. Hani Badahdah. He is a consultant foot and ankle surgeon, and he will talk the last complication in foot and ankle. Welcome, Dr. Hani, and thank you, Prof, and Dr. Nasreen. Thank you.
I think most of you will be wondering why foot and ankle is involved in obesity and diabetes topics. I think if you have an issue in your feet and you have pain, you will gain weight and you will not do exercise and you will not be able to go to the gym and lose your weight. So if we pay more attention to the patient feet and their pathology and their deformity, we'll appreciate that the type of the exercise and activity they can do in their life, and then also we can give them exact exercise to do based on their foot shape and deformity. So obesity, as we know, it's a major risk factor for multiple disease. One of this disease is a foot and ankle pathologies, and sometimes obesity leads to some foot deformities and foot pathologies. And you will see in the next few slides some of the foot and ankles related issues to obesity. Obesity-related symptoms in the feet, I think some of you experience some of these issues: forefoot pain, plantar fasciitis, lower extremity edema, stress fracture, foot deformities, pressure ulcers, and diabetic foot complications. As you know, obesity can lead to type 2 diabetes, and then eventually they will end up with the diabetic foot complications. Also, obesity-related problems to the ankles include ankle pain, Achilles tendinopathy, risk of ankle sprain, and also swelling of the both lower extremity and posterior tibial tendonitis or dysfunction. As you can see in these pictures, if you can see the left foot, the patient, she had severe pronation deformity with a posterior tibialis tendon dysfunction. And also you can see in the other pictures, the patient, she has flattening of the arch of the foot, which has happened due to obesity. It's called acquired flat foot. The patient, she was not born with a flat foot. She acquired this flat foot due to obesity. As we know, the first line of treatment for obesity, lifestyle modification, if you tell this patient to go and walk and do some exercise and go to the gym, believe me, after 1 week, the patient will come back to you with a severe foot pain and they will stop doing exercise and they will not lose weight. If you don't appreciate the foot pathologies and we correct the deformity, the patient will not be able to practice their exercise and sport activity. Another examples of obese patient with a limited mobility, they develop lower extremity edema and ulcerations, and we have to appreciate the reason of some of the lower limb edema is not related to cardiac, not related to kidney disease, but it's related to the obesity and low mobility. Diabetes, so I spoke about obesity, diabetes, and then I will combine diabetes and obesity, foot and ankle pathologies. As we know, diabetes is a big issue, but is one of the major leading cause of foot and ankle disorders and deformity. As we know, a diabetic foot complication is one of the neglected and topics in most of the conference, and also in the real life, most of the surgeons, they don't like to take care of the diabetic foot because it's very complicated. Risk of foot and ankle problems in diabetic patient is higher in comparison to non-diabetic. Increased risk of foot disorder in diabetic patient related to the peripheral neuropathy, peripheral vascular disease, and their multiple comorbidities. As you can see, and well known for all of you, this is an example of the patient with the diabetes. They come with this type of wounds because of uncontrolled diabetes and neglected of foot care system and prevention system, and then the patient will end up with amputation and this type of gangrene and wounds. Obesity and diabetes. Obesity by itself is a risk factor. Diabetes is another risk factor. Imagine you combine both risk factors, so you will have higher risk of foot and ankle pathology with high risk of disability and low mobility for this patient. So consider higher risk group in regard foot and ankle pathology with the risk of complications. Diabetic foot complication is more complicated in obese patients. When we have obese patients, it's very hard for us to decide regarding surgical treatment because risk of failure is very high. Risk of complication is very high in obese patients. Management of diabetic foot complication in obese patient is more challenge because they have lower limb extremity edema. So edema sometimes delay our wound healing. A risk of surgery failure, we've done a lot of surgery in diabetic patient and obese patient, and I found one of the big risk factor of failure is the patient weight and the obesity. And also risk of post-operative complication is higher in diabetic and obese patients because of the lower extremity edema and risk of delay wound healing in this type of patients. This is an example of patient with diabetes and obesity. Imagine how can you let this patient do some exercise and lifestyle modification with this type of deformity. So in order to let the patient lose weight, you have to fix and manage his foot and ankle pathology. Another example of diabetes and obesity issues, this patient is an obese with a low mobility. He developed pressure ulcer on the heel. This is a very complicated. It took us about almost 7 to 8 months to manage this patient with a lot of cost. We have to revascularize this patient and do a lot of surgery in order to save the patient limb and let him start walk on his feet. Prevention and management, lifestyle modification is really important. Well management of diabetes by endocrinologists or diabetologists. Management of obesity, either conservative or surgical. Early identification and management of foot and ankle disorder will expedite the recovery. I've noticed some of the family medicine or general practitioner or endocrinology or family or diabetologists recommend the patient to walk without giving them the recommendation to use the supportive shoes or orthotics or good insoles. If you let the patient walk with the bad quality shoes, they will end up with a plantar fasciitis. And if you don't address this at the earlier time, the patient will end up with the chronic heel pain and will not do any kind of exercise. And also, if you notice, most of the patients, they get excited. They go to the gym the first week. They start to use the treadmill. And the next week, will end up with a stress fracture in the calcaneus or a stress fracture on their feet. So remember, start with a gradual exercise, gradual increase in the sport activity to avoid overuse injuries. Correction of biomechanical fault, as you can see the pictures on the top, you see the patient with the orthotic, you see how the orthotics correct the deformity on the other foot in comparison to the foot without the orthotics. The picture in the bottom, you see the patient with the pronation deformity and pes planus deformity. You see it's not just affecting the foot, it's affecting the knee and the pelvis and the back and the neck of the patient. So we have to appreciate and understand the biomechanical fault to improve the patient foot and ankle function and walking ability. So remember again, foot is really important. You cannot walk, you cannot do exercise without address foot and ankle pathology. This concludes my presentation. Thank you so much.
Thank you, Dr. Hani. For the time, we would like to have you for 1 or 2 questions before Dr. Hani will leave.
Thank you, Dr. Hani, for this valuable information. I would like to ask if you include this service in each bariatric center, because as you mentioned, it's part of the treatment and rehabilitation of those people. So are you considering this in various centers of obesity?
It's a good idea, Dr. Wallahi. And when I was doing my presentation, I was thinking, why not include it in a part of the bariatric surgery or the Center of Obesity and Diabetes? We started to include this service in all the diabetic centers in Saudi Arabia under Ministry of Health, but we have to think about it to include this service in any kind of bariatric centers. I think I noticed most of the patient who does who goes to the bariatric surgeon, they recommend them to walk. But the patient, they have issue with their feet. So I tell the patient, you cannot walk with this type of deformity. You cannot do the surgery. Tell your surgeon, you cannot do the surgery until we fix your feet. After we fix your feet, then you can do your surgery. Because I think you guys recommend the patient to walk after the surgery, right? As a part of the treatment. So if the patient, they have feet problem, they will affect your treatment. Even after the surgery, the patient will not be able to walk, they were not able to exercise. Also, the issue with the patient, they get excited when you tell them, do some kind of exercise. They go to the gym, there is no professional trainer there. So when they start to jump on the treadmill, they start to develop heel pain. They don't know about their foot issues. They have pes planus or flat feet. They will have pain and they will stop doing the exercise. If we understand the foot shape, the foot biomechanic, and we give them a good support, there is a conservative and surgical treatment, but we like to go with the conservative most of the time. So if we put the patient in a good orthotics or good insoles and good shoes which fit the patient foot, that will help you guys to improve your outcome for your surgery. Thank you for your comment.
I have another comment. Thank you, Dr. Hani, for to the point of rehabilitation. You see some patient, the one you showed in your presentation, sorry to go back to him because you mentioned the point of rehabilitation and foot and other things. We have patient cannot walk, the super obese patient, the BMI above 100, and they are not small cases, they are a lot. You said the city of Prince Sultan City, Rehabilitation City, they accept these patients. But sometimes patient has no approach to the city. And so we have some super obese patient and they need a very extensive rehabilitation program. They cannot walk, they are at all, they cannot walk, and they are super obese. They have lymphedema, they have, and you show us very nice example. Such patient, if you admit them in our hospital, they are not, I mean, even tertiary hospitals, they are not able to manage these patients. And you cannot operate them immediately. Unfortunately, I have seen presentation in some conference, they have a special rehabilitation building connected to the hospital like housing. Would have nurses and all type of rehabilitation. They build their patient for 6 months or more. So in your experience, Dr. Prof. Nami, what do you think the important period are in Kingdom Data Centers can manage these patients before we operate them? It's not good to go immediately and do a very extensive surgery, whatever, and in the end, the mortality is high or the comorbidities. Thank you.
Definitely, those patients need preoperative rehabilitation that is decided by a team, including dietitian, internal medicine, physiotherapy, and multidisciplinary team who will decide the plan, the preoperative rehabilitative plan. And this plan could range from 2 weeks minimum up to 2 months. The patient I showed you took 2 months to be ready and fit for surgery. Because from the first glance at this patient, the anesthetist won't agree anesthetizing those patients at all. But when they loses at least 50 kilograms from this rehabilitative.
If you keep them in 2 months in a hospital, tertiary hospital, there is no specific bed for them. So you need a special rehabilitation hospital.
Exactly, exactly.
So how we can track these patients? Which
Yeah,
hospital?
actually, Sultan
issue,
Humanitarian City has the capability of accommodating a good number of those patients. However, there is a logistics problems for transferring those patients. Who will fund them? I just received a call this morning from Hafr al-Batin. There is a patient whom recommended such management. And the problem, no hospital is accepting them in the Ministry of Health. And there is no approval for them to be treated in Prince Sultan. He said how much it will cost so I can pay from my own pocket. So it's very costly, really. And we should have a system of collaboration to refer such patient to Prince Sultan for rehabilitation that can be done either totally in Prince Sultan Humanitarian City or partially in MOH, and we do the surgery there and the post-operative rehabilitation.
I think we need such cooperation. And this should be discussed at the end of this conference. I think one of the recommendations should mention it to our huge patient. We have a problem. This patient died before receiving the service, or he will go and complain. It will come through some orders.
Exactly.
No, we don't want it like. We want a smooth. Let's consider this one of the recommendation in the end of this conference, and we'll discuss it with Dr. Abdullah Suhaimi. Maybe he will support us in this point. Thank you. Thank you very much.
Thank you.
One more comment. These patients, especially the obese patients who are in the bed for a long time, they come with the bed sores. So this is another challenge for you guys and for us. So this patient, they go for sepsis with the bed sores infection. That's the patient I show you in the picture. He has a pressure ulcer on the heel and it was neglected, and he's obese, is unable to walk. So this patient, he could lose his leg. But, finally we catch it. So I think we have to address, I think, as you said, Professor, multidisciplinary team, I think, is the key for manage this type of cases, not just do the surgery and let the patient go, because risk of failure and risk of recurrence is high, and the patient will gain weight after a period of time. I think multidisciplinary team is the key.
Thank you, Prof, and thank you, Doctor. And we agree that multidisciplinary team is the management for diabetes and the obesity. We would like to end our session by a lecture by the GSK for shingle prevention in a patient with diabetes. Welcome, GSK. Thank you.
Assalamu alaikum wa rahmatullah. First of all, thank you very much for having me. My name is Mustafa Allam, and I work as GSK's Vaccines Medical Affairs Manager. And in the coming 15 minutes or so, I'll be discussing the topic of herpes zoster prevention in adults with diabetes mellitus. So before I take this any further, let's go through our agenda. First, we'll be going through a very quick refresher on what is shingles disease and why do we need to protect patients from it. Then we will discuss the association between diabetes mellitus and the risk of shingles infection. Third, we'll be discussing a new vaccine recently introduced to the Ministry of Health, which is called Shingrix, to prevent shingles. We'll go through its safety and efficacy. And lastly, we will conclude with some recommendations on how you can incorporate it in your everyday clinical practice. So I think we all remember chicken pox. It's a very common infection, especially among children. It is caused by a virus called varicella zoster virus. It's known to be very contagious. Transmission is usually through droplet infection or skin-to-skin contact. And this virus is one of the herpes family of viruses, they have the ability to establish latency. So our immune system cannot get completely rid of this virus. Rather, this virus can hide itself inside the neuronal ganglia in our bodies, and it can linger there for long times, waiting for an opportunity to re-emerge once again, and this time it will be in a form of a new disease, not chickenpox. This time it's called herpes zoster or shingles or al-hizam al-nari. This time it's much more dangerous and it can present with many serious complications. And according to some serological testing, we're using PCR, we found data from all over the world that more than 90% of adults around the globe are carriers to the varicella zoster virus. So it is safe to assume that every adult patient you see in your clinic, they have this virus in their systems, and therefore it is only a matter of time until 1 in every 3 persons could develop shingles at least once in their lifetime. So why is it important to know about this and why it's important to prevent it? Simply because it is dangerous. Usually, shingles is presented as acute phase. The presentation is very remarkable. I think all of us have seen it before. It is a unilateral vesicular rash. It could be painful, and sometimes the pain is very, very painful, and patients will describe this as burning or stabbing pain. What's even more serious, sometimes it is presented with complications. The most important one is known as post-herpetic neuralgia, which is a neuropathic pain that can last for a very long time, typically more than 3 months. And we have seen patients with post-herpetic neuralgia for more than 10 years or even 20 years with this life-debilitating pain. Another also common complication is known as herpes zoster ophthalmicus, which is eye involvement with this virus, and it can happen to almost 1/4 of the patients with shingles disease, and in some cases it can lead to vision loss. Other complications, and I think the most dangerous one, is disseminated disease, which when the virus can attack various organs inside the bodies, and sometimes it can be fatal. The recurrences have also been reported in up to 10% of the subjects, and of course, those subjects with immune compromising conditions are at even higher risks of the complications and other complications as well. And if we wanted to understand further about the pain that is caused by shingles, this graph will help us really to visualize it. This is coming from Miguel Pain Generic Questionnaire, which is a generic patient-reported questionnaire that allow us to compare different painful conditions reported by the patients themselves. On this side, we have some acute pain conditions, and here we have some chronic pain conditions. And when you look at herpes zoster pain reported by the patient, acute pain was found to be very, very painful, even higher than patients with labor pain. We look at chronic pain conditions, PHN, it has been topped only by fibromyalgia. So PHN was found to be more painful than chronic cancer pain and rheumatoid arthritis. And of course, you can only imagine this will have a strong toll on quality of life. This graph will tell you some examples on how patients suffer and what is the impact on their quality of life. And we'll take one example. You see that 64% of patients that have been infected with shingles have reported that they lost their ability to sleep because of this infection. And if you wanted to look at the incident, in this graph you can see the relationship between the incident rate ratio, represented by cases per 1,000 person years, and here we have age categorized in groups of tens. So at the earlier age groups, you will see that the incident rate is about 2 to 4 cases per 1,000 patient years, and the older people get, the higher the susceptibility to get the disease, up until we reach the age of 50, which seems to be the peak value. At the age of 50, the risk of herpes zoster really increased by several folds. You can see that now the risk is almost 6 to 8 cases per 1,000 patient years. The same also goes for the risk of PHN. The older people grow, the more the risk for PHN as well. And this is explained by a phenomenon known as age-related decline in immunity or immunosenescence. As many systems in our bodies, they tend to weaken over time, and the immune system is no different. So when we are first exposed to the varicella zoster virus during the primary infection of chickenpox, our bodies can elicit very strong cellular immune response that can suppress the infection after the recovery from chickenpox, and we will remain disease-free up until we reach a condition where our bodies fail to produce enough cellular immune cells against the varicella zoster virus, and there comes the shingles infection. This could happen either because of the normal process of aging, or it could have happen because decrease in immune systems, either because of an infection, condition, or treatment. So the main risk factor for developing shingles is age. The age of 50 alone will increase the risk of shingles by 30%, but I know that usually patients don't come presented with only one conditions. So these are some very common chronic conditions that you see in your clinic, and you can see how these conditions will add on to the risk of shingles. I will take only one example. Diabetes mellitus has been proven to be an independent risk factor to increase the risk of shingles, in addition to the age by 20 to 40%. So if you have a patient aging 50 or above, also having diabetes, the risk of shingles is extremely high. Also, the evidence is accumulating that patients with diabetes have higher risk of shingles, have higher risk of complications such as PHN, and when they do have PHN, those patients with diabetes and shingles, PHN is more severe and it lasts for longer. Typically, it lasts for up to 6 months compared to average of 3 months in patients with no diabetes. So Saudi Arabia, as you all know, we have a strong toll of diabetes in the country. Saudi has been ranked as top of the countries with diabetes, whether you look at Middle East countries or globally. There are currently around 7 million patients living with diabetes in Saudi Arabia, representing almost 18% of the population. And a recent study has found that 20% of patients with shingles in Saudi are presented with diabetes, giving us an idea about the association between diabetes and increased risk of shingles. And this is explained by multiple researches, but now we are understanding the relationship between hyperglycemia and immune system more and more with time, but now it is evident that elevated blood sugar has a suppressive effect on the immune system, and patients with diabetes have found to have less immune response against varicella zoster, and this is explained by hyperglycemia. And this will illustrate this observation that we see from this systematic review. So they looked at patients with herpes zoster infection, compared patients with diabetes to patients without diabetes, and you can see that the risk of herpes zoster is increased by several folds. Sometimes it reaches almost 3 times the risk for patients with diabetes compared to patients with no diabetes. Also, the relationship is continuous, so diabetes have bad effect, increasing the risk of shingles and its complication, and also shingles infection will worsen diabetes. And when they looked at patients with diabetes before and after getting the infection, they found that almost 1/4 of the patient will lose their glycemic control due to this infection. So the relationship is mutual. So what is this new vaccine we have? So the new vaccine is called Shingrix. It is a recombinant zoster vaccine. Recombinant means that we use DNA or RNA materials to produce proteins. So no need to get the virus and fraction it and purify it and all this process. We use DNA materials to produce these proteins. And we use an adjuvant system which will help elicit very strong immune response from this vaccine. When it comes to efficacy, it has been studied in several studies. I will give example of two of them, ZOE 50 and ZOE 70 studies. Both were published in the New England Journal of Medicine, years of 2016 and 17 respectively, with the aim to assess the clinical efficacy of this vaccine to prevent herpes zoster in patients or subjects aging 50 years or 70 years or above in the both studies. And as you can see from the first study, vaccine efficacy was found to be 97%, which is not a common thing to see among these older population, and this was maintained across different age groups. And when we look at the post hoc analysis for the pooled analysis from the both studies, we found that the vaccine efficacy remains above 90%, even in subjects aging 70 and 80 and above, which is again a very remarkable results to see in vaccines in this older population. Another important question, whether or not the vaccine efficacy will be affected by other chronic conditions such as cardiovascular or diabetes, and this post hoc analysis explained it or answered it that the vaccine efficacy was not affected by different chronic conditions, so that you can expect the same results, 2 minutes, even with chronic conditions. And the vaccine efficacy was found to linger more than 10 years. Up until now, we have data for 10 years, and the vaccine is still effective on those subjects. For safety and side effects, you could expect what you see in the normal vaccines, nothing really here new. The most reported ones are local side effects, and some systematic side effects are also expected, are listed here. And it's important to highlight that many recommendation bodies now recommend the use of RZV, the recombinant zoster vaccine, or Shingrix, for subjects aging 50 years or above. And this comes even more important for subjects with diabetes. So the USA CDC's ACIP recommends this with diabetic patients, and also the American Diabetes Association, they recommend the use of this vaccine for all diabetic patients aging 50 years or above. I will give this slide as a last slide, and if you wanted to implement this in your practice, we usually give the first dose, and then we can wait for 2 months, complete months, and then we can administer the second dose in a window from the end of month 2 to the end of 6 months. So you have 4 months window, you can give the second dose. Both doses are essentials, they are not booster dose, and are mandatory if you want to get the maximum efficacy of this vaccine, and it can be given with other vaccines as been proven by several studies. So we discussed shingles and how it is an old infection by chickenpox. Reactivation is a matter of time, especially in older population. We discussed the complication that could happen and how diabetes is increasing the risk of shingles disease. We discussed a new vaccine newly introduced in the Ministry of Health called Shingrix. It is administered and recommended to all subjects aging 50 years or above in a 2-dose regimen. Thank you very much, and I'm happy to take any questions.
Thank you, Doctor. If you have any question, you can ask now, or GSK, they are with us for 2 days, inshallah. And we hope, we say that the vaccine is available in all diabetic center and also available in some of the BHCs in MOH. Inshallah, if they want to expand in obesity center, we have the opportunity for that. Any question? Or you want to go to the prayer break? Okay, thank you, دكتور.
يعطيكم العافية، شكرا.
نشوفكم إن شاء الله على الساعة 2. حيكون بإذن الله حنبدأ السيشن اللي بعده. ناخذ البريك ونتقابل إن شاء الله على الساعة 2. شكرا لكم.
Good afternoon. السلام عليكم. الآن we are after بعد الغداء الجميع صاحي أكيد إن شاء الله. we'll start our presentation by the role of semaglutide in type 2 diabetes management by Dr. Hussein Raif. He's a consultant endocrinologist in King Faisal Specialist Hospital. We have the honor to
Assalamu alaikum. Good afternoon, everybody. And thank you, Mr. Chairman, for the introduction. Of course, the importance of GLP-1 in the field of diabetes is very obvious for us as diabetologists, and it has increased lately. It's very, of course, particular pertinent for this program today because it addresses not just diabetes, but the issue of obesity, which is part of the diabetes problem, and it's a very inherent issue with type 2 diabetes. But as we will see, GLP-1 has really changed the view for the management of diabetes quite a bit, as we will see in guidelines by different diabetes societies. So, of course, diabetes is a major issue, and does not just affect older people. So now, of course, we define young up to 65, so those who are a bit on the older age should feel good about this. It affects a lot of people in this age group. It's almost 500 million people globally are affected by diabetes. And we know for a while that diabetes is not an issue of hyperglycemia alone, but the major burden of diabetes is cardiovascular complications. Therefore, the approach of it, which has even been emphasized more and more, would be to attack different angles of the cardiovascular risk, including hyperglycemia, but also including dyslipidemia, weight issues, and hypertension and other factors that increase cardiovascular disease. If we talk about hyperglycemia per se, then also our understanding of the pathophysiology of diabetes, type 2 diabetes, has really expanded. We know it's not just impairment of insulin secretion and not just increase in insulin resistance, but in addition to those two major factors, it involves issue in the liver with increasing glucose output from the liver, which is indirectly related to insulin resistance. It may be or clearly related to obesity, which is in turn related to the appetite. Many can be responsible for by genetic factors and so on. So now we always seek an agent, an anti-hyperglycemic agent that might attack different angles of the pathophysiology. GLP-1 is one of those agents who can be really reliable in improving insulin secretion. We know it's a very strong anti-hyperglycemic agent, but also indirectly by increasing insulin secretion in relation to glucose and decreasing glucagon secretion, which is one of the pathophysiology of type 2 diabetes. It can decrease hepatic glucose output and improve glucose intake by the muscles and the cells, although it's not directly affecting insulin resistance. It also clearly decreases appetite, and therefore the weight loss we see with the use of GLP-1 is very particular. Now, for these reasons, and also for its effect on cardiovascular outcome and the renal outcome, which we'll be addressing briefly later on. The standards of care for diabetes management has really changed. The outlook is different now. So although we still lifestyle and maybe initiation of metformin, it's still very, very essential in the treatment of type 2 diabetes. We do focus on the phenotype of our patients. So those patients who have obesity, which are significant number of type 2 patients, we will choose agents that are more likely to not to increase weight and hopefully decrease weight, and GLP-1 would be a major or even first-line therapy for those patients. We try to minimize hypoglycemia, especially in elderly people and elderly patients or those with cardiovascular complications. And again, GLP-1, among others, like metformin and SGLT2 inhibitors, are favorite agents in this issue. But more important now is to assess the cardiovascular risk or the presence of cardiovascular disease in patients with type 2, because those patients now have clear indication to start specific agent that has proven to decrease cardiovascular risk burden in those patients. So those with established cardiovascular disease or very high risk for cardiovascular disease, GLP-1 comes as very favorite agent in addition to the lifestyle, exercise, and probably metformin. SGLT2 inhibitor is another agent that's very favorable. When it comes to heart failure, SGLT2 inhibitors usually should be a first-line agent. And in a CKD patient, SGLT2 inhibitor and likely GLP-1 also, those especially with proven efficacy against cardiovascular risk. So for those who may not be familiar with semaglutide, it is a GLP-1. This is the natural GLP-1 molecule. The problem with the endogenous GLP-1 is very short lasting. So by changing a couple of amino acid and by attaching to a fatty acid molecule, the molecule now, the GLP-1 molecule, could bind to albumin, and we can extend the half-life for as much as 1 week in the case of semaglutide. And this is why semaglutide, among other GLP-1, can be given on a weekly basis. As you know, the dosing usually starts with a lower dose to decrease the GI side effects. So starting with 0.5 and later to 0.5. And many times we have to go to the full dose of 1 milligram maintenance dose of semaglutide. Now, semaglutide, as other GLP-1 as well, was studied extremely well, and was studied with a phase 3 studies, as you see, called SUSTAIN program, in many, many different conditions. So they were studied as first-line agent versus sitagliptin, was added to a single agent, mostly metformin, was added to multiple oral agents, and compared to other comparators. There are almost all kind of comparison between semaglutide and other oral agent, or other even GLP-1, or even insulin, injectable insulin, basal or basal and brandial. In addition, the program included a study that looked in the cardiovascular and renal outcome, and there is also a study of post-marketing outcome to assess the safety of the product. So not to go in very details with these results, but to just summarize it, you can see that different studies, phase 3 studies, compared it to oral agent or to GLP-1, other GLP-1, or to insulin products. There was a wide range of baseline characteristics for those patients, including age between 53 and 59, HbA1c was not optimally controlled at baseline, so around 8 to 8.5. Different range of weight, as you see, although most of the patients were in the overweight to obese level. The duration of diabetes was also variable from 4 years and up to 13 years. So it's really wide spectrum of baseline characteristic. And in every study, semaglutide, whether used in the lower dose or the higher dose of 1 milligram or half milligram, proved to be not just efficacious in lowering HbA1c, but to be superior to all other oral agents or even GLP-1 agents when compared to exenatide, liraglutide, or dulaglutide, and also superior to basal insulin or basal insulin plus metformin. The magnitude of HbA1c decrease was 1.5 to 2% almost, which is considered quite high for any antihyperglycemic agent. In addition, and this might give it a little more relevance, especially for this symposium, its effect on body weight that was also superior to other GLP-1 and agent with an average decrease from 4 to 6 kilograms in those patients at different studies.
3 minutes.
Now, one of those studies, SUSTAIN-7, was to compare it with other weekly GLP-1, which is dulaglutide. And because of the time, we already touched on this. The HbA1c was superior using semaglutide. The body weight decrease was also superior. And also the responses, if you take the specific weight decrease, whether it's more than 5% or 10%, was more with semaglutide versus dulaglutide. So this is an agent that has proven to be very efficacious in terms of HbA1c improvement, diabetes control, but also beyond this to the weight issue. And also, as I mentioned, there is the particular effect of those agents, GLP-1, specifically semaglutide, on the cardiovascular outcome. So very quickly, SUSTAIN-6 addressed the cardiovascular outcome in patient on semaglutide versus placebo. And there was actually 24% decrease in the outcome of cardiovascular complications, which was the composite of cardiovascular death, non-fatal MI, and non-fatal stroke. If we take it specifically, the decrease was actually in the non-fatal MI by almost 26% and non-fatal stroke by almost 40%. The cardiovascular death was not significant in between the two groups. So, in summary, the primary outcome of cardiovascular death was down to by 26%, in addition to all the benefit mentioned to the semaglutide. Now, just briefly, when we switch from one GLP-1 to another, there is just general rule. If we're switching just from daily to weekly, we can do it immediately. We don't have to wait. If we switch from weekly to daily, we have to wait for the end of the duration of the last dose, which is usually a week or so. On the other hand, if you're switching a patient due to GI side effect, it's better than to wait for the side effect to resolve, and then you start from the lowest dose of the newer agent. However, if there is no side effects, you can switch from an equivalent dose. So as example, the equivalent dose of 0.5 semaglutide to dulaglutide is the 0.75, and the 1 is equivalent to 1.5. So you can switch directly without going to lower than higher dose, unless there's a GI side effect. Just 1 minute to mention that semaglutide also comes in an oral form, which is given on daily basis, not weekly basis. It was studied also significantly in a phase 3 studies. Without going into much details, the program called Pioneer, and again compare it to different oral agents, even compare it to insulin, and showed a very efficacious agent, which is the oral semaglutide, in lowering HbA1c and in decreasing the weight as well. So I will stop here, and thank you so much for your attention.
Thank you, Doctor. And we know that GLP is something precious for us and for the people who have either diabetes or obesity. Alhamdulillah, we thank that we have this medication nowadays. Thank you, Doctor. Do you have any question for the doctors? We can go for the next session. Our moderator is Dr. Khalid Sharif. He is a general surgery and bariatric surgery consultant.
We'll move to other session. Diabetes in pediatric. We'll start with Dr. Asim Al-Qurashi, consultant diabetologist and the medical director in the diabetic center. We can start.
هذا
Assalamu alaikum. Good evening, everybody. I want to express my thanks to the organization committee to invite me for this conference. My topic today about very important topic about overcoming therapeutic inertia in a diabetes care. I will talk about the definition of therapeutic inertia and its impact. I will discuss the reasons behind therapeutic inertia and explore the consequences for therapeutic inertia, highlight the importance of early intervention and proactive management, provide strategies and tools for overcoming the inertia,
and encourage the audience to consider their own practice to potential the therapeutic inertia. Actually, over 20 years, despite more technology, more education, and more than 40 new treatment options, the average of A1C for the person with the type 2 diabetes has not changed. In fact, the number of the patient with A1C above 9 have increased from 12.6 to 15.5%. The achievement of individualized target has declined from 70 to 64%, and the root of this problem is therapeutic inertia. Therapeutic inertia is a lack of timely adjustment to therapy when the patient treatment goals are not met. In a diabetes care, it means being slow to add or change the care plan if the patient A1C is too high. The care plan not include only medication, include medication, health checks, and diabetes education, nutrition, and exercise, emotional support if patient needed. The failure to initiate, intensify, or de-intensify the medication therapy when therapeutic goals are not met, despite we have a clear definition for every patient with appropriate target for A1C. We know the benefit of achievement target available. Effect therapies, we have many therapies available in our pharmacies. And we have guidelines, algorithm, protocol, it's available for everybody and it's free. All of these, still we have therapeutic inertia. And it's occur in all stages of the treatment for intensification. Therapeutic inertia, major contributor to the failure to meet glycemic goal, and it is failure to our success in management. It's present in all stages of management plan and in diabetes treatment. Actually, achieving early glycemic control has long benefits in the long term. And this showed in UKPDS trial in 1998, when showed there is a legacy effect for early management in the patient with a diabetes. It's lower A1C and glycemic burden, and a better maintenance of A1C control over time, long-term health outcome in the future, and lower risk of micro and macro cardiovascular complication. And we not forget the economic burden on the health system. This legacy first illustrated by the UKPDS prospective diabetes study in 1998, where the patient in the intensive treatment arm who achieved target goals, A1C below 7 in the first year, had significant reduction in micro and macro vascular complication in the 10 years follow-up the study, even though the difference A1C were lost over the time. Interestingly, follow-up the study showed that even though the difference in A1C were lost over time, the patient in initial intensive arm continued to have significant microvascular complication and significant reduction in cardiovascular complication. 24 reduction in microvascular complication and 15% reduction in myocardial infarction and 13% reduction in all cause of mortality, even if we lost the glycemic target over the time. Timeline on the screen show that substantial inertia exists in years, not in months. At each possible step, the patient therapeutic journey, the approach of wait and see, or treat until the medication failure. It is the enemy for our success in management. We are waiting for 7 years to add third medication. We are waiting for 7 years to add insulin for our patient. And we are waiting 3.7 years to add GLP-1 agonist. Treat to target, it is better. Put the target in the first and hit hard for your patient to create the legacy effect we are aiming for. When managing diabetes type 2, the time is really important. Legacy effect exists outside clinical trial. Managed care patient with a type 2 diabetes. Diabetes control during the first year after diagnosis. associated with the lower future risk of the diabetes complication. And this A1C in the cohort study, over 34,000 patients with a type 2 diabetes, managed care population. Patients were followed for 10 years, and they showed the patient above A1C 7 in the first year after diagnosis, they have risk for 20% mortality in the future. And the patient with the A1C above 8 in the first year after diagnosis, they have in the future 29% of macrovascular complication risk and 32% of all cause of mortality. Legacy effect, reduce diabetes-related cost. We are talking about money. There is retrospective claim analysis, more than 21,000 patients with type 2 diabetes and A1C above 7 followed up in 18 months. They show the patient took action to intensive therapy in the first 6 months. It's related with the costs were higher if there is no action taking. The patient with no action taking in the first 6 months was higher by 60% with the cost in the care system. Delaying treatment of 1 year increase clinical and economic burden. If they are waiting to treat our patient for 1 year, in the study they showed in the 13.4 million people with a type 2 diabetes, if they're still above target in above 9, can result in lost more than 13,000 lives and spend more than 7.3 United States dollars. Using electronic health record data, we can identify who are not achieving the target goals and understand why. Have they had A1C in the last 6 to 12 months? They have visit in the past 6 months? They have any change in the therapy in the last visit? The cause of therapeutic anorexia is multifactorial. It is patient-related or clinician and health provider related or health system or a buyer or industry. The most frequent cited contributor, when we'll speak about the clinician-related contributor and the patient with the diabetes as contributor and the system-related contributor. Clinician-related contributor, it's clinician-related contributor, it is because of the overwhelming of the requirement inside the clinic. And there is many patients outside waiting for. We're not empowering our team and not referral. We lost to put the target for our patient. We are fear of intensification. Therapeutic anorexia related contributor for a person with a diabetes, cost to access medication, poor insurance and coverage, limited understanding of the progression nature of the diabetes, and poor access to the education and nutrition, and poor communication with the physician and lost trust. System-related contributor due to fail to identify the patient with the high A1C, lack of transparency, not providing access to the education and nutrition, no team approach, insurance, medication, switching to downgrade if the patient reaches the target. This is the equation to know our patient if they have patient with therapeutic anorexia or not. This is the equation you use it to know you have patient with anorexia or not. This is an example. Time is very important. Empower team is very important. Neither is sufficient on their own. In the meta-analysis study, categorized by the primary type of intervention, there is a study published in 2021. There is screen 1,400 study and include 36 study, and they found that if we empower pharmacists and nurses, will be significant in the reduction A1C, and we avoid clinical inertia. The pharmacists and nurses and diabetic educator to initiate and intensify treatment independently, supported by appropriate guidelines. It's decrease and reduction of A1C. The nurses and diabetic educator up to 1.6%. The care management and patient education up to 1.2%. The pharmacist up to 0.9%, and the physician in the bottom 0.4%. Best practice action overcoming clinical inertia. We have to correct our clinician-related strategy to set clear goal for our patient, empower the team, and use technology, and develop and referral team clinician. We have to make the patient understand and recognize the progress of the disease. Let the patient share and decision making. Let the patient seek the education and nutrition as he needed, and let the patient available for technology to use it. System-related strategy. We have to identify our patient and support empower team, provide access to the services like education and nutrition, use technology in the office practices. Technology facilities evaluate management plan quickly. Early glycemic management save life, limbs, and sight. Save time and money for our patients. Save health care costs for our organization. In summary, clinical inertia is the enemy of therapeutic success in the patient care. Through the multifactorial approach, we are able to affect therapeutic inertia, and through organizational, educational, and training strategy, it will be possible to reduce this phenomenon and improve care outcome with significant impact on health outcome or reduction of complication and health costs of the diabetes. Thank you.
Thank you, Dr. Asim. Thank you. We will have the second talk in the question. We have the pleasure to have Prof. Basim Ibn Abbas. He's a consultant pediatrician. Welcome, Doctor, for your talk about pediatric. Thank you, Doctor. Welcome.
بسم الله الرحمن الرحيم. Good afternoon, ladies and gentlemen. I would like first to thank the organizing committee for their nice invitation for me, and also our moderators and the audience for having them today with me. I will be talking in the next 15 minutes about obesity in children, and I would like to talk briefly about the management of obesity among adolescents and children with obesity. The problem when we talk about obesity management among children and among adolescents, we don't have medications, drugs to treat these children and these adolescents. Recently, we have the liraglutide, which is approved above the age of 12 years. And we have also the semaglutide, which Dr. Hussein Raif talked about. Again, it is also approved above the age of 12 years among adolescents. But in kids below or before the age of 12 years, we don't have much to offer these children, apart from counseling and talking to them. Briefly, I would like to talk about the epidemiology. I'm sure that the audience knows this better than me, but generally speaking, we have almost 40 or more than 40 million children before the age of 5 years complaining of either overweight or obesity, and almost more than 350 million adolescents, children between the age of 5 and 19 years complaining of obesity. This is where we are in Saudi Arabia. We are in the middle. The prevalence of obesity around 15 to 20%. So it means that 15 to 20% of our kids are obese in Saudi Arabia. And I'm sure that talking about history, in the past, I mean 20 years back, we have two lines, by the way, here, the bottom two lines for boys and girls. The obesity was around maybe 10%. This is 25 years ago. And now we are talking about 20 or 20+% obese males and females. The upper two lines are talking about overweight. In the past, I mean 20 years back, the prevalence of overweight children is around 20%, and now we are talking about almost half of our kids are overweight. The good thing, I mean, the first step to treat anything is to recognize the problem. And the good thing is that obesity was recognized as a pandemic problem based on the European Association of Study of Obesity and based on WHO and also the Endocrine Society. The definition, we are following the same definitions like adults based on the BMI. We are defining and classifying obesity. So if the BMI above 30%, this is class 1 obesity. If it's above 35 kilogram per meter square, this is class 2 obesity. If it is above 40, this is class 3 obesity. And also we are using standard deviation, by the way, calling it plus 1, plus 2, plus 3 standard deviations. We are using both, actually. The etiology, briefly, this is the way we are classifying obesity. As you know, that the majority of causes are exogenous obesity. We call it polygenic or polygenetic obesity, representing the majority of obese children. But again, in our pediatrics, I mean, in pediatric clinics, I mean, we have genetic causes of obesity. In our hospital, at King Faisal Specialist Hospital, we are following a good number of children having genetic obesity with an onset below the age of 1 year or even 6 months. And there is a big list of syndromatic causes of obesity, like Bardet-Biedl syndrome, for example. We have a good number of these patients. And also we have other syndromes, including Cohen syndrome, for example, osteodystrophy, and others, Carpenter, for example. But also at King Faisal Specialist Hospital, by the way, we have families with what's called the MC4 receptor defects, for example. POMC, also we have cases with POMC as well. And also we have other genetic causes of obesity. But the problem, as I told you, we don't have medications to treat these patients, only counseling and trying to convince them to exercise more if they are all children and to eat less. The problem that we are receiving and accepting all cases with obesity, but the minority of them, they have endocrine problems. If you have a child who is short and obese, think about endocrine causes like growth hormone deficiency, like hypothyroidism, like Cushing syndrome, which only represent the minority of causes of obesity in general. Neurological problems, this include brain defect, for example, brain tumor, injury, irradiations, inflammations. This is we can group it under one umbrella. It's called hypothalamic obesity. But also we have drugs. And the most common cause of obesity in our pediatric clinics is steroid therapy, plus other medication, which is not common. Complications, I'm sure that you are familiar with complications related to the obesity, but before that, we have to remember and know that the majority of kids who are obese during childhood, they will continue to be obese later on. The majority of them, I mean 85% or even more, they will continue to have BMI above 30. 2/3 of them will have a BMI above 35, and maybe 1/3 of them, they will have a BMI above 40. The complications, you know, diabetes, obesity will affect diabetes, sleep apnea, liver fibrosis, cardiovascular. I'm sure the other speakers talked about also its psychological impact as well, and also its effect on the quality of life. This is the problem. The therapeutic options for obesity is so limited. We have only 2 medications, the liraglutide and semaglutide, and both were approved by the age of 12 years and above only. And this is the timeline. We are happy that we are moving forwards toward this timeline, and hopefully in the future we'll have these 2 medications approved for kids, I mean, before the age of 12 years. As Dr. Hussein Raif talked to you about the liraglutide, for example, it has a very short half-life, only 2 minutes, but by some amino acid modification, they prolong the half-life in liraglutide up to 13 hours, in semaglutide, as explained by Dr. Hussein Raif, up to 1 week. This is the main action of liraglutide or GLP in general. It makes you feel full, decreasing the hunger sensation. At the same time, it might improve also the insulin secretion and decreases the glucagon production. This is the first study. Based on this study, by the way, the liraglutide was approved for adolescents above the age of 12 years. And the study included only just limited number of children, about 250 children, and there were 2 arms of this study, placebo versus liraglutide, which is 3 milligram, and lasted for almost 1 year. And the primary endpoint to look at the BMI standard deviation, and of course there are other secondary endpoints, we'll talk about it, which is the proportion of children who lost 5% and more of their weight, or 10% or even more of their weight. So this is the first result, the change in the BMI based on standard deviation, and you can see the difference here. The difference maybe minus 0.25 standard deviation, and after stopping the medication. By the way, both arms, they were also on exercise plus diet therapy. After stopping the medication, placebo and liraglutide, the 2 arms or 2 group of children, they regained some of their weight. But even though the result was good in children who received liraglutide. If we are talking about the proportion of children who lost 5 and 10%, you can see the result here. The liraglutide group, almost half of them, they lost 5% of their weight. And if we look at the group of children who lost 10% of their weight, this is around 25%. This is the change in body weight expressed as kilograms. The liraglutide group, they lost 2.7 kilograms versus the placebo, who gained actually 2.5 kilograms. And again, after stopping the medication, there was a regain of weight to some extent in liraglutide group, and major regain of weight in the placebo group, up to 5 kilograms. The side effect, we talked about the side effects, almost comparable. The GI problems was more common, or were more common with the liraglutide group, but the good thing, it's only transient. And I mean, after a few weeks, almost the GI problems almost the same in 2 groups. So based on that, we concluded that the liraglutide 3 milligram was very helpful, plus the lifestyle modification in lowering the BMI standard deviation, and there were no major side effects getting out from the liraglutide. I would like just also briefly to talk about the semaglutide, which again was approved for adolescents above the age of 12 years, which is the 1 weekly medication. And the same thing here, limited number of patients were included in this trial, and the trial lasted for 1 or 1.5 years. The same target and the same primary and secondary endpoints. They looked at the percentage in change in the BMI, and also the proportion of children lost 5 and 10% of their weights, plus the other monitors, I mean, other parameters like the cardiovascular risk factors, the blood pressure, and hemoglobin A1C. So here's the result. We're talking about almost 16% reduction in BMI in semaglutide group versus a placebo. So the semaglutide improved the weight much better than the liraglutide, which is the Saxenda. So I'm sure the slide here is not very clear, but I'm sure I would like to show you this one, for example. You can see the difference between the semaglutide and the placebo. Almost 70% of children who were on semaglutide lost 5% of their weight, 60% lost 10% of their weight and more, and half of them lost around 15% of their or more, and 37% of them lost more than 20% of their weight. BMI by week, as you can see here, with time, there is more and more reduction in weight, in semaglutide group versus the placebo. And again, here we can see the same difference between the two groups on two arms. So this is the summary of the endpoints. In semaglutide group, using 2.4 milligram every week, the weight reduction in BMI, it's 16% versus only 0% in the placebo group. And you can see here that the percentage of children who lost 5%, almost 70% of them versus only 17% of placebo group. So just this is a summary of the same results we talked about. Also, it has more effect on lipid profile, on the blood pressure, and also a change in hemoglobin A1C as well. The side effects are almost the same like the liraglutide study. They have some GI problems, which usually resolving with time. So the conclusion here, the semaglutide using 2.4 milligram was superior to placebo in respect to percentage change in BMI and 5% weight reduction with a safe profile. Just briefly, if I have time, I would like to talk about a study we published recently in pediatric obesity, because as I told you, in our clinics, we don't have much to do with our kids with obesity. So we are trying in the clinic to find out what are the problems with our kids, why they are not responding to our instructions and suggestions. So this is a study we published. We looked at the obstacles facing our kids with obesity, and we came up with this conclusion as the title showed here. There is misalignment between kids, adolescents having obesity, and their caregivers and also their physicians. So it's a part, by the way, this is a study of action study, which is an international one. And this is the aim of the study to explore the barriers mainly to effective obesity care on an international scale among adolescents, caregivers, and healthcare providers. And this is the objectives from this study to look at the perception, attitudes, behaviors, and potential barriers to effective obesity care. So this is the steering committee, and there are 10 centers worldwide from Mexico, Colombia, Spain, UK, Italy, Turkey, Saudi Arabia, Australia, Taiwan, and South Korea. And we involved in this study adolescents between the age of 12 and 17 years. We included 5,000 plus adolescents, 5,000 plus caregivers, and 2,000 plus healthcare providers. And it was online questionnaires distributed for all subjects in this study. And here's the result. We look at the information sources, attitudes, and also the conversation about obesity. And this is what we found, that the majority of obese adolescents are taken care by healthcare providers, primary physicians, and not specialized. For example, we're talking about adolescents, only maybe 11% were followed by pediatric endocrinologists. The majority of them, they were followed by general GP physicians only. And when we looked at the professional experience of these physicians, we found only half of them, they have good training in obesity. The majority of them, they don't have even 1 or 2 days of training about obesity. This is what we found. Not only that, we looked at the information sources from where the caregivers and also the adults are taking their information about obesity, not from the physicians, actually from the YouTubes and other sources of social media. Also, we look at the attitudes, how they feel about their obesity, and we found only 70%, not all of them, they perceived their obesity as a bad disease and having impact on their health life. When we asked the caregivers, only 60% of them, they had this feeling. 40%, they didn't look at obesity as a major problem on overall health. And also, we looked at the degree of worry. We found only 40% or maybe worried about their obesity affecting their weight or affecting their future height. So their information about obesity is not that good. The attempts to lose weight, we found only 40% only trying to lose weight, not all of them.
1 minute.
Okay, so I'm almost finished. Regarding the barriers, also we look at the barriers. We ask the adolescents why they are not able to lose weight, they said hunger. They feel hungry, that's why they are not able to lose weight. But when we asked the physician about that, they talked about something totally different about this barrier. The conversation, very important before I conclude and stop here, we found that just half of the adolescents were told by their physician that they are overweight or they are obese. And after finishing the clinic conversations, 83% of the adolescents had a positive feeling about this conversation, and 33% they had a negative feeling about this conversation. So this is the summary. The minority of our physicians have good training about obesity. 70% of our adolescents perceived obesity that they have impact on their health. This is very important. And also 70% of the adolescents, only 70% felt positively about their conversation. So I would like to conclude here. This is the key points which we get from the study. The caregivers, number one, underestimated the impact of obesity. This is number one. The guidance provided by our physicians about weight loss is totally different about what the kids or adolescents feel about their obesity. So we concluded from that there is misalignment between patients, adolescents, physicians, and their caregivers. Thank you very much. I'm sorry for that.
Thank you, Prof. We would like to join us with Dr. Asim for the question. We will have 5 minutes of a question.
Thank you very much for excellent presentation. يعطيكم العافية جميعا. سؤال للبروف بالنسبة للهرمونال ثيرابي, how long the duration of treatment? And you said after 1 year there is some weight regain. What's the some weight regain?
Yeah, this is very good. Till now, because this is a new medication, liraglutide, semaglutide, new medications for us as pediatrician. So if you, I don't have an answer for that, for how long we should use these anti-obesity medication. But generally speaking, kids like adults who are obese, they are facing difficulty to lose weight. So we are trying just to help them to break this psychological impression about obesity. So we are trying just to help them to be good on exercise and changing their lifestyle. So I'm recommending, like in adults, recommending these anti-obesity medication for a while, for a short period of time, like 3 to 6 months only. And after that, after losing some weight, we are just, I think that the kids will feel that they are able to lose weight by themselves. Otherwise, they will continue on these medications forever. So I'm looking at these medications like in adults as a temporary medication only, not for life.
Okay, thank you.
I have one question for you, Dr. Prof. Did you have any cases that operated or you refer them for bariatric surgery, and what is the course and what is the prognosis after that?
Right, yes. We are following the same guidelines like in adult. Number one, we'll try with the lifestyle change, exercise and reducing weight. Some of them, we are suggesting for them ketogenic diet. And if it didn't help, and this is the protocol of our bariatric surgery in our hospital, if it didn't help, we'll go with medication. The problem at Kingfisher Specialist Hospital, we don't have these medications. So because we are at our hospital, we are trying not to open the doors for this primary, they call it a primary care disease, not a tertiary care disease in our hospital. So, but we are recommending these medications to be taken from outside our hospital. And after 6 months of a trial, if it didn't help, we usually are referring them to our pediatric surgery at Kingfisher Hospital, yes. And the surgery is very effective in lowering the weight. But again, it should be as a part of a complete program.
Thank you very much. Doctor, I want to ask about the age limit. we have an issue with the Ministry of Health that regard the new numbers, let's say it regard the age. Is it 12 and above? That's mean 13 and above. That's what you are considering as pediatric, because we know that worldwide it's 18 plus. It's not whatever below 18 is considered pediatric. So what you are following regard the number of the age that you are considered with the management?
We are following the FDA approval. The FDA approval above the age of 12 years. Before, the liraglutide, the Saxenda, was approved above the age of 12 years. And recently, we got the approval for semaglutide above the age of 12 years. So this is what we are doing. We are following the FDA guidelines.
Thank you.
Right.
Dr. Asim, regard that, do you have an accounted number for us here in Saudi Arabia, how much the cost for a diabetic patient with the treatment of the complication that you discuss and the things that will improve? Until today, they are thinking only the cost for diabetic patient is his medication. Right. But nobody take in consideration the consequences of this untreated diabetes and the complication of that.
Yeah, I agree with you. I have a presentation about burden of diabetes. I don't recall the numbers, but you are right. There's a direct effect, direct cost and indirect cost. It's very difficult to estimate the indirect cost of diabetes and its complications, but I'm sure it's huge. But there are several papers talking about the cost in Saudi Arabia, and I remember, I don't know what's the paper, but from here, from Saudi Arabia, by the Minister of Health, talking about the indirect cost as well. And there are several papers by Dr. Khalid Rabi'an talking about the same thing in adults, but in kids, I'm sure that we don't have it. Yeah.
You already answered.
Thank you. Prof, again, I will repeat the question which is said by my colleague. I'm a bariatric surgeon. The age group for bariatric surgery in childhood, this is a big issue for us in the MOH centers. Do you see those patients who operated, those kids who operated by the bariatric surgeon for morbid obesity? Our direct question, what is the effect on their body, gross, mental health? For sure, they differ from the adulthood group. In spite, the kingdom has the highest literature about those. Prof. Gahtani is a leader in this worldwide. But still, we have a limitation. Would you explore more this limitation impacted on what concerning those patients when operated at the age of 10, 11, 12, like that? We are weighing risk-benefit. A kid of a body mass index of 50, what's the quality of life he will have? On the other way around, if you operate on him, what is your comment on this level of surgery on this age group particularly?
Personally, I don't have an experience, but as you mentioned, Dr. Aid Al-Gahtani, every now and then he's lowering the age and the cutoff age for surgery. I was part of the obesity chair led by Dr. Al-Gahtani at King Khalid University Hospital, and now I don't have a cutoff age for bariatric surgery. Maybe as low as or as young as 6 years, he's taking these patients to surgery, and he showed in his several papers that it's very effective in improving the weight and its complications. So our bariatric surgery, bariatric and pediatric surgeons at King Faisal Hospital, like Dr. Ali Asiri, for example, he's operating on kids with a BMI above 40. As young as 6 and 7 years.
يعطيك العافية. Thanks, Dr. Thanks, Prof. Bassam, for the amazing talk. We know that we're expecting in the coming days to get the, to be available for the combined GLP and GIP-1 to be available in the market. Is there any data for using of the combined GLP and GIP in the pediatric population?
I'm not aware about this, but I don't know, our colleagues from other technology, maybe they are aware about that. Personally, I don't know.
Thanks.
Can we use it in pediatric, right?
Yeah, to be used in pediatric population.
He's now
I'm not aware. I didn't come across any study talking about that. Maybe there is, but I'm not aware of it. No.
Still, thank you so much.
Last question from me for Dr. Asim. What is the first step to overcome the therapeutic inertia from your from your talk or your search?
This is very excellent question. Therapeutic inertia. First thing, we have to identify the problem in our institute to know how many patients we have the A1C above 9 in our institute. We can just open the electronic vial in our system and see how many patients with A1C above 9 and see what is the last visit for this patient, what is the last management done for this patient, and if there is no recent visit within 6 months, if there is no change in management within 6 months, we have to bring those patients in our clinic and intensify the medication for them to do for them a legacy effect in the future if we can. This is what we are aiming for.
Okay, and identification is the first step. Yeah. Thank you, Prof. Thank you, Dr. Asim. We will go for the next session.
Next session, bariatric surgery in depth. We'll start with Dr. Ahmed Al-Ghamdi is around. It's not here, not yet. Okay, Dr. Assam Bataya, are you ready? Dr. Assam Bataya will speak about can diabetes be surgically cured? It's a very interesting topic. Please, Dr. Assam Bataya, he from Noor Hospital, Makkah Al-Mukarramah. He will present the case to us. Can we put Dr. Assam Bataya case? Dr. Assam Bataya is consultant bariatric surgery from Noor Hospital, Makkah Al-Mukarramah. We thank him for coming from Makkah, a long period to come to us, and we inshallah will get benefit from his lecture. Can diabetes be surgically cured? Thank you.
Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee. It's a great opportunity and honor to be among you today. I will just make it so brief, and with little back of some of the history, I will give some introduction, then I will talk about definition of the remission that it was mentioned many times by our colleague in the previous lectures. Then the metabolic surgery, and what about the procedure selection and which procedure that we should offer to our patient. The safety of bariatric surgery, and some little bit of the mechanism of the action. So going back to the history since almost 1991, when the NIH said, okay, bariatric surgery or metabolic, at that time it was still bariatric surgery, which is still until now for some reason or another. The indication was clear that BMI more than 40 or BMI more than 35 with comorbidity such as diabetes and hypertension. Since that time, this revolution of recommendation and a large new evidence have been grown. So, about the definition of the ADA regard the partial and the complete remission of type 2, you have to have 3 of these things. One, hemoglobin A1C below 6.5 or 6 respectively. Patient, he should be off all his diabetic medications and the maintenance of his glycemic control for at least 1 year. So according to this criteria, during my fellowship in 2013, me and my colleague, Dr. Ali Aminian and Hector Rimario, we start to think about the longer duration that it have been achieved in Cleveland Clinic at that time. Most of the study at that time, it was with the medium range up to 5 years, but it doesn't was reaching more than that. So we were honored to get our abstract and our result to be presented in the American College of Surgeons and in the, published in the Annal of Surgery in 2013 by our mentor, Dr. Stacy Brethauer. And from our conclusion, we found that 217 of our patients with the follow-up duration of more than or up to 6 years, the complete remission with hemoglobin A1C of 6%, it was in 24% of our patients. And the partial remission with hemoglobin A1C to 6.4, it was 26%. So we are talking about 50% of those 217 patients, they have almost complete to partial remission of their diabetes. From the other point, what about the improvement? The improvement, there was 34% of those patients, they have improvement in their hemoglobin A1C. But we, as we have an advantage, we have also some disadvantage and the issue with the recurrence. It was 19% only. So they start to think about the diabetic surgery summit, and among that, in 2016, which means 3 years later, 5 major diabetic organizations, the highest ranked organization with 48 multidisciplinary international scholars from 7 medical specialty, most of them non-surgical, so 60% of them non-surgical, with an evidence, and they get a conclusion. The aim of the summit was to summarize and to assist the leading of these diabetic organizations and to have the clinician, the benefit and the limitation of these metabolic surgeries. So since that time, in 2016, a new era. This era was started, and it was almost on the magazine of the first page and most of the literature and anywhere else. Why surgery is the next big thing. Surgery should be an option for diabetes, metabolic surgery for type 2 diabetes, and the challenges among that. I will not talk about the epidemiology. It was being already tackled and it's been spoken about, but the transformation from bariatric surgery to metabolic surgery. Thanks to our society here in Saudi Arabia for the Saudi Diabetic and Endocrine Association Society, because they were one of the pioneer and the first society that approve and endorse the consensus of the Diabetic Summit. So now we are talking about metabolic surgery. This is the treatment algorithm that the patient with type 2 diabetes, we have to categorize them. Are they non-obese or obese? The non-obese, yes, those patients, they will take him for conservative non-surgical management. Everybody agrees about that. But for the patient with the obese, we have 2 categories, and now we know the new standard and also the new recommendation with the BMI of 30 and above. So we have class 1, class 2, and class 3 obesity. From the class 1, those patients, we have to work together with our colleague, and this should be the multidisciplinary team. According to that, you can divide those patients who is good candidate and adequate glycemic control or inadequate. The one who is adequate, that's good. He is doing well, so we don't need anything further management. But who is not adequate, he should consider metabolic surgery. And this is the argument with our colleague and some of our colleagues. For class 2 and class 3, we know that class 3 is out of the discussion, no argument about them, but the class 2. We know that from most of the study of the clinical randomized trials, it was showing that reducing the weight, it's lowered the glycemic control, and with the comparison with the medical treatment, we can see it very clearly that it's in favor of surgery. Not only that, but we are talking about the time that's regard the lifestyle intervention and the range of more than that, 1 to 5 years. But we have to take in consideration, most of these randomized control trials, and also from our study which we did, there is 3 main factors that influence the result. The most important is the baseline duration of the diabetes. As long as this diabetes has been for longer time, their remission and their cure will be much more difficult, and they will have regain, and unfortunately. The other thing is the use of the insulin and how far their glycemic control. Most of our patients in our hospital, they've been referred from the pathology with hemoglobin A1C 10 plus. Yani imagine that their hemoglobin A1C is 10 and plus. So is it only glycemic control? Actually, it is not. It has been also talked about with our colleague that the enhancement of the quality of life, it's more with the reduction of the cardiovascular risk factor, microvascular and micro. Now the latest meeting will be about the International Federation, and the next meeting, they will talk about the cancer and the contribution of obesity on the cancer, and even decrease the death. So which procedure is the best? What we need to know from our procedure? We have a lot of variety. Every now and then there is a modality, there is something. But according to that and this procedure, there is no golden standard. But there is a comparison between the laparoscopic adjustable gastric band, the vertical sleeve, the Roux-en-Y, and the biliopancreatic diversion. From those studies and from this 11 randomized controlled trials, we can see the superiority and the best result outcome is mainly for the Roux-en-Y gastric bypass with the safest thing. It was up, let's say, to 2019, which means 3 years after the endorsement. But now there is a new changes, but we are waiting for the next summit so that we can say again what is this new procedure on the era. We can see clearly the Roux-en-Y gastric bypass, even after 1 year, up to 6 years, the result is much better. And the control of the hemoglobin A1C, even also the Roux-en-Y gastric bypass, it's to the 6. So it's the superior. It is too early and we cannot say what is the golden standard, but the priority, as I highlighted in the red lines, we know that the biliopancreatic diversion is number 1. But why we are not recommending it? Because we have a lot of issue with the comorbidity and the complication for such patient. One of the major issues we are suffering, and I think most of our surgeons, the follow-up of our patient, and they are not taking their multivitamins, they are not taking good care of their health. Roux-en-Y versus vertical sleeve, there is a lot of argument, and this is the new procedure that in the era, as discussed and mentioned by our colleague, it is more common used nowadays. What about the safety of bariatric surgery? The mortality of the bariatric surgery, 0.1 to 0.5. It is safer than cholecystectomy. Major complication? Yes, we had complication, and it's ranging 2 to 6%. But it's performed on skillful surgeon, it can be less than that. Nowadays, we have a lot of non-surgical options. And they start to think about intervention to treat diabetes, but non-surgical. Some are, let's say, minimal invasive surgery. Part of that, the gastric electrical stimulation, the duodenal and the gastroendoluminal barriers, and the duodenal mucosal resurfacing. This is the new thing that is already on the clinical trial, and they have been tried. So the first one, it's about decreasing the size of the stomach itself, and these are part of the procedure, but still it's not really genuine. The endo barrier, the next one, and some of those trials, and this device, it has been withdrawn from the market for a period of time due to the higher risk of the complication. And finally, the vagal stimulation devices. But now the new era with this, the endoscopic duodenal mucosal resurfacing. It is a new thing that it showed from the literature that it improved and decreased the hemoglobin A1C 1 to 1.5%, and even the scoring for those patients, and it is a new thing that it could help the patient. Is it dependent on the weight? It has been also mentioned by our colleague and many times. Usually, we see the effect before the change in the weight, and it is very fast. And until now, still, it's not that clear. But we know that the glucose hemostasis is improved dramatically. It's still inconsistent with the correlation between the amount of the weight loss and this changes. But it is there. How it's happening? It's been mentioned also regarding the GLP-1, the altered effect of the ingested nutrient, the anti-incretin and decretin, and also the modulation of intestinal cells, and even the change of the bile acid. Thank you.
A very interesting topic, but we'll keep questions after the remaining presentation. Now I'll present the pleasure to present Dr. Khalid from مستشفى الملك عبد العزيز في الطائف. Very interesting presentation. Late relapse of diabetes after bariatric surgery. Thank you, Dr. Khalid. خالد الشريف presentation please.
شفتها معاك.
دكتور خالد الشريف، عندك محاضرة دكتور خالد الشريف؟
على الجوجل درايف. So we'll talk about the late relapse of diabetes after bariatric surgery. The primary risk factor for type 2 diabetes is obesity, and 90% of all patients with type 2 diabetes are overweight or obese. The relative risk factor, the relative risk of diabetes increase approximately 40-fold as the BMI increase from less than 23 to 35. Virtually all morbid obese adults have measurable impaired glucose tolerance, and about 36% of individuals with impaired glucose tolerance will progress to type 2 diabetes within 10 years. Even in the preclinical state, the steady state plasma glucose concentration is statistically significant, correlated with the BMI. In obese patients, bariatric surgery is more effective in glycemic control than a medication. Diabetes remission after bariatric surgery is defined as hemoglobin A1C less than 6.5, fasting blood sugar less than 126, and being off diabetes medication. In recent meta-analysis of around 3,000 patients, bariatric surgery caused resolution of a clinical manifestation of type 2 diabetes in 82% of patients in the first 2 years after surgery, and 62 remained free of diabetes more than 2 years after surgery. Other studies have shown that type 2 diabetic patients also have fewer decrease in complication of life longer after bariatric surgery induce diabetes resolution. Glycemic control after sleeve gastrectomy in Taif Hospital, Kingdom, Saudi Arabia, in our hospital. In our hospital, we have study which included around 100 obese patients with type 2 patient following sleeve gastrectomy. They had highly statistically significant decrease in fasting blood glucose, random blood sugar, random blood glucose, and hemoglobin A1C level compared to their pre-operative level, as well as total cholesterol, triglyceride, low density lipoprotein during follow-up. Duration ranged from 3 to 6 months post-operatively. Who's candidate for metabolic surgery? Those when the BMI more than 40 or more than 35 with diabetic. Now more than 30 if not control. The choice of procedure, I think Dr. Assam talked about this. The best now raw in Y and mini bypass and now and sleeve gastrectomy. Choice of the procedure should be tailored to each patient individual, considering risk-benefit ratio. Several studies showed that patients who had raw and Y gastric bypass had greater weight loss, slightly high type 2 diabetes remission rate, less type 2 diabetes mellitus relapsed, and better long-term glycemic control compared with the sleeve gastrectomy. But the sleeve gastrectomy could be a valuable option to treat diabetes, especially in patients who had concern existing about the risk of operation that involve bowel diversion with good diabetic control, at least in the short to medium term, 1 to 3 years. Postoperative remission in type 2 diabetes is not only related to the weight loss, as it can totally clear within days after gastric bypass, before there is any significant weight. Underlying mechanism of bariatric surgery induced glycemic control may be the effect of gastrointestinal hormone, ghrelin and GLB, improved insulin sensitivity and beta cells function with associated regeneration or hyperplasia, intestinal glucogenesis, altered the gut motility, and increase circulating bile acid and alteration in the composition of bacteria flora. Positive predictor of postoperative diabetes remission include short duration of diabetes mellitus, a younger patient, a BMI, controversy exists. Several studies show that high BMI is usually associated with greater weight loss and hence higher remission rate. Others found that sober morbid obese BMI more than 50 to be negative predictor of diabetes remission, maybe due to severe insulin resistant and or greater destroyed beta cells mass. Lower value of fasting blood sugar and or hemoglobin A1C. Some studies showed that female gender to be positive predictor of diabetes remission. Unfortunately, despite the high rate of diabetes remission after bariatric surgery, some patients later suffer from relapsed. Late relapsed is defined as fasting blood sugar or hemoglobin and A1C hemoglobin A1C more than 6.5, or fasting blood sugar more than 26, or need for anti-diabetic medication. In large recent Swedish trial, including around 2,000 patients who showed complete remission after 2 years after surgery, Roux-en-Y and sleeve, were followed up to 9 years. The median around 5.9 years. The cumulative type 2 diabetes relapse rate was 20%. A large population based study in USA examined around 2,200 patients who experienced initial remission after Roux-en-Y. They found that 35% of the patients relapsed within 5 years of complete remission. Factors of relevance for relapse are large, extent similar to those influencing diabetes remission, mainly representing longer duration and higher severity of disease. Studies show that a longer duration of type 2 diabetes, higher preoperative hemoglobin A1C, less postoperative weight loss, being on multiple anti-diabetic agent, and insulin treatment prior to surgery are risk factor for type 2 diabetes relapse after initial remission. No significant correlation with the age, preoperative BMI, or surgical method was found. Despite relapse, patients show significant improvement in glycemic control, better lipid profile, reduction in the number of medication, the use of insulin, and blood pressure. Take home message. Metabolic surgery offers a powerful tool for remission of type 2 diabetes. Patients with obesity and type 2 diabetes should be prioritized for metabolic surgery at an early stage. Identify predictor of a remission and the risk factor for relapse should be used for clinical guidance to identify patients who will benefit the most from surgery. Late relapse should not be considered a failure, as patients who experience relapse of disease still show significant better glycemic control and improve the cardiovascular risk factor than preoperatively. Thank you very much.
Thank you, Dr. Khalid Sharif. We will just keep the question in the end of the session. There is one more presentation, then we'll take all the questions. Now we'll take the last presentation by Dr. Ala Mutlaq. The presentation is injectable medication and insulin. Thank you for presenting.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Thank you for having me today. I promise you I will finish inshallah within 10 to 12 minutes because I think all of you want to go. So let's start. So I'm going to talk about the injectable medication which mainly available in the market. Glucagon-like peptide receptor agonist, glucagon-dependent insulinotropic polypeptide and GLP-1 receptors, and finally the insulin. So as you know, there is several formulations available in the market under the glucagon-like peptide 1 receptor agonist, which is usually, or all this is formulation given as subcutaneously except semaglutide, which is available as oral and injection medication. I'm not going to talk about the mechanism of action as it's already mentioned by our colleagues. Now, what about the characteristic of the formulation? Difference from one formulation to another formulation in the same class. This different in the characteristic, which is about the size, the molecular size, structure, and duration of the action and the duration. So these differences lead to, or we can translate it to the using of this medication or the indication for specific patients or depending on the patients. So we can categorize it as short-acting medication, exenatide and exenatide. This medication or this short-acting formulation lowering the prandial glucose level, and they consider within the group as the lowest efficacy on the hemoglobin A1C, and also they have low efficacy in reduction of body weight. On the other hand, the long-acting formulation, dulaglutide, relaglutide, exenatide, and semaglutide, or this formulation is affecting both fasting blood glucose and prandial glucose, and this leading to the high efficacy of the medication regarding to the hemoglobin A1C and body weight. Now, regarding to the cardiovascular outcome, there is several clinical trial was conducted to evaluate the safety and efficacy of this group of medication, and the results show that the short-acting medication demonstrate the safety, but not reduce the rate of major adverse cardiovascular events, while the long-acting dulaglutide, relaglutide, and semaglutide, they show the benefit from using it to reduce the risk of adverse drug reaction or to reduce the cardiovascular adverse effect in established or patients with high risk. Also, the long-acting formulation demonstrate lowering of nephropathy side effect. So, due to this characteristic of this medication, they have a multiple points, or the ADA guideline recommended to be used in multiple points. Starting from if the patients have already or established acute coronary cardiac disease, or as alternative in case of patients with chronic kidney disease if he cannot tolerate the sodium glucose transportase inhibitor. Also, it is recommended to be used when we need to decrease the patient's or to control the blood glucose level if the patients have high hemoglobin A1C, and also to reduce the patient's weight. Now, all formulation can be used with all medication, metformin, sulfonylurea, insulin, but with dipeptidase 4 inhibitor contraindication or should not be used due to the similarity of mechanism of action. What about the adverse effect? As my colleague already mentioned, that the GI side effect, and the side effect can be covered or can be overcome by starting with the small doses and titrate until we reach the tolerable doses. Also, hypoglycemia. This group of medication known to have low risk of hypoglycemia, but when we combine it with the medication like insulin or sulfonylurea, we have to monitor the patients carefully. Regarding to the acute pancreatitis, this medication actually, there is some cases showed developing for acute pancreatitis, but there is no causal relationship between the using of this medication and causing of acute pancreatitis. So we need more study and further study to find what is the relationship. In general, for patients with the history of acute pancreatitis, we have to evaluate if the benefit to risk when we start this medication, but for patients with chronic pancreatitis, it is contraindication to start this group of medication. Also for long-acting GLP-1 receptor agonist, this is contraindication to be used with patients with a history of medullary thyroid carcinoma. Now we will moving to the next molecules, or this is the newly molecules in the market. It is has tirzepatide. This molecule actually has agonist activity at both glucose-dependent insulinotropic polypeptide and GLP-1 receptors. It is approved. It's once weekly subcutaneous injectable, approved by FDA to be used in type 2 diabetes. There is several studies or trial conducted to evaluate or to compare the using of tirzepatide with the different doses, 5 mg, 10 mg, and 15 mg with either placebo, semaglutide 1 mg, dulaglutide, insulin glargine, and also with the placebo in patients who already treated with the insulin glargine with or without metformin. And the results show that there is equal and in sometimes superior efficacy of using tirzepatide when compared with the other medication and with placebo in reduction of hemoglobin A1C and also in body weight. Regarding to the side effect, they compare the using of tirzepatide with dulaglutide 1.5 milligram and also with semaglutide 1 milligram. The side effect is the same regarding to the GI side effect, but we have to put in our mind with the high doses, 15 milligram, that the adverse effect leading to discontinuation of the medication was high. And also to put in our mind that the dulaglutide dose 1.5, semaglutide is 1 milligram. There is also a trial called Termont. They evaluate, it is the double-blind randomized controlled trial, including 2,539 adults with body mass index 30 or more, or of the participants 27 or more with at least one weight-related complication. They exclude the diabetes patients. The patients randomized to receive either 5 milligram, 10 milligram, and 15 milligram of tirzepatide or placebo for 72 weeks. And the study or the results showed that the percentage of reduction was high with all doses when they compared with the placebo. But still, until now, this medication not get the approval as to manage the obesity. Still, it is using for type 2 diabetes. For cardiovascular and chronic kidney disease is still under investigation. So it is recommended by AD guideline to be used in patients when we need to decrease the blood glucose level, if hemoglobin A1C more than 10, or also when we need to decrease the patient's weight. Now I'm going to move to insulin. As you know, insulin is the only medication can be used in type 1 diabetes. Also in type 2 diabetes, if the patients have extreme hemoglobin A1C or symptomatic hyperglycemia, and also in hospitalized patients. I'm going to move to the medication error, which reported in 2022 from MOH hospitals. So the most common insulin formulation was aspart, followed by glargine, I think because this is the most common used in our institutions. Then followed by regular insulin. And the most common error was done by during prescribing. I think, again, this due to the under-reporting from physician and nursing, because this is, in this case, the most reported by pharmacists. So, of course, they will capture the prescribing error. And most of the error, alhamdulillah, it's not reaching the patients. But I think when we understanding the type of insulin, we can prevent the happening of this error. So the type of insulin, as you know, basal insulin, background insulin with the different medication. MPH is considered as least ideal to be used due to less duration of action, and it's have different peak. While the insulin glargine 300 and degludec with a different diagnosis considered as a best formulation to be used due to no peak, and there is no peak and also longer duration. Regarding to the short-acting insulin, we have short-acting, rapid-acting, and ultra-rapid. And as you know, within the time or over the time, the improvement of pharmacokinetic for formulation of short-acting is improving. Now there is also a combination therapy used when we need to simplify the regimen for patients. There is a combination injectable therapy containing or including the fixed dual combination of basal insulin plus glucose-like peptide receptor agonist, insulin glargine plus lexinitide, and insulin degludec plus liraglutide. But we have to put in our mind when we choose if the patients have a cardiovascular effect, so we will use a formulation with the benefit for these patients, which is degludec plus liraglutide. So as you know, type 1 diabetes should be treated with basal bolus insulin injection and also subcutaneous insulin infusion. Now, just to simplify the managing of type 2 diabetes, it is preferred now to start managing of patients if they have high hemoglobin A1C more than 10 or hyperglycemic or catabolism symptoms, to start them with glucose-like peptide receptor agonist, or GIP, GLP-1 receptor agonist. And then if the patients not reach the target, then we can start with basal insulin. And when using it as and in the other hand, if the patient's already on the basal insulin, we have to start the GLP-1 receptor agonist or GIP-GLP-1 receptor before we starting to go to add the prandial insulin. If the patient is not reaching the target, then we can start prandial insulin with the largest meal, then additional prandial insulin, and full basal bolus insulin, which unfortunately this strategy not followed in our practice due to multiple factors. Or we can directly go to a combination of the therapy. Now, the combination of the basal insulin has a potent glucose-lowering agent because and less weight and hypoglycemia compared with intensified insulin regimen. I'm just to highlight when we use this insulin for elderly. Usually, the premixed insulin is not preferred to be used for them because they usually having 1 to 2 meals per day. So it is, and the hypoglycemic risk increased with using of premixed. It is preferred to use basal insulin without even prandial insulin. If the patient's already on the prandial insulin, we have to try to step down until we stop prandial insulin and start the other medication. For hospitalized patients, as you know, that the sliding scale, that the basal bolus correctional approach is preferred to treat patients in hospital setting. In case of critical care, that the continuous intravenous medication is considered as the best treatment. Now, as a conclusion, GLP-1 receptor agonist or GIP-GLP-1 receptor agonist preferred over insulin as a first injectable agents in patients with extreme hemoglobin A1C more than 10 or symptomatic hyperglycemia. They are recommended for many patients population, including high risk or established atherosclerotic cardiovascular disease or chronic kidney disease, and also for patients who need to avoid hypoglycemia and also who need to avoid weight gain or induce weight loss. And as you know, the role of insulin or the place of insulin when we treat the patients. Thank you.
Thank you, Doctor. Thank you for the presentation. It was the last presentation. Now, Wash will get some questions from the audience. If you can sit, Dr. Khalid Sharif and Dr. Isam Batiya. Any questions regarding the 3 presentations, please?
Thank you very much, Doctor. Nice presentation. My question regarding the dose is different from, because I'm a bariatric surgeon, we give the dose of hormonal therapy as a scaled dose. So we'll starting with some certain dose, then we'll double it. It depends on the response of the patient and also the type of hormonal therapy what we use. In diabetic patient, we will follow this principle, or there is fixed dose for those patients because you prefer to start GLP-1 for the patient before the insulin? Thank you.
It's the same, Doctor. We have to start with the small doses, titrate until the target dose, but the doses from to manage weight loss, managing the weight is different for medication approved for weight loss. The doses is different from the diabetes.
I'm not hearing well.
The dose, we have to titrate also for diabetic patients. But the doses or the target doses is different when we manage the patient for weight or when we manage him as for diabetes.
This is the final dose, but the starting dose.
Starting dose, we have to start with a small dose until we reach the dose.
Even the patient hemoglobin A1C uncontrolled and above 10, as you mentioned?
Yes, we're starting with a small dose to prevent the side effect. This is our aim, to prevent the side effect.
Okay, thank you very much.
Any other question?
يعطيكم العافية على السيشن الأخير هذا، الله يوفقكم يا رب. For bariatric surgeon دائما احنا تجينا مشكلة في الفوت issues في الفوت surgery. Most of our patients are obese and diabetic. So دائما أكون في doubt مع نفسي, do I send the patient for bariatric surgery because they need some gastric sleeve or they need bypass. Do I consider foot surgery first or send the patient for bariatric surgeon first? So what's your recommendation? Do we finish with the bariatric surgery first and then you refer the patient back to me to work on their feet? Because most of the case of failure in my cases in obese patients.
Thank you very much for this question. I consider the foot surgery like orthopedic surgery. We are receiving the patient, for example, for disc prolapse or for total knee replacement. First to operate him to decrease weight, then go back to the orthopedic or the foot surgeon. And I think the bariatric surgery, it will control the blood sugar better than the medication. And otherwise, the outcome of the foot surgery, if there is a sharked ankle or other complication of the diabetic, it will be the outcome, I think, better than this.
I agree totally with Dr. Khaled, but if you are referring the case, if there is a diabetic foot or infected foot, no, I think we should control the infection, and if there is vascular problem, we should be controlled. So your question is regarding cold cases. So exactly, I agreed with Dr. Khaled Sharif.
We just mentioned it when I was sitting beside you. The scenario that always we are seeing, it's better really to operate on them to decrease weight, then it will improve your next step and outcome from your side. Just the story to be heard by other colleague, the youngest boy that I have operated on him, he was referred from the orthopedic surgeon regard he has the vulgaris and his knee, he need both knee surgery to help him. But he was overweight in a way that almost his BMI, according to him, with his percentile is more than 95, and he's 10 years old. So when we operated on him and we did the sleeve for him, eventually he did not need really the surgery which was planned for him, and avoid the surgery for him. So this will help the patient and will help the outcome from your side. Even if you are planning to do a procedure for them, I think it would be great for a good result. So you will be happy and the patient will be more happier.
Is there any specific time to operate the patient from my side? Let's say if they do the bariatric surgery, do I wait like 3 months, 4 months, and then I proceed with my surgery? Because most of the patients, they came with a foot deformity. They are not able to walk. So that's why most of the time I decide to do the surgery and then send them, stabilize the foot, and then send them for bariatric surgery.
I would recommend minimum 3 months.
You need some results, as Dr. Hassam said. If you take him early, you will not get any benefits from the surgery. You need some weight reduction. Minimum 3 to 6 months to get a result. Other things, you don't want to keep the patient stressed of other surgeries. He needs analgesia from your operation. You need to be sure he's eating well, and he will recommend. This is my opinion. What do you think, Dr. Hassam? I think less than 3 months.
Yeah, because the 3 month almost you will lose 10 to 20% of his total body weight. So that's, I think, at least a reasonable time that you are okay in the correct track, and there is no consequences from our point of view regard you can proceed with any foot surgery that you would like to do.
A question to Dr. Hassam. We said that our operation can cause remission, complete remission of diabetes. So when a patient comes to your clinic and patient is diabetic, type 2 diabetic, and you decide for him gastric bypass or SADI or anything, and the patient is refusing, and other procedure, restrictive sleeve still is a restrictive procedure. We are not sure there is some rule of metabolism in it, but still is not approved 100%. And you think, and my question, if can you refuse operating patient in wrong procedure? Like you want to give metabolic surgery for the patient.
This is a common scenario we are facing on daily basis. Every day in the clinic,
when a patient came with a history of comorbidity and metabolic disease, his hemoglobin A1C, etc., and I am telling him, please, your best choice, number one, is Roux-en-Y gastric bypass. Due to the lack of the good repetition of Roux-en-Y gastric bypass, most of the patients, they afraid and they run away from Roux-en-Y gastric bypass. We try to convince them as much as possible. But by the end, at least I can let him to try to do the sleeve if he insisted to go for the sleeve. If there's no contraindication, especially about the GERD things. But otherwise, I proceed with him with the sleeve. And later on, he might benefit more with this and get the control. If he didn't, so that's when he will come back.
So this is why I'm mentioning this. I want the help of our colleague in diabetes and endocrine to push our patient to the proper procedure. You should choose the pressure before he come to us. Why? This is what we see in our hospital because we have obesity medicine, endocrine. They are well educated in our procedure. We have to spread this education to our patient so they will be convinced. He will come to Dr. Isam, please do for me bypass. This is excellent patient because you'll get good result. He knows what's the best procedure for him. Now our surgeon also pushing the patient to sleep. Unfortunately, some surgeons, not all of us. So we need to be highly educated by our endocrine, and we are working as a team. It is not only because we want to do the procedure, but we want to get the best result. Diabetes cure or remission is excellent, outcome for our patient. This is my point. Last question for Dr. Khan. You mentioned that there is relapse after remission, right? And this late relapse is related to weight regain in the study you mentioned, or related to the mechanism or pathophysiology of the procedure?
Actually, regarding the first question for sleeve for diabetic, I make a study in our hospital around 100 patients only operated sleeve gastrectomy. And I think now 10 patients sleeve for type 1 diabetic. But still, now the 100 patients only 2 years. So I don't know what will happen, but the decreased weight and the control blood sugar, it is good. They say still processing, yes.
So you are studying any GLP,
yes.
anything? So that study or just
no result. Hemoglobin A1C, fasting blood sugar, and the medication.
We did a study, but still not completed. We measured the GLP and all the GI peptide, 4 GI peptide. Still, we are under the process.
And regarding the another question, why the relapse? I don't know, because I think if the diabetic came, it not go. There is remission, but still we are.
But we see the relapse after a few years. Some patients still their weight is controlled, but like we do gastric bypass, complete remission. How we say remission? There is no hemoglobin A1C is controlled. Normal level. But after 2-3 years, still the patient, his weight is controlled, but still his GLB is increasing. His hemoglobin A1C is rising.
But I think predicting factor, duration of diabetic, the use of insulin, the pre-op BMI, and all this, I think.
Doctor, I don't have answer for this actually. I don't know.
I mentioned it clearly. It is in constant correlation. Until today, we don't have. Even though we tried on the animal studies, we were doing it on the rats, and we were even harvesting the pancreatic island to see what's happened in their pancreatic island, and we studied it on the electron microscope. But still, I cannot give you an answer, a final answer that what's really going on and why they have a remission, why they get again, despite if they are still good with the weight, but they get remission.
If you allow me, Dr. Abu Khater, I have a question. with now the era of tirzepatide, the Mounjaro, it's decreased the weight in the max dose by 22%. It is good to start patient. He need to bariatric metabolic surgery on Mounjaro and wait for the result, or push the patient on bariatric surgery.
According to the category of the obesity, and as we mentioned, what is his BMI, and is he class 1 or class 2, and what is his control of his hemoglobin A1C? Is it good, well controlled or not? Because this is a potential patient that, yes, he can avoid really to go for surgery if his BMI on class 1 obesity and he start to catch up with the good controlling. But if he's still with ungood control, I would recommend superiority of, as I mentioned here, that it should be considered. The meaning of it should be considered that we should talk to our patient to give them an open discussion and opportunity that he will think about it, and there is no harm at all. I totally agree with you that he can try this. If it's failed, then we can step up.
That mean will be the first step before a surgery, because it's a major surgery. Even
for class 1 obesity.
Okay, what about 2 and 3? Push for surgery.
For class 2 and 3, I think the superiority is for the surgeon.
So the problem for this medication, it is not available in most of the public hospital, and it is costed. And the patient, even it is not in Wasfati now, I think the Mounjaro.
We are talking about medication not reached Saudi Arabia yet, the Mounjaro. Only take up the approval from
But
Saudi.
we're already facing this في السكسندا وفي الأوزمبيك والأذر اللي هي medication. Unfortunately, يعني only on some governmental hospital under يعني very restriction بيعاملوها معاملة الأدوية البيولوجيكال. بنرفع الطلب للمريض بالاي دي بريبورت علشان تيجي باسمه بالمدة اللي أنت بتحطها. يعني لدي الدرجة. So it's really an obstacle and challenge to give it as the first option.
Okay, by this, any other question?
Thank you.
Very interesting discussion. Thank you for your attendance and to you bear with us the last group. Thank you very much. And by this we end our scientific of first day, presentation. Thank you very much. Thank you all.